So without wasting any time, I hand over mic to Dr. Harpreet Singh to start the proceedings.
Good morning, Dr. Neeraj. Thank you for inviting us in the Best of ASTRO session. So I think we have, just let me get the list out. Just give me a minute.
Hello, Dr. Harpreet.
Yeah. Just a minute.
So just change your mobile mode.
Like this?
Perfect, sir. Perfect.
Okay, thank you. So we would like to start the first session on the hematological malignancies on the first day of the first session of the second day. So the panel of the session coordinator is Dr. Manish Pandey, and I think the panel of experts are Dr. Amal Roy Chaudhary from Delhi. He is from Fortis Gurgaon. Dr. Chandra Kataria, who everybody knows, she's a head of department of radiation oncology in Medanta Hospital. Colonel Ashok Kumar, he's the head at R&R Center in Delhi, and Dr. Sharad Yadav from Lucknow. So the first lecture is going to be by Dr. Neha Lal from Varanasi, and she's going to speak about the PET guided treatment of early stage favorable Hodgkin lymphoma, final results of international randomized phase 3 trial HD16 by GHSG. Dr. Neha Lal is there?
Yes, sir, she is there.
Okay. She also has a second abstract of long-term outcomes for patients with limited stage follicular lymphoma and update of population-based study, which will be a second talk. So, Dr. Neha, you can start.
Thank you, sir. I'm unable to share my screen, the abstract.
No problem, ma'am. We will run your abstract from here. You can present it. You can start, ma'am.
Okay, thank you, sir. A very good morning to all the seniors and dear colleagues. The topic given to me is the PET-guided treatment in the early stage favorable Hodgkin's lymphoma. Final results of the international randomized phase 3 HD16 trial by the German Hodgkin study group. Next slide, please. Based on the earlier German Hodgkin's study group trial HD10, the standard of care in the early favorable Hodgkin's lymphoma is 2 cycles of the ABVD followed by 20 gray involved field radiotherapy. However, the PET-guided trials in the early favorable and unfavorable Hodgkin's lymphoma, such as RAPID and H10, resulted in controversial views. The prognostic value of interim PET in this context is still unclear. Next. In this study, early favorable Hodgkin's lymphoma, the majority of patients comprise of the classical Hodgkin's lymphoma of stage 1 and 2 without any risk factors such as large mediastinal mass, any extranodal disease, high value of erythrocyte sedimentation rates, or 3 or more areas were included. It was divided into 2 arms. The standard arm, which include 2 cycles of ABVD followed by an interim PET. Whether the patient had an PET positive or negative disease, irrespective of it, they received 20 gray of involved field RT. And in the PET guided arm, after the 2 cycle of ABVD, the patients who received radiotherapy were only those in which the interim PET was positive. And the other arm was kept on follow-up. The The total number of patients which was taken up for the study was 1,150 patients. They were recruited from November 2009 to December 2015. And the age group which were included was 18 to 75 years. And they were further randomized into 1:1 ratio of 575 in each arm. And after the further exclusion because of various reasons, mostly being the withdrawal of the consent or disease entity were not finally concluded with the help of the histology. And the PET arm, in the standard arm, the patient number was 501, and in the PET guided arm, it was 506. And out of that, there were negative patients in the standard arm was 353, and in the positive were 148. Further, these patients were excluded from the protocol population because of the withdrawal of the consent and any missing documentation or non-compliance. So finally, in the PET negative arm, in the standard arm, we had on the basis of the per protocol population was 328, and the PET positive was 136, and in the PET guided arm, the per protocol analysis negative was 300, and the positive was 188. Next slide, please. This table shows the patient characteristic, and all the characteristics was well stratified among the two groups. The median age was mostly of less than 60 years, and in the standard arm, the more than 60 years were only 10%, and in the PET guided arm 11. And the majority of patients comprised of the male patient, the female being 42 in the standard arm and 43 in the PET guided arm. And the majority of patients in both the arms were of stage 2A, which included 62 and 65, and the other stages 1A, 1B was 29 and 4% in standard arm, PET guided arm 26 and 4%. And the majority of patients were of ECOG status 0. And the histological subtypes, which I already mentioned, were majority comprised of the classical Hodgkin's lymphoma type, which was 91 in the standard arm, and in the PET guided arm 89. And the another subtype, which was much more commonly in the nodular lymphocyte predominant type, which was 9 in the standard arm and 11% in the PET guided arm. The author gave the two primary objectives. The first of all, can RT be omitted from standard combined medical therapy without relevant loss of tumor control in PET2 negative Hodgkin's lymphoma patients? And does a positive PET after 2 cycles of ABVD represent a risk factor for a PFS among patients treated with standard CMT? So first of all, we look at the first objective, progression and relapse in the PET negative patients. In the patient who received combined modality of treatment, the 328 patients, in comparison with the patient who received only chemotherapy. And if we see the type of the relapses, the majority of patients those patients who just received the chemotherapy, they had in-field relapse and any relapse outside the field also, which was much more common. It was 8.7% in the in-field relapse, and other was 9.7. However, in the combined modality of the group, it was 2.1 and 4.6%. Next slide, please. This slide shows the progression in the relapse in the PET negative patients. In the combined arm, the 5-year overall estimate was 93.4% of progression-free survival rate, and in the chemotherapy alone arm, it was 86.1%, and this was the log-rank P for this was 0.040. So this was not significant. Next slide. And the overall survival in the PET negative patients in the combined arm was 98.1%, and in the chemotherapy arm it was 98.4%. This was taken again for the 5-year. So the next slide. the second objective. So the primary objective, the first objective was whether RT can be omitted from a standard CMT was not achieved by the authors in terms of overall survival and progression-free survival. The other question which the author put forward in this was whether a positive PET after 2 cycles of ABVD represent a risk factor for progression-free survival among patients treated with standard combined medical therapy. Next slide.
Dr. Neha, you have 2 minutes.
Okay, sir. The progression and relapse in patients treated with PET negative patients, the progression and relapse in the PET negative patients, including early and the rate relapse was 4.8%, and in the PET positive patient it was 8.8%. Next slide, please. So in the PET negative patient, the 5-year estimate was 93.2%, and in the PET positive patient, it was only 88.4%. Next slide, please. The most important factor was the impact of the dual score, in which it was seen the patient who had dual score of 3 had a 5-year estimate of progression-free survival was 92.8%. However, the dual score 4 was 80.9%. Next slide. So the result of this conclusion was that in early stage fibrable Hodgkin's lymphoma, positive PET after 2 cycles of ABVD indicate a high risk for treatment failure, and particularly when a dual score 4 is used as a cutoff for positive patient. So the PET positive patient in the dual score of 4 was 5-year estimate was only 80.9%. Next slide. The summary of this study: the RT cannot be safely omitted from standard combined arm without a clinically relevant loss of tumor control in patients with negative PET after 2 cycles of ABVD. Significantly poorer progression-free survival in Hodgkin's lymphoma patients treated without RT, and there is no difference in the acute toxicity between patient receiving RT or not. Overall survival on a high level not impaired by omission of RT due to effective second-line treatment. A positive dual score of 4 after 2 cycles of ABVD is associated with significantly poorer PFS compared with a negative PET. Thank you.
Thank you, Dr. Neha. Now you can start with your second presentation.
Yes, sir. So please share this screen for the second presentation. Thank you. This study is the long-term outcome for patients with limited stage follicular lymphoma. This is an update of a population-based study. Next slide. In the earlier as we know, the follicular lymphoma is the most common indolent lymphoma and frequently present as advanced stage disease. For limited stage disease, chemotherapy alone is not curative, whereas radiotherapy alone is potentially curative. However, given the long natural history, mature follow-up is needed to accurately define the relapse risk. And in this updated study, they took the follow-up of 16.6 years. We previously had the reported outcome of 237 patients with limited stage follicular lymphoma treated with curative intent radiotherapy with a median follow-up of 7.3 years. Reducing RT fields to involved node with a margin of less than 5 centimeters did not compromise the outcomes. Next slide. The study objective of this study was to report an update on the outcome of limited stage follicular lymphoma treated with RT alone and to re-evaluate the long-term impact of involved node RT with margins less than and equal to 5 centimeters on relapse rates. The material and methods: the eligible patients which were previously identified from the British Columbia lymphoid cancer database, they were taken up of stage 1A to grade 1 to 3A, non-bulky follicular lymphoma diagnosed from 1986 to 2006, treated with curative intent RT alone. Minimum dose which was given was 20 gray. The dose ranged from 20 to 45 gray. And CT scans were done for staging and not PETs, not PETs. Next slide, please. In the earlier years, from 1986 to 1998, involved regional RT was given to such to patients, and it encompasses the involved lymph node plus a prophylactic RT to at least one adjacent uninvolved lymph node. And from 1998 onward, involved nodal RT of less than equal to 5 centimeter were added to gross tumor volume to form the planning target volume and to account for any physiological movement and interfraction setup variation. It was most similar to which we presently practice as an involved site RT. Next slide, please. But the survival time, date of diagnosis to date of event or censorship were included the freedom from progression, progression-free survival, disease-specific survival, and overall survival. And proper statistical tests such as Kaplan-Meier, log-rank tests, and Cox regression models were applied to such. The results out of the 237 patients with the median follow-up of 13.81 years, the patient characteristics were by and large equally distributed in both the groups of the regional and the involved site radiotherapy group, and majority comprised of the for the males it was 48% and 47% in the both the group, and majority comprised of the ECOG status 0, and the patient were mostly of grade 1 and 2 of 89 and 88% respectively, and stage 1A of were in the involved regional site 69% and involved site 85%, and 2A 31% and 15% respectively. Next slide. The nodal size were majority had less than 5 centimeter of in the involved RT group, involved regional RT group 69%, and involved site 79%, and more than 5% were 18% in the involved regional group, and involved site 21%. And there were many extranodal diseases patients were in the involved site group. The serum LDH level were normal in the 93% of the patient of the IRT group, and ISRT group 82%. Radiotherapy doses, the 30 gray in 10 fraction was given in the 35% of the IRT group, and 31% in the ISRT group, and 35 gray and in 20 fraction were given in 42% of the IRT group and 21% of the ISRT group. There were other patients also who received doses up to 45 gray and 20 to 45 gray also, which included 24% in the IRT group and 48% in the ISRT group. Next slide, please. So this graph shows the freedom from progression, which was the median follow-up of 13.1 years, and the 5-year freedom from progression was 5.8, and the 10-year freedom from progression was 49.0%, and 15-year was 43.3%. Next slide. Freedom from progression when compared with the ISRT and the involved regional radiotherapy. So after 10 years, the freedom from progression almost plateaus in such in cases of involved site radiotherapy group. Next slide. The progression-free survival in the 5-year was 61.4%, 10-year 39.3%, and the 15-year 27.9%. And similarly, the disease-specific survival, the 5-year was 92.2%, 10-year 84.7%, and 15-year was 79.3%.
You have 1 minute, Dr. Neha.
Okay. The overall survival for the 5-year was 86.5, 10-year 70.9, and 15-year 57.5%. Next slide. In the patient who were transformed into aggressive lymphoma, the majority of patients, 195 patients, did not transform, and the transform was 42 patients, which were transformed into aggressive lymphoma. And the overall survival in such patients was only 57%. And freedom from transformation of ISRT versus IRT, the 10-year freedom from survival for the involved regional was 80.3% and involved site was 82.9%. Next slide. This shows the univariate analysis of the freedom from progression, in which the p-value was significant when the patient where the male were having a inferior outcome. Next slide. And also the another important was nodal size. When it was more than 5 centimeter, it has an inferior outcome. Next slide. In the multivariate analysis of the final model of the freedom from progression, the male gender, stage 2, large mass, size, and elevated LDH were associated with inferior freedom from progression. Next slide, please. So this shows the multivariate analysis, also the age, the lymph node size, where of poorer progression from survival, age, lymph node size, and serum LDH level were of disease-specific survival, and overall survival age was a specific factor in which the age more than 60 years were having inferior survival. Next slide. Timing and site of relapse, the majority of the patient who relapsed were of the distant relapse, which was 71 in the IRRT group and 36 in the ISRT group, whereas the infield relapse was only 2 in both the group, comprising of 1.4% and 2.1%. Next slide. Conclusion: in patients with limited state follicular lymphoma, disease recurrence was uncommon after 10 years and rare after 15 years. And at 15 years, 43% of the patient remained disease-free, confirming that a cure is possible with RT alone. The reduction of RT fields to ISRT did not appear to impact relapse risk in the long term. Thank you.
I would like to call on the next speaker, Dr. Samsi Arora from Jalandhar. She will be speaking on radiotherapy in early stage gastric mold, improved survival without increased cardiac death. Dr. Samsi, she's there?
Dr. Samsi?
Yeah.
Please unmute yourself.
Dr. Samsi, your voice is not audible.
She might have to rejoin.
Yeah, let her rejoin so we can
So go to the next speaker. Yeah. So while Dr. Samsi is rejoining, we can ask Dr. Divya Mahajan from Faridkot. She can take up a topic, the abstract number 4, which is a radiotherapy adequate treatment for is radiotherapy adequate treatment for patients not in complete metabolic response after first line chemotherapy for DLBCL? Dr. Divya.
Hello.
Yeah.
Yes, sir.
You can start your screen.
Sir, I'm not able to share my screen.
We will share your PPT.
Yes, sir.
You can start, Dr. Divya.
Good morning, everyone. Today, my topic for presentation is radiotherapy adequate treatment for patient not in complete metabolic remission after first-line chemotherapy for diffuse large B-cell lymphoma. This abstract was London. Next slide, please. Hello. The aim of first-line treatment for diffuse large B-cell lymphoma is to achieve complete remission, defined as complete metabolic response on PET-CT as recommended by Lugano classification. Persistent metabolic activity on PET-CT at completion of first-line chemotherapy in diffuse large B-cell lymphoma is associated with the presence of residual disease and worse prognosis. Fit patient may be offered salvage high-dose chemotherapy if residual disease is confirmed. For less fit patient, there is no standard treatment. Radiotherapy is an effective treatment for diffuse large B-cell lymphoma with high control. Authors hypothesized that RT was adequate treatment for subset of the patient not in complete metabolic response after initial chemotherapy. The aim of the study were to evaluate the outcome of the patient with diffuse large B-cell lymphoma with incomplete metabolic response with individual score of 4 to 5 after first-line chemotherapy who underwent RT to the site of persistent activity. And second aim was to perform an exploratory analysis of the factors that will predict the outcome. Material and methods were, this was the single-center retrospective analysis of the patient treated from January 2010 to April 2019. Inclusion criteria were more than 18 years old, histological diagnosis of diffuse large B-cell lymphoma, patient who received first-line chemotherapy that is rituximab based, individual score of 4 or 5 on the end of chemotherapy PET-CT scan. Radical RT dose more than 30 gray with a conventional fractionation regime of 1.8 to 2 gray per fraction. Of relapse, progression-free survival, overall survival, post PET-CT response. Progression-free survival and overall survival calculated using Kaplan-Meier method. Analysis of predictive factor for relapse performance using Fisher exact test and chi-square test. Result of the study, which was conducted between January 2010 to April 2019, including 47 patients who have received RT and having met the eligibility criteria, were published. Patient and disease characteristics are sex, male and female sex ratio was taken with male 48.9 and female 51.1, age with a median age of 62, stage was stage 2 with percentage of 46.8. International prognostic index mostly was in 0 to 1 with a percentage of 38.3. And histopathological factors were taken. That was germinal center was most common histopathology which was studied with a percentage of 38.3, and other was non-germinal center not otherwise specified. PMBL, that is mediastinal B-cell lymphoma, HRLBCL. Chemotherapy regimes, that is the treatment regime details which were taken are chemotherapy regime, R-CHOP, R-mini-CHOP, R-CVP, Arcodox M. The most common use was R-CHOP, followed by the other regimes. Number of cycles which were planned was 6. Radiotherapy doses most commonly used were 30 to 30.6. Other was 36 gray and 40 gray. All initial sites were taken and initial bulky sites were also included with percentage 24.5%. This is the slide representing the PRT Dinwell score and metabolic response category. The most common Dinwell score was Dinwell score of 4, and partial metabolic response was seen most commonly with a total response rate of 80.9%, and with Dinwell score of 5, the response rate was 19.1%. 13 out of 47 patients, no response or progression was seen. This slide represents the fate of the patient after RT with a median follow-up of 31.7 months. This showed that 29.8 patients have relapsed and progressed. Median time for completion of RT to relapse was 4 months. Out of the 14 patients who relapsed, 11 have died, 10 lymphoma, and 1 of the myocardial infarction. Pattern of relapse. Most common relapse was seen in out of the field, that is 64.3, and 21.4 was seen in and out of the relapse, and 14.3 only was seen in field. Local control rate was 89.4%. Progression-free survival, 2-year progression-free survival was 74.1%, and overall survival was 79.4%. PET-CT response. This showed the fate of the PET-CT response post-RT with a Deneuve score of 4. There was decrease from Deneuve score 4 to Deneuve score 3. And in the patient with Deneuve score of 5, there was varied response in the post-RT Deneuve score. 54.5% of the patients achieved complete metabolic response. Fate of the patient not in complete metabolic RT. This showed that with the patient in Deneuve score 1 to 3, 12.5% with relapse, and most of the relapse was seen in Deneuve score of 5, that is 90%. Only one patient with Deneuve score of 4 was biopsied, which showed the persistent disease confirmation. Rest of the patient were analyzed by interval scan or clinical surveillance. Factors which
please wind up it.
Factors which predict relapse are PRT Deneuve score and pre-RT response. This showed that most of the relapse was seen in the Deneuve score of 5. This is also showing that post-RT Deneuve score 5 was most important predictive factor of the relapse with significant p-value. RT, which when was given to all the positive site, had all the sites was showing less number of relapse as was given only to the positive site. So when we include all the sites in RT, there was less number of relapses which was seen. So in conclusion, radiotherapy is adequate treatment for patient not achieving complete metabolic response after chemotherapy, and may be avoided for these patients may be avoided for intensive salvage chemotherapy. Radiotherapy produced excellent local control. Relapse occurred early. Deneuve score 5 post-RT is a strong predictive of relapse rate. Take-home message: RT as a salvage option for the patient not in complete metabolic response after rituximab-based chemotherapy, covering all sites. And Deneuve score 5 more than RT was recommended for risk of relapse. Thank you.
Thank you, Dr. Divya. You can go to your next lecture, which is the abstract 5, patterns of failure following chimeric antigen receptor T cell therapy.
Yes, sir.
And you will have 7 minutes.
Good morning, everyone. Today, my topic for presentation is pattern of relapse in chimeric T cell therapy. Most of the patients continue to develop disease progression following chimeric antigen receptor T cell therapy, that is ERT. Most research has focused on systemic mechanism of tumor escape. That was CD19 antigen loss, T cell exhaustion, and immunosuppression. The goal of the abstract, which has been presented, is describe recurrent pattern of following CRT relapse, identify potential risk factor associated with local treatment failure. Method. Retrospective material and methods include retrospectively reviewed 53 consecutive patients treated with CAR therapy to identify the patient with disease progression. Patient level characteristic data, patient disease characteristic, previous treatment and toxicities were prospectively calculated per institutional protocol. Compared pre-treatment PET-CT to imaging at the time of treatment failure. Statistical analysis. Analysis were performed at the level of the patient and the disease site. Disease-free survival, overall survival were estimated using Kaplan-Meier method and long rank comparison. Various analytic methods
This is voice drop.
Dr. Divya Mahajan? Ma'am, can you hear me?
She has left, I think. Yeah, she has left.
How many slides are left? Just go slow, just go slow.
Sir?
Yes,
So
yes.
Dr. Divya Mahajan is reconnecting in 2 minutes. So can we start the next abstract presentation?
Dr. Harpreet, you are not audible.
The next, Dr. Samsi, is she ready or she's not ready? Is it?
She's ready, I think. Yeah, she's ready.
So then we can take her presentation. That is the radiotherapy in early stage gastric mold, improved survival without increased cardiac death. Dr. Samsi is from Jalandhar.
Dr. Samsi?
Dr. Samsi, you can start, and you will have 7 minutes for that. She is there or?
She's there, but her network is very low, so her voice is
Hello?
not coming.
Yeah, acha, okay.
Hello?
Okay, yes, yeah, she's starting.
Am I audible?
Yeah, you are audible.
Dr. Samsi?
Not audible now, yeah.
Hello?
Yes. Yes, you can start, Dr. Samsi. We are waiting.
Sir, she's
Sir,
Dr. Divya.
Dr. Divya here,
Acha, okay,
sir.
Dr. Divya, okay.
So, Dr. Divya, sir, I want to start my presentation again.
Okay, okay. The card sorry, okay. You can start again.
So, slides. So, my slides are not like,
Yeah,
I'm
we
not
are
able
running.
to share my slides.
Yeah, they'll be running it, yeah.
Yeah, we are running again.
Yes. So the patient characteristics which were taken were male, that were 88%. Other characteristic was diffuse large B-cell lymphoma, that histology, that is 85%. Prior auto HCT, that was 15%, and disease work mostly was nodal was taken. And pre-treatment site 6 were taken. Next slide. This This is the graph showing disease-free survival in the patient who progressed on the CAR-T. 3-month disease-free survival was 34%, whereas 6-month disease-free survival was only 3.8%. Next slide. Result. Patient level analysis were nearly all patients, 96% have had progression as component of the treatment failure. 1 patient had distant only progression and 13 had local plus distant progression, and 12 patient, that is 46%, had local only progression. This is the slide showing pre-CAR-T treatment, that is the disease was present. 30 days post CAR-T treatment, that was there is significant reduction in the disease bulk, and after 3 months post CAR-T there is relapse is seen in this PET-CT. The disease site analysis characteristic of all the pre-treatment lesions are location, nodal versus extranodal, size, metabolic volume, metabolic activity, that is standard uptake value, cluster of the disease, that is matid node, and presence of the necrosis. This is the diagram showing the disease bulk, which is bilateral axillary lymph node are there. This is the site showing the necrotic pattern of the disease. In this, disease sites were analyzed. Total 243 pre-treatment sites in 26 patients were analyzed based on the PET-CT. Complete metabolic response was seen in 37.4, partial in 14.4, and stable disease in 0.8, and progressive was seen in 47.3. Various analysis was formed. Univariate analysis, in this the main factors, that is cluster, cross-sectional metabolic volume with significant and SUV value more than 10 were the most significant, statistically significant p-value. Other factor, necrotic and location, were not having any statistical significance. This G multivariate analysis was also taken. In this also factors taken were SUV, location, and maximum diameter, and with not statistically significant value, p-value. This is the diagram showing the CAR-T workflow. Identify CAR-T patient early. Then T-cell apheresis is done. Following 3 to 4 weeks, chemotherapy conditioning and 5-day CAR-T infusion is done. Meanwhile, during this phase of the T-cell apheresis and chemotherapy, there is a relapse. There is a time period of 3 to 4 weeks. In order to prevent progression of the disease during this phase of the cycle, we give we give RT. This is known as bridging RT. This is entire flowchart is known as Moffitt experience. Prior to CAR therapy, this is the disease bulk prior to CAR therapy. This is the bridging radiotherapy during which we do target GTV and target volume delineation, following which the chemotherapy condition and CAR therapy infusion is done. Pre-CAR, and this is the figure showing pre-CAR volume, disease bulk, and 3-month post-CAR, which has shown significant reduction in the disease bulk. This is a paper which represent radiation therapy as a bridging strategy for CAR T-cell therapy with axi-cell in diffuse large B-cell lymphoma, which was published in International Radiation Journal, Journal of Radiation Oncology and Biology. The question which have arisen are in RT are optimal sequence, optimal dose, and fractionation and potential synergy, which are yet to be evaluated by the study. Limitations of the study were selection bias, and do this principle apply as CAR advances to earlier stages? And third is, do this principle apply to CAR in solid tumors? Conclusion: majority of the CAR patients will develop progressive disease and tend to relapse early, involving at least one pre-treatment disease site. Potential improvement of CAR outcomes with addition of the local treatment such as involved site RT to high-risk patient sites are large hypermetabolic, clustered, and necrotic. Radiotherapy has been shown to be a safe bridging strategy. Thank you.
Thank you, Dr. Divya. So can we proceed with Dr. Samsi, or we want to start with Dr. Savita? I think we can go ahead with Dr. Savita. She's Savita Sharma. She's from Faridkot, and she'll be talking about the abstract number 6, which is the quality of life improvement following low-dose total skin electron beam therapy in patients with mycosis fungoides or Sézary syndrome. Dr. Divya, you have 7 minutes. Oh, I'm sorry,
Hello.
Dr. Savita. Dr. Savita, you have 7 minutes.
Hello,
Yeah.
I'm audible.
Yeah, you can.
Yes,
you are audible. Audible.
Is the screen is visible?
Yes, it is visible, but your
Hello?
slides are not visible. Your slides are not visible. Your screen is visible. Yeah, now it is visible.
Hello.
Yeah, now it is visible.
So can you? Okay. So good morning, everyone. My topic for discussion is quality of life improvement and clinical impact of maintenance treatment following low dose total skin electron beam in a patient with mycosis fungoides or Sézary syndrome. The T-cell lymphoma, they consist of 75% of cutaneous lymphoma with a median survival of more than 10 years, and if the node is positive, it's less than 2 years, and if the metastasis is present, it's less than 1 year. And this is the image showing the treatment with the 6 dual field Stanford technique. This is the image showing mycosis fungoides patient with the large cell transformation present with the CD30 positivity before and after 8 weeks of 12-period total skin electron beam therapy, with the overall recovery rate is 87 to 96%, cure rate 18 to 35%, and the advantages are it's repetitive and with the less duration of treatment with the less adverse event. No quality of life analysis to date, short-term remission. We hypothesize that low-dose total skin electron beam has the potential to improve health-related quality of life for mycosis fungoides or Sézary syndrome patients. We examined the impact of maintenance treatment after total skin electron beam on the outcome. Materials and methods: 48 radiation courses over year 2011 to 2018 with a median age 68 years and 60% are of which males, and 40 patients are of mycosis fungoides, and with 8 patients are of Sézary syndrome. 16 patients presented in stage 1B and 15 patients presented in stage 2, and 4 presented in stage 3 and 13 presented in of Sézary mycosis fungoides underwent maintenance treatment, and the 4 underwent maintenance treatment in Sézary syndrome patients. The median total skin electron beam dose was 12 gray, with the median fraction dose was 1.5 gray, and the hemoglobin levels was 12.7, with the lymphocyte count 1248, with CD4 is to 8 ratio 2.4. The overall recovery rate was 8.
I think we have lost a voice.
8% with cure rate 33%. Is it audible?
Yeah, it's audible now.
Dermatological life quality index and Skindex 29 questionnaire with a functional assessment of cancer therapy general questionnaire, where the emotional domain, social domain, physical domain, and functional domain has been analyzed. This is the graph representing dermatological life of quality of life index, where the SW80 score improved from 44 to 1. The Skindex 29 score, the overall response for 10-point pruritus was 84%. A trend towards subjective improvement, where the emotional domain has significant p-value of 0.03, followed by social domain, followed by physical domain, followed by functioning domain. The therapy administered after low-dose total skin electron beam was given topical steroids, Bexarotene, systemic chemotherapy, systemic steroid, PUA therapy, interferon, ECP, and the novel agents like zenulumab, brentuximab, and vorinostat, 0.01. The conclusion was total skin electron beam of mycosis fungoides or Sézary syndrome has improved disease symptom and emotional domain of the patient quality of life. The maintenance therapy for total skin electron beam may improve the performance-free survival, and the future studies are warranted to assess the efficacy of total skin electron beam in a combination with maintenance therapy to enhance the clinical benefits. Thank you.
Thank you, Dr. Savita, for completing in time. So you can start your next presentation, which is the accelerated fractionated compared to conventional fractionated salvage radiotherapy improves the outcome in salvage chemotherapy refractory diffuse large B-cell lymphoma.
Thank you, sir. My next topic for discussion is accelerated fractionation radiation therapy improves the outcome in salvage chemotherapy refractory diffuse large B-cell lymphoma. So patients that were found to have salvage chemotherapy refractory diffuse large B-cell lymphoma are thought to have a universally poor prognosis, and we have observed the salvage chemotherapy refractory diffuse large B-cell lymphoma continue to progress with once daily radiation therapy. So we reviewed individual patient data assessing the efficacy of two different salvage radiation therapy fractionation schedules, that is with conventional fractionation 36 grain 20 daily fraction over 4 weeks period, accelerated fractionation with 36 grain in 20 twice daily fraction over 2 weeks period. The table is showing the patient characteristic where all the patients were refractory to salvage chemotherapy. Patients were either primary refractory to chemotherapy as well as to the salvage chemotherapy, or refractory to salvage chemotherapy in the relapse setting. 23 patients had progressed disease and 15 patients had no response or partial response at conclusion of salvage chemotherapy. The 22 patients underwent accelerated salvage radiotherapy and 16 patients underwent daily salvage radiotherapy. This is the table showing analysis of the response of salvage radiation therapy. You can see the overall response survival rate at 2 years is 70% for those that achieve a cure rate to salvage radiation therapy compared to 36% for those that didn't. Response to salvage radiation therapy, the accelerated fractionated salvage radiotherapy is associated with improved cure rate compared to conventional fractionated salvage radiotherapy when seen in the PET images. The outcome for the local regional control is better in accelerated salvage radiotherapy compared to the conventional salvage radiotherapy. The overall survival has no associated improvement in overall survival rate associated with the salvage radiotherapy. High dose chemotherapy and autologous stem cell transplantation. 22 patients underwent high dose chemotherapy and autologous stem cell transplantation. Among the patients who underwent accelerated salvage radiotherapy, 13 completed autologous stem cell transplantation compared to 8 patients who underwent conventionally fractionated salvage radiotherapy. The high dose chemotherapy and autologous stem cell transplantation was associated with improved 2-year overall survival rate. Among the patients that underwent high-dose chemotherapy and autologous stem cell transplantation, accelerated salvage radiotherapy was associated with improved 2-year disease-free rate. However, the difference in the 2-year overall survival rate was not statistically significant. Accelerated radiotherapy was associated with improved cure rate and disease-free rate. And with accelerated salvage radiotherapy, the pattern of failure shifted from predominantly local to distant failure. The patient had a cure rate to salvage radiotherapy and underwent autologous stem cell transplantation appeared to have improved overall survival. Contrary to common belief, patients refractory to salvage chemotherapy can achieve a high rate of sustained survival with curative intent treatment. Thank you.
Thank you, Dr. Savita. The abstract left is of Dr. Samsi. So if we can have that. Early stage gastric mold.
Yeah, she has joined on other device. Dr. Samsi, can you hear us? Dr. Samsi? Dr. Samsi, can you hear us?
I think there is some audio issues.
Yeah, I think she has some audio issues with her device. Dr. Samsi?
If not possible, we can discuss her
We can
presentation.
start the discussion, yeah. I think we can start the discussion if it is not, if she is having issues. Dr. Manish will now take over as a session coordinator and take over the discussion aspect. Dr. Manish Pandey, please.
Thank you, sir. Thank you. And thank you, Dr. Neeraj, for giving this opportunity to coordinate this important session. This session was dedicated to discuss the...
You can run through the slides of whatever left and then you can start.
Yeah, we will discuss it, Dr. Neeraj, during presentation, don't worry. The session was dedicated to discuss the modern radiotherapy techniques for the lymphoma patients and current trends in systemic treatment and how radiation modalities can help lymphoma patients. So, can I request to run the slides, please? Yeah, this is and I welcome all my experts for this session, Dr. Tejinder Kataria, Dr. Amal Rai Chaudhary, Dr. Ashok Kumar, and Dr. Sarath Singh. And to make the discussion good and beneficial for all, we have made the comments on each abstract and we'll discuss in limitation to that to save the time. The first presentation was about the PET-guided treatment of early stage favorable lymphoma, and we can say despite overall past several decades, PET-CT emerged as critical to accurate staging and designing the treatment strategies of lymphoma to decide the adequate treatment and establish the state-of-art imaging and key role in decision of treatment. But the optimal use of PET-CT have critical issues. Risk-adopted strategies appear to improve the clinical outcome in lymphoma patient. This abstract was subjected to this and we find there is no concrete evidence in this study and in literature to omit the radiation even in early favorable Hodgkin's lymphoma. Patients in whom radiotherapy was omitted had poor progression-free survival, especially in patients with PET-positive residual disease and reverse score was more than 5. The results of HD10 trial holds true and is still the standard of care in lymphoma patient. May I request Dr. Tejinder Kataria, Madam, to please give her expert comment, and if any question from anyone, they can ask. Madam, please.
Good morning, everyone. Thank you, Dr. Manish, and thank you, Dr. Neeraj. So we've seen the study showed that the patients, although in early stage, also in early favorable classical Hodgkin's lymphoma, continue to fail, which is very, very unlikely. This when we were in residency, we learned that the Hodgkin's lymphoma, especially classical Hodgkin's lymphoma, early stage is a curable disease. So you cannot omit radiation from the treatment. And if we look at the studies from UK, BCRG 1 and 2, when 2 cycles of ABVD versus 4 cycles of ABVD versus no radiation versus radiation, in both these was given, it was found that the best results were there when the radiation was 1/2 the arms in these cases. And the patient's survival is more than 90%. So it doesn't behold true that the patient should be not given a treatment which is curative for them. And especially if the imaging has come in, and we have had a board of articles which have been published both in the Red Journal as well as in the Journal of Cancer Oncology, JCO, and the patients who did show response on the PET and there was positive residual disease, if you omit the radiation, they will continue to fail. And then the salvage chemotherapy or salvage bone marrow transplant does not give you the same results as would radiation upfront as an added treatment in the primary presentation. And in 2015, I was in Heidelberg, where they were participating in the trial which has been presented today, and they had already started seeing the early failures. So they've moved on, and the new trial was started where radiation dose is being varied between 20, 25, and 30 gray, and we'll probably get to see the results in the next 5 years, because it's already 5 years and now the accrual would be complete. Thank you so much.
What about the patient who have complete response and even PET-CT is negative, means favorable disease of group? What about your suggestion or recommendation for that group?
So for that patient, the studies have shown that if you give 20 gray, if there is a complete response, 20 gray of radiation is curable for them, and if there is residual disease, then 30 gray, between 25 to 30 gray is the dose which we give for Hodgkin's lymphoma, which cures these patients. So these studies have already been published, and we cannot negate them and continue to accept the new studies and then let the radiation not be a part of the treatment of such patients who are showing a PET response.
Thank you, ma'am. So can we move to the next abstract? And it was the second abstract was long-term outcomes for patient with limited stage follicular lymphoma. Despite fact that most follicular lymphomas are advanced at the time of diagnosis, many patients may not require treatment for prolonged time. Median survival is almost 8 to 10 years historically. And nowadays, evidences are in favor of use of radiotherapy or at the time of diagnosis or for limited stage lymphomas. Although still it is variable and is to evaluate the role of radiotherapy and chemotherapy. This is our comments about this abstract. This is an updated study with a very long follow-up. Nearly 40 to 45% of the patients are disease-free and without any toxicity at the end of even 15 years. Role of radiation has validated in follicular lymphoma over chemotherapy. The volume of radiation does not impact the outcome, and it is a question mark whether we should give ISRT or IRRT. May I request Dr. Amal Chaudhary to make a comment and try to answer this question or last point. Dr. Amal?
Yeah. So, am I audible, Dr. Manish?
Yes, you're audible.
So, I would like to point out two things in this study. The take-home message from this study, which I get it, is if you look at the multivariate analysis on DFS, PFS, and freedom from failure, freedom from progression, the take-home from all the variables is the only thing common I found was that wherever they were completely excised and then an RT was administered, that had a significance value. Although less than 5 centimeter and more than 5 centimeter, if you look at, complete excision did not make much difference in the disease-free survival or progression-free survival when radiation was added. So core biopsy, what is complete excision? That is one that I could take a message that outcomes were better. Number two, the outcomes at the end of the final analysis. Initial presentation, a paper was published in Cancer Journal in 2010 of the same authors. Now, they have not mentioned about International Prognostic Index in this. With that, if they would have published the results, probably we could have a better idea. Nevertheless, 15 years follow-up is a very long follow-up, and the failure rates which were seen was only 3% after 15 years. If we look at the data were low, intermediate, and high data. The 5-year and 10-year 5 survival, overall survival for low grade is 91% and for high grade is 52%. In this study, the S already is in that range, although it has been not segregated in that fashion. So I think radiation therapy definitely scores over chemotherapy, because the data which I told you regarding 5-year OS for low grade to high grade range, that has not discriminated. There is no data as such where only chemotherapy has been given and only radiation therapy. There is no arms comparison. But looking at this paper and the data which is data from other studies, I think radiation alone is giving good survival in 50% of the patients. So old thought process was there that, okay, 60-year elderly patient, there is a 5 centimeter, it is not growing very rapidly, you can still watch. I think it is time to change our thought process and bring in radiation early in the treatment.
Yes, completely agree with you, Dr. Amal, and thank you for your expert comment. Now we move to the third abstract, which was presented as radiotherapy and early stage gastric mild lymphoma. The stomach is a very frequent site of extranodal lymphoma. It is
Dr. Manish, this was not presented.
So this is supposed to, this is considered to be presented, and we will discuss it. This is a low-grade lymphoma and B-cell malignancy. Association of H. pylori is very well established, and radiotherapy has an emerging role. Organ preservation, as well as with the without any long-term complication of surgeries as it was previously done. It used with anti-pyloric therapy make it more effective treatment. Although role of immunotherapy in form of rituximab and vascular endothelial growth factor as target therapy in coming up the mild lymphoma, radiotherapy is still a good option for treatment. And comment about this abstract 3 is, this is a too long study period. Multiple changes in treatment regimen has occurred, especially for the radiation techniques. Newer radiation techniques are very well capable of reducing the toxicities. Too many patients are having unknown, I think, too many patients are having very much unknown treatment that is not a reliable thing, and no significant increase in cardiac death due to radiation when compared with orbital mild radiotherapy. And significance of cardiac death has shown while comparing unknown treatment versus RT at the end of 10 and 15 years. Not justified. Unknown treatment arm have some patient with RT treatment. May I request Dr. Ashok to make a comment here? Dr. Ashok?
Sir,
Yes, sir.
thank you very much, sir. You have made my comments very easy, because you have summarized the entire study in 5 lines. But I'd like to add that this study, obviously this was a very long study from 2014, 21 year period is quite a long period. And that time, wherever we treat gastric maltomas, part of the heart do come in the field. So to avoid these things, DIBH techniques and IGRT techniques is very much useful. Regarding this study, obviously it has also shown that there is no significant risk of death or cardiac related death, and comparing it with orbital myeloma and those cards, obviously it is not justified. What I'd like to mention is that a large number of patients whose treatment schedules was not
So we will go ahead with the fourth abstract, which was is radiotherapy adequate treatment for patient not in complete metabolic response after first-line chemotherapy for DLBCL? As all of know, benefit of radiotherapy in limited stage disease is very much controversial, but randomized trials have established the role of radiotherapy in patient not achieving complete response after chemotherapy and basis of PET-CT evaluation. About this study, we have our comments in form of 45% of the patient belong to stage 3 and 4 on the both side of the diaphragm, and all sites of relapse were treated in 55% patient, but it is not clear how many of them were stage 3 or stage 4, and stage 3 or 4 if treated with all sites lead us back to radiation area of the previous lymphoma era with mental or inverted white field, but it is not clearly mentioned. And the response evaluation in the PET-CT score predicting the relapse indicator for further treatment, and toxicity details are not mentioned in this study. So I request Dr. Sharad Singh to make comment about this study. Dr. Sharad.
Thank you, Manish boss. You have made all the things very clear as Dr. Ashok has mentioned. I think the only thing which you have left a bit tedious in your life was your marriage invitation card, which was in Sanskrit. So I think it is a very good example of a study which picks up retrospective data and tries to stretch the benefits further by addition of radiation, by a good usage of radiation combined with the help of functional imaging. This was although a retrospective study, but it has shown very clearly that radiotherapy is definitely an adequate treatment, and many patients had good remission at 2 years. And if we if we do the functional imaging consistently, and if we find a high Dovell score, it can predict those cases which are not going to respond very well. Otherwise, this shows that if the functional imaging is very good, and as we all know that if the residual volume is less than 2 centimeter, and if all the index sites were covered properly in the radiotherapy volumes, the response is going to be very good. So, of course, this needs further evaluation and further trials. Thank you.
Thank you, Dr. Sharad. Next presentation, please. It is this abstract is a new thing for us, combining radiotherapy with this chimeric antigen receptor T cell, which is this is a type of treatment in which patient T cells are changed into the laboratory and it will kill the cancer cells. The success rate is 30 to 40%, and the treatment for certain type of non-Hodgkin's lymphoma with certainly have side effect. About this study, nearly all patients on CART develop progressive disease. Need to identify patient for this type of therapy in our context to tolerate and afford this treatment is a very big challenge in our country. And radiotherapy has always enrolled giving response evaluation in chemotherapy resistance lymphoma. We have discussed in the previous abstracts also. And response to CART also depends on the risk factors like matted mass, presence of necrosis, SUV uptake, and area of disease. So cost benefit should be assessed versus the response. Madam is working in a very advanced and state-of-art radiotherapy center where all facilities are available. We don't have any experience of such type of treatment. May I request Dr. Tejinder Kataria to make a comment on this?
Thank you, Dr. Pandey. So when I was given this task to go through the CAR-T cell therapy for diffuse large B-cell lymphoma, especially when there is refractory disease to chemotherapy, and what is the role for radiation, I reached out to our hemato-oncologist. We are not yet offering the CAR-T cell therapy at Medanta, and we have a protocol where the patients who respond to chemotherapy, they go on to receive the bone marrow transplant. But if the patient has primarily has a high risk of developing the disease refractoriness to chemotherapy, then we discuss about the radiation, but then it becomes palliative. And to the large bulky sites, if there is residual SUV uptake of dual score 4 or 5, we take up these patients for radiation upfront. And then they do not go on to the salvage chemotherapy, because if we take them up after salvage chemotherapy, the second line or the third line, then the responses are poor. And in addition to this abstract, I would also like to go back to the abstract 7, which was presented in the morning session, where they have shown that if you give an accelerated radiation of 1.5 gray twice a day, they've shown better responses. So I think that is the way to go forward, because we understand that diffuse large B-cell lymphomas, especially if the volume of the disease is large and the stage is advanced, and especially if the SUV value is more than 10, then these patients will continue to proliferate very rapidly. They are so proliferative. If we go back to our first year of residency, then we find that the leukemias and the lymphomas in this stage, they have a doubling time of less than 24 hours. So maybe an accelerated radiation and a dose which has been prescribed by the Moffitt Cancer Center, where they've suggested that we should have a kind of a bridging therapy, is something that needs to be explored. Instead of waiting for the patients with post-CART, because then the disease is anyway refractory to both the radiation and to the chemotherapy and the CAR-T already. So the salvage may not work, radiation may not work, then it will be just pain palliation. If we have to bring in radiation in the diffuse large B-cell lymphomas with addition to chemotherapy, so maybe it needs to come as a bridging therapy. So these are my comments, Dr. Kami.
Thank you, ma'am. And Dr. Harpreet has unmuted himself to say that we have to stop the session.
Just stop the session because of the time.
Sir, we are going to take 2 minutes only, 1 minute for each abstract. And thank you very much, Dr. Kataria. And thank you very much, Dr. JP Agrawal also. He informed that there is no center practicing CORD in our country. If Medanta and TMS is not doing, no can. So the next abstract was on TZ, and it is the effective treatment of primary cutaneous T-cell lymphoma we all practice, and low-dose therapy has been used to decrease the complication in comparison to conventional therapy. About this abstract, we have made comments in form of a good innovative study to address the quality of life aspect, which is very important in patient with mycosis fungoides, which is very important in the patient, and the major improvement in emotional and social domains, which feel the patient to complete the treatment. As a result, approximately 80-85% were able to take maintenance therapy, and significant difference noted in patient who take maintenance therapy. This is very important issue because all of us know in mycosis fungoides, due to high dose, lot of patients are not able to complete the treatment or not able to take maintenance therapy. May I request Dr. Amal to make a short comment on this abstract.
Thank you, Manish. Manish made our job much more easier by having a crux of the whole presentation. I'd just like to add that it is to endure the total skin electron therapy is difficult. This is a general perception on the patient's behalf. Studies have been there. So counseling has to be done regarding the side effects during the treatment, so as to make it more in early stages, as you mentioned, that so I think that's it. Time is short. I don't need to add anything more to what you have in addition to what you have shown.
Thank you, Dr. Amal, for taking care of the time limit. And then for the last abstract, and this is most fascinating abstract, which involved comment and discussion from all radiation oncologists. This is because this is the area where every radiation oncologist want to involve and want to play with the fractionation schedule. This study was about the fractionation schedule in the lymphoma, and the study defining role of radiation in DLBCL even after the refractory to chemotherapy. Accelerated radiation therapy has been used with success in squamous cell carcinoma of the head and neck cancer with improvement in locoregional control, as Madam told her in comments. Same has been represented in this study, but radiation detail, technique and volume has not been mentioned, as more than 50% patient was stage 3 and 4. toxicity profile has been mentioned in this study, which is a very common fact for accelerated fractionation, and BD not same for the both treatment schedule, which is a very important finding in this study. May I request Dr. Kataria, and after that, may I request Dr. Sarad and Dr. Ashok to make a comment, and after it we'll finish the session. Madam Kataria, please.
Yes, so my only comment is, that they have treated all sites prior to the, disease with radiation. So the only issue which we may face in such a situation is, especially when we're giving accelerated fractionation, is that these patients may have very poor bone marrow reserves post chemotherapy. So that's a challenge which we as radiation oncologists will have to see what happens to these cases. So this is my comment.
Ma'am raised a very important issue which has not been discussed in detail. And Dr. Ashok, please.
So this ma'am's point is very much valid, firstly. Secondly, despite the challenges in giving twice daily fractionation, this looks promising in terms of decreasing the overall treatment time from 4 weeks to 2 weeks. Apart from this, we have to closely monitor the patient. Regarding the study, obviously, most of the data has been redacted, and toxicity profile and radiation details has not been given. And lastly, point of biological equivalent dose, obviously that they are not same, but as we have seen in the head and neck, it has got a beneficial value for giving twice daily fractionation.
Dr. Sharad, please.
I have a query rather than a comment, and to Madam Kataria, that is it not tantalizing to, given the modern amenities we have for radiotherapy, to increase the dose and through this technique, ma'am? Do we have any?
Dr. Sharad, biologically this would be a superior dose because you reduce the time. If you're giving 30 gray over 2 weeks versus 30 gray over 4 weeks, this is already an escalated and an accelerated dose protocol. So going to a dose beyond 36 to 40 gray for any lymphoma doesn't help, because then we start hitting the toxicity ranges rather than the clinical benefit, and the normal tissue complications go up. We have very good techniques that if we can get the bone marrow sparing radiation, and which is possible with the current techniques, then I think that is where meticulous planning needs to come in. So you need to map out the whole marrow and then keep the doses to such low volumes, maybe less than 5 gray during the whole, or maybe less than 2 gray. I don't know, because there are no studies. So this is very tantalizing, as you said, and it's very challenging also. So I think we look forward to having these younger generation come up with the trials and then show us, because you have all the equipment. So why not?
Thank you very much, and thank you all experts for making my job. And thank you, Dr. Harpreet Singh, as a chairperson, to allow us to give an extra time for discussion. Dr. Harpreet, please.
I think it was overall a very well discussed topic. With the definitely being that we have a role of radiation in lymphomas, and maybe in the coming time we'll have some for leukemias also. But in addition to the prophylactic cranial radiation that we give in future, there are definitely studies coming up, and we will be having some areas, maybe like we saw from Hodgkin's to follicular lymphoma to DLBCL, whether salvage or whatever. So overall, the indications for radiation are there in lymphomas. So I think we have a bright future, and I think the future generation, as mentioned, they will continue with the good work, and maybe we'll be having more data in the coming years. Thank you, Dr. Neeraj and the team, for inviting us. And I think we wind up the session here and get the mic back to the organizers.
Thank you, Dr. Neeraj. Thank you, Manish Boss. Thank you, ma'am.
Thank you, sir. Thank you, everybody. Thank you, Doctor.
Thank you, everyone. Thank you, everyone. And now we quickly move on to second session on lung cancer. And chairperson for this session is Dr. Ramesh Billimaka. And he needs no introduction, and he is very senior radiation oncologist and ex-president of AROI, and presently practicing at Bangalore. And coordinator for this session is Dr. Jyotirup Goswami from West Bengal. And I ask Dr. Ramesh Billimaka to take over.
Good morning, everybody. Thank you, Dr. Neeraj. And we will start the 8th session for Best of ASTRO. and that happens to be on the lungs. And we have been allocated 60 minutes for this session, and we are now at almost 10:25, and we will go ahead and with our presentations. We have in this an expert panels, and I hope all the panelists are present. Dr. Aman, present. Dr. Kuldeep.
Yes, sir, present. I'm there, sir.
JP, Pradeep.
I'm Dr. Preeti, sir. It's not Pradeep.
Oh. No, Preeti is there. Preeti Jain is there. Pradeep Garg.
Okay.
And Manish Bansal. So these are experts, and they are present. And we have we have a 6 abstract, and we have 1 coordinator. We will start with in the first presentation. As all of you know, the lung cancer is one of the increasing cancer in India. But unfortunately, into the radiotherapy department, not many lung cancer patients are coming and for the treatment. It needs quite a good lot of interdisciplinary approach and to make the role of radiotherapy felt and among our referring consultants. There are good 6 abstracts. Can I start with the first one? The first presenter is Poonam Sehar from Faridkot. Are you ready? Dr. Poonam?
Hello.
Yes. Dr. Poonam, are you ready?
Yes, sir. Yes, sir.
Yeah. Okay. Please
Am I
go
audible?
your first presentation, and you have 7 minutes to go. Please go.
Yes. Hello. Am I audible?
Yes.
Yes, you are.
Yes, yes.
For my topic for the presentation is phase 3 trial prophylactic cranial irradiation with or without hippocampal avoidance for small cell carcinoma. In this, the prophylactic cranial irradiation is the standard treatment of the limited stage of the small cell lung carcinoma patients who responded to the treatment. But in case of extensive stage disease patients, it is recommended in selected patients who responded very well to the chemotherapy. And according to the standard dose for the prophylactic cranial irradiation, according to RTOG 0212, that is 25 grade 10 sections. 62% neurocognitive toxicity were reported, and 68% relative increase in the probability of the HVLT. In case of neurotoxicity concern on the part of patient, the oncologist appears to be major impending preventing patients for receiving PCI. The patient beneficial effects of the PCI in case of hippocampus avoidance in limited state. Small cell carcinoma, lung cancers, the patient develops the metastasis in case of underdose lesion. In case of small cell lung carcinoma, limited disease extensive without brain metastasis, candidates for the prophylactic cranial irradiation after response of the chemotherapy and chemoradiation. The age should be less than or equal to 18 years. CAMSPK index is more than or equal to 80%. Negative brain MRI with 1 month of the enrollment. And the standard dose for the PCI is 25 grade 10 sections, and the in case of with the hippocampus avoidance is also the same 25 grade 10 sections. The hippocampal contouring. In case of contouring atlas, according to the RTOG 0933. 33, it's a PTV, IMRT and VMRT. There is a optimal and acceptable doses were given, and in case of hippocampus, the optimum, that is, the optimum is less or equal to 16, and in acceptable it is less than or equal to 17. For the endpoints for the primary to evaluate the effect of prophylactic cranial irradiation with the hippocampal avoidance on neurocognitive functions at 3 months after the end of the treatment relative to control the arm receiving standard PCI. The secondary is to look for the quality of the life after the PCI hippocampus avoidance versus the standard PCI. Early and late adverse effects. and the incidence and location of the brain metastasis after the PCI with the hippocampal avoidance versus the standard PCI. Overall survival and the hippocampus structural changes. In case of yeah.
Purnima, your voice is not clear.
No. In case of hello.
Yeah, it's okay.
Hello, am I audible?
Yeah.
Yes, you are.
Primary endpoint free and selective reminding test. The FC-STR measures the verbal learning and the memory, including the encoding, retrieval, and the retention of the new information over time. Alternative versions are used to alternate the practice of the effective. 5 derived scores were considered: the trial 1 free recall, the total free recall, total recall, a delayed free recall, and the delayed total recall. To compare the scores on the cognitive test, the raw scores are converted to standard scores based upon the published normative data adjusted to the deceased age, education, gender when applicable. And the difference of the FCRS biased, that is a failure if less than or equal to 3, successful if it's less than 3, and the expected difference is 50%. That is 75% per arm, 80. Power.
I think Poonam, you will have to adjust your mic, please.
Hello?
You will have to adjust your mic. You are not audible.
Results for hello.
Yeah. Okay.
Results patient characteristics according to the standard PCI or PCI with the hippocampus avoidance. The mean age, the comparison of the both the two arms are non-significant. And the mean dose for the hippocampus is 21.46, that is a plus 6.1, and 10.9, that is a 2. That is both are non-significant. Total recall and the delayed free recall after the cranial irradiation. The comparison of the two in case.
Again, no, your voice is not heard at all. At least, can you put the last summary slide?
Dr. Poonam sir?
Hello?
Yeah, okay. I think she has lost her the mic. She has lost. We have seen the last conclusion. I think with that, we'll go ahead. Poonam, the second case is also from her. Are you ready to present the second one? No, I think her voice.
Dr. Poonam sir?
Hello?
Ma'am, are you ready to present your next abstract?
We'll do one thing. We will go to the third one, and when the just at the background, you please check whether Poonam is ready, and then we will come back. Whether Dr. Surya, are you ready?
Hello.
if Dr. Suri is ready, we'll go ahead with him, and Poonam can come back later when her mic is okay.
Hello, Hanji. Good morning. Am I audible?
Who is it? Oh, yes. Yes, you are audible.
Suri.
Yeah, yes, Suri, please.
Could I get the slides presented on the screen?
Yes.
Yes, go ahead. Poonam, you'll have to stop sharing your slide. Let Suri present.
The slides.
Can somebody from the admin help? Yeah.
Hello?
Yeah, but this is again, came back to the first one only.
So can I start?
No, but you come back to the first one.
So I'm Dr. Osheen Suri. Can I start?
Yeah, please. Go ahead.
Slides have disappeared from the screen. Yeah, it's visible now.
Okay.
Okay. Good morning, everyone. My abstract for discussion today is the incidence and location of brain metastasis following hippocampus avoidance, prophylactic cranial irradiation compared with the standard PCI in small cell lung cancer, a phase 3 trial, MCT 01780675. Next slide. Next. Yeah, it's a randomized phase 3 trial which was based on the hypothesis that the hippocampus sparing PCI will decrease the neurocognitive deterioration as compared to the standard PCI. It had the primary endpoint and the secondary endpoint. The primary endpoint was intended to treat the analysis Hopkins Verbal Learning Test revised score at 4 months. The difference in the HBLTR is binarized. It was considered as a success if it was less than 5. However, it was considered as a failure if it was more than or equal to 5. The expected difference was 30% and 50 patients per arm were necessary to have sufficient power. The secondary endpoints were other cognitive outcomes, intracranial relapse, overall survival, quality of life, biomarkers, abnormalities on MRI. Next slide. Yeah, the two arms which were randomized were the arm A included the standard PCI and arm B was hippocampal avoidance PCI. The dose prescribed was 25 brain 10 fractions and the neurocognitive test battery was done at baseline and at 4, 8, 12 and 18 and 24 months. Also, the MRI was done at baseline 4 months and 1 year. The interim and the final analysis in the hippocampal avoidance PCI trial in small cell lung cancer. One interim analysis was done in 2017, could have stopped for efficacy. The DSMB also looked at the safety for brain metastasis. The analysis primary hypothesis needs to be tested at 0.049 with the p-value which was derived from the Fisher test. Now this is sagittal section showing the hippocampal avoidance PCI technique. In this you can see the red area outlines the hippocampus and the green area it outlines the hippocampal avoidance zone in both the images. Now the various treatment planning constraints for hippocampal avoidance PCI for VMAT IMRT tomotherapy with the dose prescription of 25 gray in 10 fractions. The V115% to PTV was less than or equal to 1%. The D1% PTV was preferably less than 110%. The Dmax PTV was less than or equal to 115%. The mean maximal dose to the hippocampus was less than or equal to 8.5 gray. The mean maximal biological dose to the hippocampus alpha by beta or 2 gray was less than or equal 1.1 grade. The hippocampal avoidance PCI with the randomized phase 3 trial had inclusion period from 2013 to 2018 and 168 patients were randomized in this trial. The baseline characteristics included with the age of 64 mean in the PCI arm, and in the hippocampal avoidance PCI arm also the mean age was 64. 46% of the patients were male in PCI arm and 48% in the hippocampal avoidance PCI arm. The tumor stage 1 to 3 was included approximately 80% in the PCI arm while 79% in hippocampal avoidance PCI arm. The performance score 0 to 1% was 95% in PCI arm and 96% in hippocampal avoidance PCI arm. The performance score 2 was 5% in the PCI arm and 4% in the hippocampal avoidance PCI arm. The endpoint neurocognition was based on the HVLTR score at the 4 to 8 months. In both the treatment arms, the total recall score of the HVLTR dropped at 4 months. The Kaplan-Meier was drawn and the secondary endpoint to assess the overall survival was assessed in both the PCI and hippocampal avoidance PCI arm. It was slightly more in case of the hippocampal avoidance PCI arm as compared to the PCI standard alone arm with the no significant p-value. The incidence of brain metastasis was also seen to be more in case of the PCI standard arm as compared to the hippocampal avoidance PCI arm. However, the p-value was 0.88. Now, this is an image showing the multiple brain metastases which you can see in their outline outside of the hippocampal avoidance zone. The another sagittal section showing the blue one highlighted area with the hippocampus and multiple brain mets which are seen outside the hippocampal avoidance zone. Now in this sagittal and coronal section you can see one metastasis located in the hippocampal area while the another one is located outside the hippocampus. Now this is an image showing the SRS which has been planned for the two metastases which were found in the patient, one in the hippocampus and another outside the hippocampal avoidance area. Now coming to the conclusion of this, the hippocampal avoidance PCI trial, the incidence of brain metastasis. The cumulative incidence of brain metastasis at 2 years is 18% for the PCI arm and 16% for the hippocampal avoidance PCI arm. No significant difference was seen between the arms and no isolated brain metastasis was seen in the hippocampus or hippocampal avoidance zone. Thank you.
Yeah, that's good. Are you, Dr. Surya, are you ready with the next one also, the fourth paper?
Sir, I'm ready. I need to get the slides presented just.
Yeah. Go ahead with the second, the fourth. Yeah, stop.
Our next topic is accelerated hypofractionated chemoradiotherapy followed by SABR boost for locally advanced unresectable. Yeah, it's not visible. Prospective phase 2. The limited advances were seen prior to the Pacific trial for unresectable stage 2-3 non-small cell lung cancer in the last decade. From the 1980s to the 2000s, the trials conducted like CAL-GB8433, the single agent chemotherapy was compared with the double agent as seen with the etoposide cisplatin in the SWOG 9019 trial. The induction versus induction and sequential chemoradiotherapy was seen compared in the RTOG 9410 trial, based on which it was established that the concurrent platinum doublet concomitant chemoradiotherapy was to be given as the standard of care with the dose of 60 to 63 gray. From the 2008, previous slide. From the 2008 to 14 to 15 to 16, the maintenance durvalumab in the Pacific study. Next. The hypothesis and rationale for this was the medically inoperable stage 2 and 3 non-small cell lung cancer was included. The local control was still 50 to 60% and the survival was poor prior to the Pacific trial. The dose escalation beyond 70 gray with protracted approach is detrimental in the randomized cooperative phase 3 setting. The hypothesis behind this was applying the technical advances of SABR with hypofractionation. It had a thoughtful margin design, reduced toxicity, improved outcomes, and the shortened treatment course. Now the study schema behind this hypofractionated chemoradiotherapy followed by SABR boost. The patients were enrolled who were biopsy-proven stage 2 to 3 with no history of prior radiotherapy. The simulation was done and the patient was prescribed with the dose of 4 gray in 10 fractions boost, followed by which at the 8th or 9th fraction resimulation was done and the dose escalation cohort was given like 5 gray in 5 fractions boost or 6 gray in 5 fractions or 7 gray in 5 fractions. The majority of the patients, like 64%, were of the adenocarcinoma variety, while 36% were of squamous cell carcinoma, and the median follow-up was 16.9 months. The normal tissue sparing strategy with the DVH goals as the dose prescribed to the PTV, the V100% was 95%. The mean dose to the esophagus was less than 34 gray and it was achieved as 14.14 gray. V75 gray for trachea and bronchial tree less than or equal to 10 ml achieved was 0. The mean dose to the heart less than or equal to 30 gray. The total lung PTV1 V20 less than 40%, mean dose less than or equal to 20 gray. Skin V75 less than or equal to 5 ml, spinal cord maximal dose less than or equal to 40 gray. Brachial plexus V65 gray less than or equal to 5 ml. Now the various patient and treatment characteristics were included based on the low, intermediate and high dose cohort. The median age was approximately 70 gray in all of these, with the majority being the male gender and the KPS median was 80. The adenocarcinoma variety included 64% as a total, with the 36% in the squamous cell carcinoma. The majority of the patients in the total category belong to the stage 3A and 3B, with the median follow-up being the highest in case of the intermediate cohort. The total dose was 65 gray, 70 and 75 gray in the low, intermediate and high cohort respectively, and the number of fractions given were 15. The consolidative treatment was 20 with paclitaxel was 21%, while with the durvalumab was 4%. Now this is an image showing the patient with the stage 3 adenocarcinoma left upper lobe lung. Initially the patient is given 4 gray in 10 fractions with the PTV margin of 5 mm. And you can see the PET-CT response after 40 gray, for which patient is provided with the SABR boost with the 6 gray in 5 fractions to the IGTV only. Now the dosimetry gains with the PET adaptive SABR boost was seen in case of the adaptive plan sum as compared to the initial plan, with the dose comparing as seen in case of the lung, the esophagus and to the bronchus. This is an image showing the response assessment with the initial hypofractionated followed by the boost in case of the patient after the boost therapy. Now we have a Kaplan-Meier curves to compare the local control, progression-free survival and the overall survival. Next. The disease control was as compared of the low dose cohort was compared with the intermediate and high dose cohort. The local control was more in case of the intermediate and high dose cohort as compared to the low dose boost. And the progression-free survival was initially more in case of the low dose boost, however later on it was more or less similar with no significance. The overall survival was seen to be more in case of the intermediate or high dose boost cohort.
One more minute to conclude.
Okay. Coming to the summary, the local control was seen to be more in case of the intermediate and high dose cohort. The median progression-free survival was more in intermediate as compared to the low dose cohort, and the median overall survival was more in case of the intermediate and high dose cohort. Now this is the bar graph showing the acute toxicities. It was seen that in case of the low dose boost, the grade 1 and grade 2 toxicities were more. However, the grade 3, 4 and 5 were more with the high dose boost. The late toxicities were grade 1 and grade 2 with the low boost. However, with the grade 3 and 4, 5, the high toxicity was seen with the high dose boost. The various serious treatment-related adverse effects, the acute being with the less than 90 days post-RT were pulmonary toxicity, radiation, dermatitis and sepsis. The late ones including the pulmonary toxicity, esophageal stenosis, stricture and sepsis.
Can you come to the summary slide, please?
Yes, just the last one. Now coming to discussion, to our knowledge, this trial utilizes one of the most aggressive hypofractionation regimens studied in SABR boost with the various treatment planning and IGRT strategies. The specified maximum tolerated dose was not reached. However, the patients who were treated with 70 gray in 15 fractions had the most favorable outcomes. Overall safety profile, efficacy and convenience for this regimen appears promising. Further improved outcomes may be achievable utilizing this regimen as the backbone in combination with the novel drugs and immunotherapy. Thank you.
Good, sorry. Nice presentation.
Yeah, thank you, sir.
It's a good presentation. Can we, Dr. Poonam, are you ready with your second paper? Dr. Poonam?
Yes, sir. Hello.
Ready with your second paper?
Yes, sir. Yes, sir.
Yeah, go ahead with the presentation.
Slides, please.
Second paper, slides, please.
Should I start?
Yeah, go ahead. Yes.
My topic for the second presentation is a prospective single-arm phase 1, phase 2 study, the consolidative ipilimumab and the nivolumab with the thoracic radiotherapy after platinum-based chemotherapy for patients with extensive stage small cell carcinoma. The radiotherapy may stimulate the CD8 positive T cell anti-receptors. In this diagram, the diagram showing the tumor, when the radiotherapy given to the tumor cells, the dying tumor cells releases some new antigens, which were engulfed by the antigen-presenting cells, which further, when goes to the lymph nodes, then the further cells were activated, CD8 positive. Then there is a tumor proliferation occurs, and the lysis of the tumor further done by the cells. The first line, in case of the treatment part, the first line treatment for the extensive disease, small cell lung carcinoma, there were 4 to 6 platinum doublet chemotherapy were given. If stable disease and better for the RECIST 1.1 and the ECOG 101, then they're eligible for the enrollment. The thoracic radiotherapy was given, the dose for that is 30 gray 10 sections for 2 weeks. And the drugs were given with the dose of
Again, we have lost you.
6-month progression-free survival. And the secondary endpoint is 12-month overall survival. Improvement in the 6-month progression-free survival by the 20% consideration clinically meaningful. And in 52% yields the patients yields the 90% of the power reject null hypothesis. That 6-month progression-free survival with consolidative thoracic radiotherapy, followed by the EP and nivolumab, that is more than 20% improvement compared to the Saltman and et al. .
Poonam, we have lost you totally.
Dr. Poonam, can you hear us?
Or at least can you forward forward her slides and yes, let the viewers see those slides. Yes. Yeah, good. Just hold on. Yeah. Yeah, go ahead. Yes.
In the navel outside the RT field, there is a bar graph showing the number of 8 patients with the largest lesion outside the RT field. The conclusion part, in case of single arm phase 1 and phase 2 study, discontinued in early due to the low likelihood of the meeting primary endpoint 6-month progression free goal is 44%, and the 12-month overall survival second endpoint is promising compared to the past studies. The toxicity is in the line with expected, but grade 3 toxicity rate is high. In this diagram, the multiplex immuno
Okay, next slide. Yeah. Yeah, just hold it there. Hold it there, please. Poonam, you want to come back to this slide or are you still not able to read? Okay, I think we have totally lost her. What we will do, Dr. Jyoti Swarup, when in the discussion part, please focus on this paper and let the discussant also talk about this. Okay?
Sir.
Yeah, just sir, please take note of it. And the paper 2, and you make sure that our discussants they focus on this paper 2.
Okay.
With that, and we'll go ahead and with the next paper, and that is the paper 5 by Dr. Abhishek Arora.
Hello, good morning everyone. Can you hear me?
Yes, we can hear you.
I will present the slides. Good morning everyone. My abstract topic is the Dutch lung cancer audit. It was a real-world data on elderly stage 3 non-small cell lung cancer, small cell lung carcinoma treated with radiation. Next, please. Next slide. Next. Okay. First of all, what is a clinical auditing? It is a systematic critical analysis of quality of medical care, including the procedures used for diagnosis and treatment and the resulting outcome for the patient. In simple words, it assesses if a certain aspect of healthcare is being attained by the patient according to standard clinical criteria, which are generally set by a clinical auditing board. It is generally practiced in the European countries, which is UK and the Netherlands. The process, the steps which are included in the clinical audit, they include first of all, in step 1, we have to identify the audit topic. Then we have to set the standard criteria, and we have to match those standard criteria with the predetermined criteria of the study which have already been done. Then according to those criteria, data is collected and data is analyzed. in that analysis, we generally match if the standard criteria which were present, which were there are according, if they are being followed and if they are being matched or not clinically as well as theoretically. And then if they are not, then changes are implemented for welfare of the patient. Next, please. Okay, this was now in this lung cancer audit, mainly non-small cell lung cancer and small cell lung cancer patients of stage 1 to 3C. According to AJCC dates, they were included. Mainly the radiation techniques which were, the protocols which were followed were in majority of patients SBRT was followed and followed by concurrent CBRT. Concurrent CBRT, it was preferred over sequential CRT, mainly I suppose the trial by McGuire et al., in which the concurrent CBRT benefited over sequential CBRT in terms of overall survival as well as the tolerance of the treatment. The exclusion criteria, it was the stage 4 lung cancer and palliative and patients with poor ECOG performance status. Next slide, please. Now, the feedback to the hospital, it was given in the form of stage 4-5 toxicity. These were early toxicities which were evaluated less than 90 days after treatment in the year 2015 to 17. And as we can see, it was higher. Generally, early days it was higher in SBRT arm as compared to the concurrent CBRT and conventional RT arm. Next, please. The study aim in this was analyze definitive chemoradiation in elderly patients which were above markers above 75 years of age with stage 3 non-small cell lung carcinoma. Next slide. The study methodology was that they analyzed the percentage of stage 3 non-small cell lung carcinoma which were treated throughout 2015 to 2018 in a period of 3 years with either sequential chemoradiation or concurrent chemoradiation. The concurrent CTRT is scored in case if RT is started within 30 days of prior chemotherapy, then it can be considered as concurrent CTRT. Information was collected on patient characteristics, tumor size, and treatment characteristics. Toxicity as well as mortality was scored within 3 months after the end of RT. Okay, in this the results of this study, there were 2 arms: the non-elderly less than 75 years and the elderly more than 75 years. The mean age for in the non-elderly was 63.6 years and in elderly was 78.9 years. The predominance of males in both the arms and WHO grade 0. There were mainly the patients of primary tumor, which were 2527 in the non-elderly and 428 in the elderly arm, as compared to the recurrent tumors, which were 88 in non-elderly and 15 in the elderly arm. The pathologically, all of those were the pathologically proven, histopathologically proven cases of non-small cell lung carcinoma of either stage, clinically stage 3A, 3B, or 3C. This is according to the AJCC, in which the stage 3C was added later. And the type of chemoradiation which was followed were in 1738 patients in the non-elderly were concurrent and in the elderly 196, and sequential patients in the non-elderly group were 512 and in the elderly they were 146. The number of patients that were missing or lost to follow-up or lost to didn't continue treatment, there were 371 in the non-elderly and 102 in the elderly. And if the cumulative dose which were reached as planned by the treating physician, it was in 271 it was reached in the non-elderly and in 374 in the elderly now. Next slide, please. The overall toxicity which was recorded were more, as you can see, in the non-elderly arm as compared to the elderly. The toxicity which were less than grade 3 and more than grade 3, they were also more. And as we can see in the concurrent setting, the toxicity was way more as compared to in the sequential setting. 70 in cases of the non-elderly and 17 is in cases of elderly. And within the within the 90 days, and after finishing ctRT, it was 14 cases of non-elderly and 15 in cases of elderly. There were some patients that were missing from the study or they were lost to follow-up. Next slide, please. The conclusions mainly of this study was that the concurrent ctRT, the tolerance of the concurrent ctRT is not worse in the elderly as compared to younger patients, and there was no difference in acute toxicity between elderly as well as the young patients. The 90 days mortality, which was 5.2% for the younger and 9% for the elderly patients. So concurrent ctRT, which is considered to be non-inferior in cases of elderly, the study proved that it is not the case. So concurrent ctRT can be considered as an option if the performance status of the patient is good in cases of elderly patients. Thank you so much.
Yeah, thank you, Abhishek. It was a good presentation and we could be able to understand the summary. Can we move on to the next the presenter for the paper 6, Dr. Pallavi?
Yes, sir, I'm here.
Go ahead.
Can you see my slides?
Yes.
Okay. Good morning, everyone. I will be presenting an abstract presented by Caitlin Atkins. It was a left coronary artery dose exposure that predicts major adverse cardiac events in coronary heart disease negative lung cancer patients. As we know, cardiac events are common and associated with heart dose and baseline cardiac risk. Heart dose is an independent predictor of all-cause mortality, and patients without baseline coronary heart disease are at particularly high risk for major adverse cardiac events and mortality with increasing mean heart dose. They have recruited 748 patients of locally advanced non-small cell lung cancer, and all the hearts were manually contoured. Mean heart dose was associated with increased risk of MACE, that is major adverse cardiac events, with hazard ratio of 1.05 per gray and all-cause mortality with hazard ratio of 1.02 per gray, and that was particularly in CHD negative patients, where they have seen that mean heart dose of more than 10 gray versus less than 10 gray, and they have found that there was increased risk of MACE in CHD negative patients. Their primary objective was to identify the cardiac substructures dose, variables predictive of major adverse cardiac events. The MACE included myocardial infarction, cardiac death, coronary revascularization, and heart failure. For that, 701 patients were identified of locally advanced non-small cell lung cancer. Those were treated with thoracic RT, and a detailed cardiac risk of CHD and Pangemung risk assessment was done. All substructures were manually delineated, which includes whole heart, all chambers, coronary artery spaces. As you can see here, they have delineated all the structures on CT simulation. Coronary spaces were contoured. Those variables were obtained for each structure, with like mean dose, maximum dose, and V for X-ray, that is X in 5 gray increment to up to 70 gray. Then it was exported in a single step from NIM using custom designed automated workflow extension. Analysis was Cox regression analysis was also done, and cut point analysis was determined. When looking at the patient characteristics, the total number of patients were 701, whereas CHD negative were 449 and CHD positive were 252. As we can see that predominantly it was the elderly population, more than 60 years. In CHD negative, median age was 62 years, whereas in CHD positive, median age was 69 years. And then they looked at the top performing dose variables and the cut points by cardiac substitute. Then left anterior descending coronary artery and left circumflex artery were the top performing dose variables, whereas they performed better in patients without pre-existing coronary heart disease and improved performance in low to moderate dose variables, that is V10 gray and V20 gray. Then moderate performing substructures were total coronary artery and left ventricle. Lowest performing substructures were left main coronary artery and the right ventricle, which performed better in patients without pre-existing coronary heart disease. In multivariable regression model, they have seen that they have reported 70 MACE events where significant increase in the risk of MACE with increasing LED V15 gray, that is AHR 1.3%, with p-value significant less than 0.001. Significant interaction between the LED V15 gray and coronary heart disease was seen. Then they estimated, then MACE estimates the stratified by LED V15 gray more than 10% versus less than 10% in total population, and they have seen that there was an increased risk of MACE associated with LED V15 gray more than 10% as compared to that of less than 10%. And as you can see that both the curves were widely separated with significant p-value. When they analyzed separately in CHD negative and CHD positive patients, then the results were similar with significant p-value in CHD negative patients, and the curves were widely separated. That is LED V15 gray more than 10% versus less than 10%. They have again estimated that LED dose with V15 gray more than 23% and less than 23%, and they have found that there was a significant difference between two groups in CHD negative patients. As compared to, the difference was more significant and more in CHD negative patients as compared to those in CHD positive patients. Then looking at the all-cause mortality, multivariable regression was seen, and there was total 490 death events were reported. Significant increase in the risk of ACM with increasing LED with V15 gray, which was significantly associated with a p-value less than 0.001, and significant interaction between the LED V15 gray and the CHD was found. So at the end, they have concluded that despite the competing risk of lung cancer death, cardiac substructures, those variables are associated with an increased risk of MACE and all-cause mortality, particularly in CHD negative patients. As mean heart dose provides a crude estimate, left coronary dose variables have increased sensitivity in predicting the MACE. That is LED dose V15 gray less than 10% in total population, and left circumflex V15 gray less than 14% in total population. These are newly identified left coronary dose volume thresholds are worthy of further study for validation. That's all. Thank you.
Good, Pallavi. That is able to complete it and within the time and give a good summary also. That's good. Excellent.
Thank you, sir.
Move on to the next is the discussion with the expert panel. I will call Dr. Jyoti Swarup Goswami to take over and call the experts for the discussion. Dr. Goswami, are you there?
Yeah, I'm here, sir.
Yeah. You have 12 minutes, Dr. Goswami. Yeah? Go ahead.
Okay. Morning, sir. Thank you to the organizers, Dr. Neeraj, for having us here. So we've got a very short time and we have to make our way through the 6 abstracts as quickly as we can. We've got a panel of experts here, Professor J.P. Agarwal, Dr. Pradeep Garg, Dr. Preeti Jain, Dr. Manishi Bansal, Dr. Aman Sharma, and Dr. Kuldeep Sharma. I hope you're all of us here. Now, we had shared some of the issues that we would discuss today. So, let's discuss perhaps about the first abstract, which is about hippocampus avoidance whole brain radiotherapy. Just a couple of questions on that. If I can start with Professor J.P. Agarwal, sir. What would you feel are the limitations to implementing this routinely for whole brain radiotherapy in India? And also, given that in the past we were used to doing whole brain radiotherapy for brain metastases and have moved on to perhaps doing whole brain radiotherapy with boost, where does hippocampus avoidance sit with regard to focal radiotherapy techniques for brain oligometastases? So, how does it compare in terms of neurocognitive function protection with SRS, SRT?
I think, thanks, Jyoti. I think you have taken the whole big gamut, Being the time too short, I want to thank all the organizers, number one. Second, definitely if you can avoid any critical OAR with whatever techniques you have, the likelihood that if not, in the clinical disease outcome, will have in a quantitative outcome of quality. So that is known across the site. So this is the part of that only. But there are certain caveats in this abstracts presented, especially if I like to say, see in all those neurocognitive studies, they have not taken a neurocognition from the baseline before starting chemo. That is one. Patient factors are generally not taken in account. Like if you see, most of these patients are with a median age of 65, some comorbidity. So already because of those, neurocognition is already on decline. And on the top of that, if we give radiation without avoiding the hippocampus, we accelerate that process, and that is seen maximally at 4 months, 7 months. And those who survive, the repair takes place, and it regains. May not be able to at the full scale if we have not prevented the hippocampus. Having said that, in India, it is really a tough job to do these modern techniques in all comers. So you have to select out which group of patients you like to do it, who are going to survive for long. So that's the bottom line. So maybe if you extend that, not PCI, even if we have sent it to focal radiation, patients with mutation driver, oligo situations, we should be looking for those to do a high-end technique and to have the maximal benefit from a community point of view, rather than an individual point of view.
Thank you very much, sir. Moving on to the next question, which is going to be about chemoradiation in elderly. Could I ask, say, Dr. Pradeep Garg, what is your cutoff in terms of age, performance status, other factors when you select a patient who is technically elderly for chemoradiation? What is your view on the importance of motion management for elderly patients in particular? And just referring to one of the abstracts here today, what is the importance of cardiac dose constraints when we look at giving elderly patients chemoradiation for lung cancer?
First of all, I thanks to all organizers and congratulate Dr. Neeraj especially for taking such pain and making it a huge success. Secondly, thank you, Dr. Jyotiru. I am audible?
Yes.
So,
yes.
Yeah. Regarding the chemoradiation in the elderly patients, I want to comment on just a very fastly that if we compare chemo and radio, chemo has got the more side effects in the elderly patient than the radiotherapy alone. When we combine the chemotherapy with the radiotherapy, then yes, we are going to have some chemotoxicity or radiotoxicity while we treat the cardiac patients or the patients who are getting heart in the field. Like the dose to the LAD and the circumflex vessels, they just can predict whether we are going to get cardiac toxicity in the future or not. Regarding the chemoradiation tolerance, yes, it is tolerated. It is well tolerated. We can give a good quality of life to the patient. Not for so long, because the late complications starts arising because of fibrosis. If the patient has got the tumor near the mediastinum or the lung, and the fibrosis get developed, then the pneumonitis. But we can settle on that with some spurts dose or something like that. But the chemoradiotherapy is well tolerated in the elderly patients. Cardiac toxicity is seen. Cardiac toxicity, of course, arises along with the pneumonitis, which is often seen in our set of patients. We are using platinum-based chemotherapies in our setups because these are cheap, easy to approach. Then the immunotherapy drugs, because nowadays immunotherapy drugs have come into the lung, and the lung cancer are getting the better prognostic, I think they have got the better prognosis after invent of the immunotherapy drugs. So I will go with chemoradiation in the elderly patients if they cannot tolerate immunotherapy or they cannot have finances to get the immunotherapy.
Thank you. Moving on to immunotherapy now, because you referred to it. And I know that abstract was not presented in full. So can I ask Dr. Aman Sharma, can we discuss about the paradigm of how immunotherapy and radiotherapy can work together? How does radiotherapy serve to potentiate the action of immunotherapy, let's say in lung cancer?
Am I audible?
Yeah.
Yeah, good morning, everyone. Firstly, I thank the organizers for a successful Best of ASTRO program. And I also congratulate Dr. Neeraj for his efforts. If I have time, can I answer the previous two questions? Can I make a brief comment?
I think we'll have to stick to just these ones for the
moment. Okay. So my experience with the immunotherapy is very limited. So I think I'm not the best person to talk about it. We have been using this in 1 or 2 patients, but it's difficult to comment right now. So I think I'm not the best person to answer that question.
Can I just ask quickly if any of the other experts on the panel would like to just discuss briefly?
May I say something?
Yes, sure.
Yeah. Hi. As far as this specific paper is concerned, in which this immunotherapy and concurrent radiation has been used for the lung cancers, I just saw that the dose of radiation used has been low. They have just used 30 gray in 10 fractions in a radical dose for small cell lung cancer, which is low. So I think that this is become a trend these days, that whenever there is a concurrent protocol, generally they reduce the dose of radiation and they add chemotherapy. So somehow we are losing on radiation in such type of protocols, and we are just thinking that it is an immunotherapy, so it will not cause any toxicity. I think it will, if we do not concentrate on this, it may go the same way we have taken these Ayurveda and homeopathy, because people just think that they do not cause any problem at all, so anyone can take it for whatever worth. So we have to be very careful, although yes, we know that immunotherapy is safer as compared to the traditional conventional chemotherapy, but they have their own set of problems. And whenever a protocol is made where immunotherapy, chemotherapy, or radiation is used, we have to take good care that we give good dose of radiation so that we can actually compare it with standard protocols of the past.
That's a point very well made, Dr. Kuldeep. In fact, sticking to that issue about dose. Yes, sir.
I'm so sorry. I think regarding the immunotherapy, few basic facts. We should be doing immunotherapy, there is no doubt, and most of the time it is molecular driven. Very well now, good amount of data in NSCLC. SCLC, the data is very sparse and with a limited use and a limited benefit. So in this paper also, they wanted to specify and try to divide which group of patients, the likelihood that you are going to have a better survival. Okay. So it is better to put it in some group of patients depending upon their cluster differentiation, where we should be putting our money on. That's it.
Yeah. So it's all about selection, sir. That's a very important point.
Yeah, that's right, Jagvi, but along that, it is used as an immunobooster. Radiotherapy, particularly SBRT, is used as immunobooster, and that is the reason why radiotherapy by SBRT is given first and followed by immunotherapy. Today, these things are studied very scientifically, and in fact, just about 2 or 3 days back, there was a very good webinar on the use of immunotherapy along with radiotherapy and in lung cancer. Thank you. We'll go ahead.
Okay, thank you, sir. So moving on to the other part, which is about radiation dose, which is obviously very important, and it's actually heartening to see studies still being done on radiation dose. It's not a forgotten topic. So can I ask Dr. Preeti Jain, where does dose escalation stand today with regard to potential, use of immunotherapy, because it's all going towards immunotherapy, but dose escalation still appears to have some tangible benefit. Are you there, Dr. Preeti? Can I ask Dr. Aman then to pick up on this, please?
Yeah, thanks, Dr. Jyoti. Yes, I think there's a role of dose escalation in non-small cell lung cancer, especially if we have to, but then kind of select the patients, and we have to be very sure about the techniques and the margins that we are giving, because it has also been shown that if we use the conventional margins, probably and escalate the dose, it leads to mortality. So I do see a future probably with tracking, when we use techniques like tracking or gating. Probably generating an ITV and then escalating the dose would not be a good idea. Reducing the dose, reducing the volume and then giving a high dose would be fine at my end. Especially we can use 2 to 3 cycles of chemo, maybe reduce the volume of the dose. It also depends like how many the nodes are in the mediastinum. Are there like mediastinal nodes, contralateral mediastinal? What is their volume? What is the volume of this of the primary tumor? Is it central in location? Is it peripheral in location? So if there's a peripheral small tumor, of course you can target it with the SBRT, and you can use a hybrid technique also, where you can combine SBRT for the peripheral tumor and maybe use conventional doses in the mediastinum. That has also been tried. Another thing is we can shrink if the nodes are very big, we can shrink them with chemo, and if they respond well, then again we can escalate the dose. We have to be very careful, but I do see a future in dose escalation, and I feel that when the volume is not very big, and if we go to a PED of 100, as we go in early disease, we can have good control, local control rate, but we have to be careful.
Thank you. Now I know the time is very short.
Technology is also coming, so I think there's a bright future. Proton, Cas9, MR-Linac, I think we have a future.
Dr. Jyoti, can we close this session now?
Can I just have the last question, sir, because I don't think we've asked anything for Dr. Manish Bansal. Just on the note of reducing the volumes, the use of PET-based adaptation, what do you think are the pitfalls of using PET scan for adapting treatment volumes for lung cancer? Where could we go wrong, do you think?
I think I don't know whether
yeah.
is Manish Bansal, are you there? Okay, we'll skip this question. And
yeah.
Can you do your final concluding and your remark, Jyoti? Then we'll close this.
Yes, I think that the abstracts have been absolutely spot on in terms of choosing the important trends in research, and the importance of hippocampus avoidance. We're obviously coming to terms with how radiation works with immunotherapy, something we are looking at with a lot of interest, and looking back, more traditional topics like chemoradiation and dose constraints for cardiac sparing is obviously, these are areas where we can keep on improving traditional treatment approaches. So I think that the selection has been excellent, and I'd like to thank yourself, sir, and also the organizers for having us here. Thank you.
Yeah, good. That is right. I agree with you. The selection of the papers are really good, and we learned quite a lot. I can see only one question. I know in the chat box, and Dr. Shashikala has asked, can immunotherapy be used along with radiation in elderly? Yes, it is being used.
Yes, it can be used.
It can be used, and of course, the medical oncologists will deal along with them, and going ahead, it is much better, and you are quite safe. To conclude the whole session, it was a wonderful session. Particularly, I liked the auditing, clinical auditing. I request all my radiation colleagues, when you go back and please audit your own department and how far you are doing well in in any particular case that you take, or it could be even lung, or it could be any other part, and audit your case, how you are faring as far as the patient outcome is concerned. That's a very big take-home message for me. And the rest of things like hippocampal sparing and the dose to the heart and SABR dose escalation, all these things are a part and parcel of learning curve for us. It was a very good session. I thank the organizers, the presenters, and the expert panel, and the discussant, Dr. Jyothi Swarup, and thank you very much and a good day. We close the session.
Thank you, sir. We quickly move on to the next session. Next session is on very important issue of the palliative care. In India, we will get the patients late stages and the patients of the care.
Sir? Dr. Neeraj Jain? Sir, can you unmute yourself?
Yeah, we quickly move on to the next session. Next session is on palliative care. This is an important topic in radiotherapy. We get the patients in stages of the cancer. Palliative care is the only choice left. Chairman for this session is Dr. Patrick, Director of Chairman. Coordinator for this session is Dr. Immunotherapy. ED in University Lucknow. President of Radiotherapy.
Hello?
Yes, sir. You are audible, sir.
Yes. So can we start?
Yes, sir.
Okay. Welcome, dear delegates and speakers for the day 2 session 9 on palliative care. We'll have the session coordinator as Professor Neeraj in oncology at Sanjay Gandhi PGI Lucknow, and a panel of experts with Dr. Suman Das from Vizag, Dr. Suman Malik from Kolkata, Dr. Santanu Paul from Kolkata, Dr. Madhup Rastogi from Lucknow, and Dr. Manjit Singh Jora from Bhatinda. And in this session, we'll have 8 presentations. The first 2 will be presented by Dr. Ayush Garg from Bareilly. Then the next 2, the third and the fourth presentation will be by Dr. Maninder Singh from Chandigarh. 5th and 6th will be by Dr. Deepak Agrawal from Delhi, and 7th and 8th would be by Dr. Nilesh Mani from INSBT. Now I request Dr. Neeraj Rastogi, the chairperson, the session coordinator, to please take over and continue the session.
Thank you, Dr. Pradhan. Now I am thankful to Dr. Neeraj Jain and his team for organizing such a wonderful program in this COVID era, so that we are all joined together with the face-to-face, like one-to-one each other. Now, without wasting our time, we are just inviting Dr. Ayush Garg for presenting the abstract number 1. Dr. Ayush Garg, please, he is from Bareilly.
Good morning, sir.
Good morning. Yes, Ayush.
Is my screen visible?
Yes, your screen is visible.
Good morning to all. So today I'll be presenting my first abstract on the topic Palliative assessment of the BMITS decision support platform. So it is a tool to improve provider survival estimates and selection of prognosis appropriate treatment for patients with symptomatic bone metastasis. So as we know, so there are various protocols for palliative radiation, 8 gray versus 4 gray in various fractionations, or 3 gray in 10 fractions versus stereotactic radiotherapy. So as we move from 8 gray to various 20 in 5 year, 13, 10 towards stereotactic, there are lower chances of retreatment rates and possible increased local controls in stereotactic RT. But the disadvantage of tactic RT is that it takes longer time to plan. So as you can see, 8th grade has shorter treatment time and planning time, and as well as lower direct cost. So ideally the selection of appropriate palliative bone regimens would be individualized for each patient. So considering of life expectancy, quality, and best evidence. So the project objective was to develop a assess provider facing developing support platform to aid in selection appropriate palliative treatments in the management of bone metastasis. So it is based on Ottawa decision support, and the determinants of the decision process were identified by semi-structured interviews with provide stakeholders and the review of 54 key evidence and consensus-based resources. So first of all, the two important components are collecting relevant patient-specific data to facilitate ease of use and to display an individualized predictive survival curve for each patient. So these are the basic platform for the BMETs, which uses 27 prognostic variants and random survival forests to predict the time from RT to consultation to death. So the various patient features have been taken like age, sex, race, KPS, WBC count, lymphocyte count, treatment factors like site of RT, concurrent palliative RT to the bone sites, concurrent palliative to bone non-bony sites, or patient is on steroids or non-opioids, or which was the last systemic therapy type, or disease factors like primary cancer site, neuroaxis compromise, or time from cancer diagnosis, or metastasis to various other organs. So as you can see, so this is the site in the tool on which we have to enter the various factors. As you can see, there is age at consultation, race, gender, primary cancer site, when we enter all these factors, so this type of survival curve comes, in which it is an interactive orange plot. As you can see, it demonstrates the predictive survival curve within the 12 months following radiation oncology consultation for the specific patient based on characteristics selected above, as you shown on the previous slide. So the blue curves demonstrate the predicted survival for all other patients with symptomatic bone mets in BMET database, arranged from lowest, which is in dark blue, to the highest in light blue. So through this we can see where does the patient lie actually. So orange one is showing where the actually patient is lying. So when we again come to the components, so there is reviewed with 54 consensus resources to identify clinical factors used as criteria for selecting specialists. So it provides individualized prognosis and evidence-based recommendations for RT and non-RT interventions. So again, when we see to this page where we have entered our data, the DSP links specific clinical factors for a given patient with corresponding treatment recommendations from the consensus resources. So when this chart is showing, then this is the main recommendation of treatment. So discussion of prognosis, it is as shown the whatever shown on the software, that prognosis should be discussed early in the course of treatment illness, ideally within 1 month of diagnosis with the terminal disease. And what about the radiotherapy? It says that consider shorter fractionation radiotherapy. Palliative radiotherapy for bone metastasis can be considered with life expectancy greater than days to weeks. Then high quality data is demonstrated 30 grade to 10 fraction, 20 to 25 or 8 in 1 are equivalent in pain control or uncomplicated chest wall sites. 8 grade 1 optimizes convenience, but it is associated with higher retreatment rates. And again, it also gives evidence that as per NCCN and NSCLC guidelines, 8 grade 1 fraction 20 in 5 is recommended for any bone metastasis. And stereotactic radiotherapy would not usually be appropriate in this setting. So as you can see, it gives data regarding guidelines also, that which guidelines are giving which data. So what it says about open surgery, like no definite contraindication, open surgery to chest wall sites is contraindicated if life expectancy is less than 2 months. What is the regarding systemic therapy? Cancer directed therapy should not be continued in inflated patients, either of the following, and solid tumors on low performance status. Expectations include those with disease characteristics and life expectancy less than equal to 2 weeks. And what about hospital referral discussion? No definite contraindication. It is recommended when life expectancy less than equal to 6 months. So after following all these recommendations from the software, we have to make a treatment decision. So how will you make? So they took 10 radiation oncologists, 5 physicians and 5 trainees and reviewed 45 patients without the use of BMETs. So after 3 weeks of washout, then again these physicians reviewed with the help of DSP the software, and the use of DSP resulted in a reduction in overestimation of actual minus estimated survival time with a mean difference of 1 month, and p-value was very significant. So the physician's accuracy for predicting survival at clinical relevant points. So whether it is less than or more than equal to 3 months, less than equal to more than 6 months, and less than 12 or more than equal to rest. So in pre and post DSP era, the p-value was significant. And as you can see, in pre and post DSP, the use of BMET significantly increased selection of single fraction RT and reduced selection of more than 10 fraction RT or SBRT regimens. As you can see, the yellow one, which is the post DSP era. So in this also, the 3 months and 6 months and less than 12 months survival, the use of BMET tool improved prognosis, appropriate selection for less than 1 fraction RT for survival in less than 3 and 6 months, and then 5 fraction for more than 12 months, as you can see in this bar graph. So what about the open surgery and other hospice and systemic? This also improved significantly in the open surgery era. So the confidence in survival estimate was more for the physicians, and likelihood of sharing estimate with case patient was also physicians were quite confident. So in summary, in this pilot assessment, BMET DSP significantly improved physician accuracy in estimating survival, resulting in a reduction of survival overestimation by 1 month. BMET DSP improved selection of guidelines and prognosis appropriate RT regimens in open surgical interventions, and BMET DSP also increased physicians' prognostic confidence and likelihood of sharing survival estimates with case patients. But the main drawback and the future directions for this study will be multi-institutional assessment of BMET DSP and inclusion of patient preference parameters which are not included in this tool.
Thank you, Dr. Ayush. Now, in paucity of time, you can now start the second abstract of your presentation, that is rapid access multidisciplinary bone metastasis.
Thank you, sir. So my second topic is rapid access multidisciplinary bone metastasis clinic decreases financial toxicity for patients undergoing palliative radiation. So basically, palliative radiation is effective in reducing pain from bone metastasis. The primary purpose of this study was to evaluate patient financial toxicity for patients receiving treatment in a rapid access bone metastasis clinic. So why it is called rapid access? Because they have a flow chart in which they are saying that as soon as the referral is placed, consultant is triaged and prepped, and in the morning orthopedic consultation is done, followed by radiation oncology consultation, and at 11 or 12 around simulation is done, and the same day the patient is treated. So that's why it is called rapid access bone clinic, the rapid access bone metastasis clinic. So patients referred to RABCs are surveyed, and the patient estimates OP cost. So OP cost is like out of pocket cost. So in the US, they have, apart from the finance they have, apart from that, what else they have to pay. So that patient estimated OP costs were taken. So OP costs were compared in patients treated with this RABC clinic, non-RABC, in when 8 gray was given in RABC and 8 gray was not was given in non-RABC clinic. So the travel distance was computed, and the local patients traveled less than 100 miles. So Wilcoxon test was done, and patient self-assessment of cost burden was done in patients treated in RABC and patients treated out of RABC. So as you can see in this chart, patients reported on the y-axis, patient reported out-of-pocket estimate, and the x-axis distance from MDACC Cancer Center. The travel distance directly correlated with the OP cost, which increased the cost when patient had to travel longer. But there was no difference in travel distance by treatment in clinic. So when they were coming, there was no distance in travel distance. So the satisfaction with cost burden was high, and the OP cost was lower in RABC 8-gray single fraction regime. So it was $500 versus $3,500. So in US settings. So the take home of this study was that RABC at MDAC significantly decreased overall financial toxicity for palliative radiation treatments. Increased financial toxicity was associated with longer travel distance, and implementation of RABC in local community centers can further decrease financial toxicity for patients receiving palliative radiation. Although it is quite tough to talk in Indian scenario because the figures and distance are comparatively less in US as compared to India. So thank you.
Thank you, Dr. Ayush. So because we are running behind the schedule, So we will be asking questions in the end from to our expert panels. And now I will invite Dr. Maninder Singh from Chandigarh for abstract number 3, a prospective randomized phase 2 trial of single versus multiple fracturation, stereotactic spine radiosurgery. Dr. Maninder from Chandigarh.
Good morning, everyone. Am I audible?
Yes, you are audible.
Is my screen visible?
Yes, your screen visible.
Okay. Good morning. Today's first topic for presentation is a prospective randomized phase 2 trial of single fraction versus multi-fraction spinal SRS. As we all know that oligometastatic state is hypothesized to represent an intermediary state between widely metastatic disease and curable localized disease. Within this group, an opportunity arises where targeted treatment toward limited metastasis may confer disease and even possibly survival advantages. Spinal SRS increases the therapeutic window by achieving delivery of higher BED and lowering the risk for spinal cord myelopathy and other critical OAR toxicity. There have been multiple studies which has compared the conventional radiotherapy with SRS with local control as high as 90%. Despite the observed high local control rate, optimal schedule of SRS for patients with limited spinal metastasis is not well established and has never been investigated in a prospective randomized trial. As we all know that multiple studies have assessed the role of SRS in limited spinal metastasis using different dose fractionation schedule, of which a few important are summarized in this table. They demonstrated local control rates ranging from 72% to as high as 96%. Present study was aimed to compare two spinal SRS schedules to determine which results in the lowest rate of treatment-related toxicity. Patients with biopsy-proven non-hematogenous malignancy and limited unirradiated spine metastasis not requiring upfront spine surgery were eligible. There should not be any leptomeningeal or intramedullary involvement on imaging, and not more than 3 sites of involvement with a maximum involvement of 2 contiguous vertebrae, a KPS of more than 60, and life expectancy of at least 4 months were considered. It was an open label randomized phase 2 trial having 2 arms. First arm received single fraction, 16 gray single fraction with BED 10 of 41.60 gray, whereas second arm received 24 gray in 3 fractions with BED of 43.2 gray. They were all treated using IMRT, VMAT, and RapidR. Primary endpoint was to compare 2 spinal SRS schedules to determine which results in lowest rate of grade 3 or higher protocol-specified adverse events at 4 months. Secondary analysis included time to treatment failure, which was defined as presence of grade 3 or higher adverse events or unequivocal local progression of treated spine, indicative of re-irradiation or surgical intervention. For radiotherapy treatment planning and target delineation, MRI fusion was used. CTB was defined as the spinal tumor with intraosseous margins of 5 to 8 mm within the involved spinal level. Entire vertebral body IVDs and both pedicles were not routinely included when uninvolved. All patients were treated with Linac-based SBRT using VMAT via dynamic conformal arcs. CBCT before each arc was employed as image guidance to confirm setup accuracy. Between November 15 and October 2018, a total of 50 patients were enrolled for spinal SRS, including 40 lung cancers, 2 each from breast, head and neck, liver, and prostate, and 1 each from colon and thymic cancer. Of these 50 patients, 26 were randomized to single fraction arm and 24 to multi-fraction arm. Median age was 62 years and median follow-up time was 16.3 months. A total of 77 metastatic spinal levels were treated, which included 1 cervical, 42 thoracic, 31 lumbar, and 3 sacral sites for SRS. 9 out of these 50 patients had epidural invasion, 4 in single fraction arm and 5 in multi-fraction arm. At 4 months, none of the 25 evaluable patients in single fraction arm experienced any protocol-specified grade 3 or higher toxicities. But 1 out of 21 in multi-fraction arm underwent surgical intervention due to progressive compression fracture. None developed radiation-induced myelopathy. During longer follow-up, 3 patients in single fraction arm and 6 additional patients in multi-fraction arm developed treatment failure. Median time to failure was 13.5 months in single fraction arm, whereas it was 8 months in multi-fraction arm. 1 year treatment failure rate was significantly worse in multi-fraction arm at 14.3%, which was statistically significant. To conclude, single fraction spinal SRS has met primary endpoint with low risk of treatment-related high-grade toxicity at 4 months. Initial secondary analysis suggests 16 gray single fraction might be the preferable spinal SRS schedule due to less treatment failure events after longer follow-up. Thank you.
Thank you, Dr. Maninder. Now we invite you for the second abstract, which is the improving palliative care journey in the radiation and oncology.
Yes, sir.
Dr. Maninder, please.
Yeah. The next topic that I will be discussing is presented in Sydney Cancer Center was how to improve a palliative patient's journey in the radiation oncology department. RT has an important role in providing the symptomatic relief and improvement in quality of life for patients with bony and soft tissue metastasis. Current clinical pathway, as you can see here, firstly getting a referral to radiation oncologist, then coming in for a consult with a radiation oncologist, and then returning for a CT simulation scan, which will purely be used for treatment planning purposes. Then patient has to wait somewhere between couple of days to a week or more before the treatment is started. This time is burdensome not only for the patient but also for the patient's family and results in unnecessarily prolonged discomfort and poor quality of life. It was hypothesized to streamline the clinical pathway by removing the need for CT simulation. Aim of this study was to investigate the feasibility of using a patient's diagnostic CT to produce palliative 3D CRT plans.
I think your the screen is not visible, only the first slide is visible.
Let me shows that it is sharing.
No, it is visible, Dr. Maninder.
Okay. So to see if this was at all feasible, project was divided into 2 stages. First stage was a retrospective analysis from the database, which will help find the patients most suitable. Second stage was prospective implementation. It was begun by comparing diagnostic CTs to simulation CTs to help define potential barriers to sim-less palliation. They were assessed for field of view, difference in patient position, and other potential factors which would impact radiation dose if the CT simulation were not required, such as Hounsfield unit comparisons and its impact on dose. There was considerable variation in field of view. The first image is an example of a spine CT, which is very limited and clearly insufficient for treatment planning. Chest, abdomen, and pelvic CTs were good, but chest, abdomen, and pelvic CT were good, but as you can see from the image on the right, the best were PET CTs. They had the largest field of view encompassing the whole patient body, but they also enabled the easy location of lesions. Next step was to replicate patient's diagnostic CT position. Lesions situated in the pelvis, abdomen, thoracic, and lumbar spine were easiest to replicate. For chest lesions, reproducibility was dependent on patient's arm position. Areas such as cervical spine and extremities were excluded. This was because, for example, the cervical spine replication of neck flexion and extension was too challenging. Hounsfield unit comparison of different tissue types were conducted, and it was found that HU values were similar to simulation CT. On assessment of the dosimetric impact of HU variance, it was found that the largest dose difference occurred through lung tissue and may have a dose error up to 5%. The selection of beam energies also mattered. Higher beam energies reduce the effect of HU variance. All these factors put together affected the PTV coverage. Plans with predominantly soft tissue anatomy exhibited less variance in PTV coverage compared with thoracic spine and chest plans. This was mainly due to the variability in the location of inhomogeneity, such as bone and lung, impacting dose calculation. On average, PTV V95% between diagnostic CT and simulation CT plans were reduced by 1%. With all this allowed the project to move on to stage 2, and this is how it was implemented. Prospective patients for palliative treatment were screened for eligibility, which were bone and soft tissue metastases, which are located in pelvis, abdomen, thoracic and lumbar vertebra, and chest. Diagnostic imaging, CT or PET CT, with adequate field of view to enable treatment planning and patient setup, and they had to be clinically current, preferably within 4 weeks. Patients were set up to best replicate their diagnostic position and CT. This was performed so as a backup plan would be available if diagnostic position could not be replicated at treatment. To overcome a flat top treatment couch, a custom curved back bag was used to assist in reproducing the patient's posterior body contour. The volumes were contoured on diagnostic CT and they were checked on simulation CT. Treatment planning was done on both diagnostic CT and replicated on the simulation CT dataset, only to be used as a backup. Pre-treatment CBCTs were performed. Either a bone or soft tissue match was done and the patient's body contour checked to ensure that they were within 2 centimeters of tolerance. If an appropriate image match could not be achieved, then SIM-CT plan were used. If it was achieved, then we proceeded to deliver the diagnostic plan. Post-treatment, actual delivered dose was compared to what was planned. For this, delivered plan was recalculated on the acquired CBCT and compared. For the result of stage 2, 30 patients were treated from a range of anatomical sites and dose fractionations. A total of 87 fractions were delivered, with the majority being bone metastasis. For all fractions for 30 patients, only diagnostic CT plans were delivered. Post-treatment dosimetric comparison between CBCT and diagnostic CT plans showed PTV V95% ranged between -2 to 2.5%. So for palliative intent treatment, clinically acceptable plans using a patient's diagnostic CT were successfully produced and were able to successfully replicate their diagnostic position for treatment, thereby removing the need for a SIM-CT in selected patient. With this seamless pathway, plans can be available at patient's initial consult with their radiation oncologist, allowing same-day treatment, reducing patient wait times, and expediting the delivery of radiotherapy to improve quality of life for palliative patients. Thank you.
Thank you, Dr. Manendra. Now I invite Dr. Deepak Agarwal, who is from New Delhi. He will be presenting single fraction stereotactic versus conventional multi-fraction radiation therapy, a phase 2 trial.
Thank you, sir, and good morning, sir. Thanks for the organizer to giving me this opportunity to present the abstract. So, is my slides visible?
Yes, visible, Deepak.
Okay. So, good morning all. So, my first abstract is a single fraction stereotactic versus conventional multi-fraction radiation for predominantly non-spine bone mates, a randomized phase 2 trial. We don't have robust data fraction RT for non-spine bone mates. but still few literature have suggested that single fraction RT is equivalent to multifraction RT. Multifraction RT suggests that 20 grain 5 fraction or 30 grain 5 fraction, 30 grain 10 fraction. But in spite of this, higher single fraction RT results in higher retreatment rate. Some literature has shown is 2.5 times. However, it is also less expensive and more convenient for the patient. All the clinician in this world is very much familiar with multifraction regimen in 13-10 or 20 grain 5 fraction, and more comfortable, and patient are, and also physicians are more comfortable with long-term outcome, and it is also durable. A previous study, RTOG 9714 study, this included patients with breast and prostate cancer. Almost 900 patients were randomized in 8 grain single fraction or 30 grain 10 fraction to see the clinical effect at pain and narcotic relief in patients with variables as complete, partial, stable response. Secondary outcome was there were retreatment rate, quality of life, toxicity, and fracture. The clinical outcome between two fractionation regimen, that BPI means that brief pain inventory score, was not significantly different between the two arms. Also, overall response as complete, partial, stable, or progression, there was no difference. If we take the survival outcome between two fractions, median survival was 9.1 in 8 gray and 9.5 in 30 grain 10 fraction. Also, complete objective response, orthonorcotic, pathological factor, retreatment, toxicity was no difference between two arms. The conclusion of this previous study was 8 gray was as equal to 30 grain 10 with pain and narcotic relief. However, there was similar rate of pathological fracture, but 30 grain 10 with more toxicity and also retreatment rate in single fraction was higher. In 2007, a systemic review, which included 16 trials from 1986 onwards, this pooled data shows that there was no statistically significant difference with single fraction in terms of objective response, complete response, pathological fraction, cord compass. However, retreatment rate with single fraction was 2.5 times compared to multifraction. So now coming to the current study, which is single fraction SBRT versus conventional multifraction SBRT for pain relief in patients with predominantly non-spine bone mass, we included 163 patients, randomized 160 patients. In 79 patients were treated with multifraction regimen and 81 to the single fraction regimen. So primary objective to evaluate single versus multifraction in terms of pain control, and also secondary objective to prospectively report pain, quality of life, orthonorcotic, acute and late toxicity, local control, survival, and re-RTA salvage surgery in later course of time. If you see the patient characteristics, there was most of the patients, the primary include breast, esophagus, head and neck, liver, lung, multiple organs, pancreas, prostate, and renal cell carcinoma. So total 160 patients, 79 in 30 grain 10 fraction. In SBRT arm, total 81 patients were stratified with dose with 12 grain single fraction, dose of lesion more than 4 cm, and for patient with less than 4 cm lesion, the dose was 16 grain 1 fraction. The PT was GTB plus 5 mm margin. So if the clinical outcome as pain response over time, but per protocol analysis, if we see that patient who received single fraction over multifraction, they are well responder at 2 weeks, also at 3 months, and also 9 months, and that was statistically significant in single fraction compared to multifraction arm. If you see at 2 weeks, it is 62% in single fraction, 36% in the multifraction arm. If we assess the intention to treat analysis, the patient who received single fraction have got better responder at 2 weeks and also 3 months compared to multifraction arm. If you see the progression-free survival in the SBRT arm, 2 years, at 2 years, PFS was completely 100%. However, in multifraction, it is 90% on 1 year and 75% at 2 years. If we assess the re-RT rate in those patients who are treated, 2-year re-RT rate in SBRT was 0% in the current study. However, in multifraction, it was 5.3%, while the difference was not statistically significant. If we compare the similar result, the present result, which is the previous bone pain trial, 1992 to 1997, that shows that 1 year re-RT rate is double in single fraction compared to multifraction, 8 grain to 20 grain 5 fraction. One of the possible cause could be because the less BUT dose given in single fraction arm compared to the current arm, which is given a higher BD compared to that bone pain trial. So I think that could have translated equivalent result between the SBRT and multifraction arm. If we assess the toxicity between SBRT and multifraction, that the dermatitis was still grade 1 and not more than that. The other toxicity, nausea, vomiting, was also limited to grade 2 mostly, and grade 3 were very few. However, one patient, the SBRT was very gratifying. The result, the patient presented with acute urinary incontinence and loss of sensation. After being 12 grains single fraction SBRT, urinary sensation was regained, function was regained, Foley's catheter was removed after 3 weeks. So in conclusion of this study, the higher dose single fraction SBRT results in more durable pain response compared to standard multifraction 20 grain 5 or 30 and 10, and should be recommended for patients with good KPS or with long life expectancy. This is minimal toxicity, safe and also effective treatment, and higher dose of SBRT could be in future could be a standard of care for bone metastasis. Though at present we don't have a much robust data, and so RCT with high ability dose as SBRT with combination of immunotherapy or combination of chemotherapy is need to be evaluated in prospective study in future. Thank you for this was my first presentation. So coming to my second presentation, the SBR COMET randomized phase 2 trial of stereotactic radiation for comprehensive treatment of oligometastatic cancer, the quality of life result. This is a Canadian study. The previous study, which was published last year, has shown that SBRT over the conventional fraction has a benefit of 6 months in terms of PFS and 13 months in terms of overall survival that was statistically significant. So, randomized data assessing the quality of life in SBRT in oligometastatic setting are lacking. We don't have much quality of life data in SBRT in current scenario. Also, we think that since higher dose per fraction is given in SBRT, so it could compromise the quality of life because of increased side effect, especially the late side effect, because dose per fraction is very high. So the primary endpoint of this study was overall survival, secondary was PFS, toxicity, quality of life, local control, and number of cycles of systemic therapy. So in this current study, they have assessed the quality of life between the 2 arms. So FACT-G, this is the functional assessment of cancer therapy, general questionnaire, which is commonly used in clinical trial, which allows the comparison of quality of life between different anatomical site treated and also the site of different primary, which is more 4 main domains, which is physical, social, emotional, and functional well-being. So main inclusion criteria, those who have oligometastatic disease and has been treated past 3 months with controlled primary up to 5 meds with maximum meds 3 meds in a single organ, and all where diseases were safely treatable. These were included in the study. Regarding dose fractionation, most of the dose was given in the multifraction at 3 to 5 fraction, and most of the side were lung, bone, brain. However, single fraction was also given in SRS 18-24 gray in brain, or also in a bone 16 to 20 gray in single fraction. Otherwise given as multifraction, normal tissue tolerance was respected, and PTV, however, the PTV coverage was not compromised during the treatment. The result of a study, if we compare the baseline characteristics between the 2 arms, standard of care in SBRT, that there was no significant difference between the A6 or site of the primary tumor with respect to breast or colorectal, the other side which was, there was no difference between the 2 arms. If we see the baseline number of metastatic sites of the which were treated, most of the patients have 1 to 3 meds. This is almost 90% in the both the arms, equally distributed, and no significant difference between 2 arms. Regarding location of meds, majority has either lung and bone meds. Almost it was 80 to 85% between the 2 arms, and not different between the 2 arms. Regarding adverse event, more than grade 2 event was little bit more with SABR 29%, then 9% in standard of care. That was the significant difference. Other adverse event at fatigue, dyspnea, pain was very much controlled and was very much less than 10% in both arms, and was not difference between the 2 arms. Now coming to quality of life or quality of life outcomes, if we see The four parameters which was determined previously, the physical, social, emotional, and functional well-being, there is no statistical difference between the control and SABR arm between the two arms. However, if we observe, there was a little dip as the patient is followed during the course of time in the SABR compared to control arm. So quality of life outcome in patient who died from last 5G completion to death. Standard of care, it was 8.2 months, and SABR, it was 3.1 months, thus there are no difference. This suggests that quality of life completion rate may have worsened as patient condition deteriorated due to progressive disease, particularly standard of care arm. So discussion, this study has several limitations. This one of these says 5G is a general measure of quality of life. This which patients were treated in is either in SABRT or in the conventional, both were given the same questionnaire, and we don't have the study don't have the question regarding dyspnea, diarrhea, and dysphagia, which could also be attributed because of the treatment toxicity. So to take home message, quality of life declined slowly in both arms. There was no statistical quality of life determinant. There is no quality of life compromise in SABRT, which was previously hypothesized in this study. The quality of life instrument used by general, which has advantage and drawbacks, because choices may be because there were different sites with different histologies, allow for higher participation and comparison in different tumor types. So conclusion of this study that SABR for oligometastatic disease did not appear to be associated with quality of life compromise in the current study. Future studies should be considered to test or to develop more sensitive and specific quality of life measurement tool, while keeping the general quality of life questionnaire still to be allowed for global comparison between the arms. Example, adaptive electronic questionnaire, and which may be included in the further studies SBR COMET-10 trials. Thank you, sir.
Thank you, Dr. Deepak. Now I invite Dr. Nilesh Mani from Varanasi, who will be presenting in pre and post radiotherapy SUV values of the basically PET matrix into the oligometastasis. Dr. Deep.
Good morning, sir.
Nilesh Mani.
Good morning, sir. Am I audible?
Yes, you are audible.
First of all, I would like to thanks my organizer to give opportunity me to present the abstract. And good morning to all delegates and everyone. My first abstract is pre and post treatment metabolic matrix predict probability of local relapse-free survival in oligometastasis following single dose radiotherapy. The purpose of this study was to assess the potential of baseline and early post treatment PET SUV max values as a predictor of long-term outcome of single-dose radiation therapy and hypofractionated stereotactic body radiotherapy in extracranial oligometastasis. Material methods used in this study was a total of 169 patients were taken, of which 559 lesions were present, mean of 2.1 and ranging 1 to 5 lesions per patient. And the prescription dose was 24 gray in a single fraction. In those patients in which due to dose volume constraint, the prescription dose was not achievable, in that patient 9 gray into 3 fractions was used as a SBRT. And 76% were treated as single dose radiotherapy and 24% were treated as single stereotactic body radiotherapy respectively. The SUV max values were acquired 3 times, one at pre-treatment, second at 3 months and 6 months post-treatment, and 6 months thereafter. Tumor response was scored according to the PERSIST criteria and confirmed by morphological imaging. And correlation between baseline SUV max and its decline with actuarial local relapse-free survival were analyzed. So what they found that the baseline SUV was significantly associated with the local relapse-free survival, and the optimum cutoff value was 10.2, yielding a relapse-free survival of 86% when the value was less than 10.2 and 63% when it was more than 10.2. The Kaplan-Meier survival plot for local relapse-free survival here depicts the 86% local relapse-free survival for baseline value of less than 10.8. This graph is for all lesions, and when while separating for the two different arms, it was found that the value of local relapse-free survival was higher as compared to the stereotactic body radiotherapy arm in both the values less than 10.2 and more than 10.2, and the value of 93% was found at 5 years. Local relapse-free survival of 93%, the SUV max less than 10.2, 93% was found. Another relation was done between change in SUV max. A decline of more than 75% was associated with 86% actuarial 5-year local relapse-free survival versus 72%. For all lesions, it was found that the local relapse-free survival at 5 months was 86% when the decline in SUV max value was more than 75%. So, and while separate analysis in between two arms, it was found that the total local relapse-free survival at 5 years was 96% when change in SUV max was more than 75%, and 88% when change in the SUV max was less than 75%. In both the arms, single dose radiotherapy and stereotactic body radiotherapy, the values are statistically significant. So they concluded that these two factors, first, the baseline SUV values, that is 10.2, and change in SUV, that is more than 75%, found to be two good features, and the reciprocal of these are two adverse features, vice versa. A multivariate Cox analysis confirmed decline in SUV max as the only independent covariate in predicting local relapse-free survival. Bivariate analysis using permutations of various baseline SUV max and change of more than 75% SUV max decline at 3 months versus either of the above adverse features were compared, and it was found that for all lesions, when both good features are present, that is baseline SUV max less than 10.2 and change in SUV max more than 75%, the local at 5 years, the local relapse-free survival was 93%, as compared to 77%, which is when one adverse feature was taken, and as compared to 53% when both the adverse features were taken, and both the differences were statistically significant. In individual arm, it was found that on bivariate analysis, when comparing two good features with two adverse features, the 5-year local relapse-free survival was better in good feature arm as compared to the bad feature arm, and it was also statistically significant in both the groups. So they conclude that the combination of pre-treatment SUV max and post-treatment change in SUV max can be used to predict metastasis-directed long-term local relapse-free survival, and these metabolic metrics can be used in clinical decision-making where lesions are at risk of local failure, may be subject to more intense follow-up for potential early rescue with effective application. Specifically, the relapse-prone lesion identified with this approach in good prognosis oligometastatic patient may potentially benefit from early reintervention to achieve optimal long-term local relapse-free survival. Thank you. My second abstract is a volumetric dosimetry analysis of vertebral body fracture risk after spine stereotactic body radiosurgery, presented by Maxwell Lee et al. At Cleveland Clinic. Spine SBRT is gaining popularity nowadays because of delivering high dose per fraction, but with a feared complication of radiation myelopathy and vertebral compression fracture. However, till now we do not know that how radiation dose heterogeneity affects the vertebral compression fracture. So in this study, the previous studies have shown that done by Rose et al. In 2009 has shown that the rate of vertebral compression fracture is 39% when here says 71 sites in 62 patients, and the median dose given to the patients were 24 gray in one fraction. And in another meta-analysis done by Farooqi et al. In 2017, which has assessed 2911 spinal segments and found a vertebral compression fracture rate of 13.9%. with a median dose ranging from 18 to 27%, hazard ratio of 5. So the objective was to analyze how the distribution of radiation dose on vertebral body is associated with risk of vertebral compression fracture. They hypothesized that increasing the proportion of vertebral body receiving high dose may be correlated with the greater risk factor of vertebral compression fracture. So what they did, they studied patients undergoing a spine SBRT at a single center between November 2014 to August 2016. And for all patients, the vertebral bodies were contoured using CT simulation, and their clinical characteristics were analyzed retrospectively, and risk of vertebral compression fracture was assessed with completing risk analysis of death as a completing risk factor. So the patient and treatment characteristics were a total of 173 vertebral bodies were drawn from 85 patients. Median follow-up was 14.2 months. There was no difference between demographic characteristics between the groups, and all patients were given 16 or 18 gray in single fraction. The location of spinal vertebral were 69 in lumbar, 86 in thoracic, 22 in cervical, of which 22% were having prior vertebral compression fracture, 62% were having oligometastatic disease, and 41% were having epidural disease. So the survival on completing this factor with death, they found that 1 year survival was 66%, 2 year survival was 43%, and accrued incidence of vertebral compression fracture was 12.1%, of which 9 were progressive and 12 were de novo. On multivariate analysis between the they found the relationship between different treatment characteristics and incidence of vertebral compression fracture, and they found that volume of vertebral body receiving dose 20 gray and volume of vertebral body receiving dose 24 gray was statistically significant. So they did a sensitivity analysis, and to obtain a 90% sensitivity, they compared different volume, and they found that volume of vertebral body receiving 24% of volume receiving more than 20 gray is found to be 90% sensitivity when the dose was restricted to 20 gray or more, and when the percentage volume of vertebra receiving more than 24 gray, they obtained the 90% sensitivity. So they finally conclude that vertebral compression fracture is a common complication of spine SBRT, and an increased proportion of vertebral body receiving 20 gray or greater is associated with increased risk of vertebral compression fracture. And at the 90% sensitivity, limiting the portion of vertebral body receiving 20 gray to less than 24% reduces risk of vertebral compression fracture, and limiting the proportion of vertebral body receiving 24 gray to 0% reduces the risk of vertebral compression fracture. Thank you.
Thank you, Dr. Nilesh Mani. Let's thank all the presenters. Very good presentation by the. Now we will discuss each abstract by one of the experts. So now the first question regarding the first abstract to Dr. Suman Das. Is Dr. Suman Das is there?
Yes, sir.
Good afternoon, sir.
Good afternoon, sir.
Actually, the first abstract was bone mets assembled trees for survival, BMET.
Right.
And BMET, they have used the 27 prognostic factors.
Right, sir.
And there was reduction in overestimation by 1 month by the clinical versus the overestimation by this clinical versus this tool using the tool. How you feel whether BMET tool is worthwhile to use?
In Indian scenario, I still feel it's a long way to go, but definitely at institutes with good kind of documentation, and it needs a lot of basically paperwork to have all these things in place. And if we have, maybe this can be tried as a tool to as a thesis topic for students, and a long way to go in terms of research on this topic.
I think I agree with you. You should at least have a computer assisted, because every data you have to fill on the computer, and then you can, it requires a lot of data to entry in the computer.
Yes,
Sir, I Dr. Madhav, sir, I feel that
yes, Dr. Madhav.
It's a sort of is a tool of artificial intelligence, I suppose. Because once you have entered everything, you just enter the patient data and it will tell you.
But you require a lot of assistant, Dr. Madhu, for the putting all the data. One can record the data and then put all the data on the computer, and then you can analyze this. I agree with you. It may require a lot of AI.
Yeah, but once it is prepared from previous inputs only, and ready-made software will help you.
Thing is that if we leave aside this tool also, but all these factors are very, very important to consider whether to treat with what kind of palliative treatment that we need to go ahead, and that should be taken into consideration in the Indian scenario. That's what I feel.
Thank you. Now the second question is Dr. Suman Malik from Kolkata.
Yes, sir.
For the second abstract, in which they have used the rapid access multidisciplinary bone metastasis clinical disease, and then they have find out the financial toxicity in those patients who have going the multidisciplinary versus for the out of the pocket expensive, and they have found that $500 versus the $3,500.
Yeah. So actually this is important aspect, because for a palliative patient, if we can treat that patient on the same day, that actually not only improve the financial toxicity, but also that decreases patient's hospital visit, and which is significant for a painful bone mets. If you ask a patient to come for another day for the treatment or for the simulation, that is a definite logistic problem for them. So likewise in our institute also, we always try to do the palliative treatment on the same day. We do the simulation and as well as the treatment on the same day based on the patient. If you look at the other hospital, like I worked before in the TMH, in TMH also we had a specific slot on Saturday. Usually we ask patient to come on Saturday. Usually we do simulation as well as treatment on the same day. So this is, I think this is one of the important aspects for palliative care treatment, because that not only improves the cost, out of pocket cost, but also improve the quality of life of the patient.
Thank you, Doctor. Now, because we have a very senior radiation oncologist, Dr. Shantanu Pal, with us. He has a vast experience in this radiation field. So I can ask what is his views. Dr. Shantanu Pal.
With regard
to this thing, immediate treatment versus you can calling again and again.
It should be logistically, it should be immediate treatment to lower the cost, travel, all the logistics can be adhered to if you can have a single fraction and do it immediately.
Okay. So now for the abstract number 3, 16 gray 1 fraction, single fraction versus the multiple fraction in phase 2 trial. I can ask this question from Dr. Shantanu Pal again.
Yes.
Because you have already answered this question.
Now, we still do not have a proper optimal schedule, and it's going through a phase of study. And if we actually have these two SSRS protocols, we have seen that the adverse effects for the single fraction is doing better, because it has lesser adverse effects, grade 3 and 4 at 4 months period. So if this is, and logistically also, if you are coming for a single fraction and if you are bearing lesser costs, I think it is better that we do it. But we need a longer follow-up to know the details of this. So we need to have a longer follow-up gradually.
Thank you, Dr. Paul. Now we have the next abstract number 5, abstract number 4, I think. Abstract number 4 is improving the palliative patient journey to radiation oncology by Dr. Maninder Singh, and we have to ask this question to Dr. Madhu Prastogi.
Yes, sir.
Whether really we use the diagnostic CT, because in this their plan they have shown the diagnostic CT which can be used. Otherwise, you can use the CT SIM for the planning the patient. What you feel, Dr. Madhu, in this?
Sir, I would like to answer this question in a different way, because just before that, abstract number 3 was concerning spine SBRT. Another paper is there where we are talking about non-spine SBRT. Yes. And here we are discussing that can we omit the even CT SIM, and we can use the diagnostic CT SIM. So there are so many things depending upon the patient which you are dealing with. For example, why we are talking about today the spine SRS, because it's not an easy place to handle, and where you are going to give 16 gray in one dose. It is only became possible because previously it used to be framed. You have to fix the spine, then only you can go ahead with such sort of treatment. Now we are doing, because we have got better, imaging. We are implanting fiducials. We are doing infrared surface markers with real-time motion correction. Then only we are able to deliver such big doses. So here I would like to point out that what type of patient and what type of treatment you are planning. Suppose if a patient is in oncological emergency and you have to deliver a radiation in immediate basis, there I think we can use the CT diagnostic CT, but it should be in your department and it should be connected by packs which you can import from that radiology department to your TPS, and then you can correct that all backlog and you can make the curved body posture rather than a straight couch correction. And then you can deliver. No doubt about it that it is going to help the patient in our scenario. That much I have to offer. But if you are planning a very high end of radiation with a single fraction of SBRT or SRS, you cannot depend on these type of imaging.
Thank you. I think very nice you have told that packs should we have before. Now I have to, for the 5th abstract, I have to ask this question from Dr. Manjeet Singh from Bhatinda. Is Dr. Manjeet is there? Is Dr. Manjeet is there?
Hello, sir.
Yes.
Good afternoon, everybody.
Good afternoon, sir.
So thanks, Team ASTRO and Dr. Neeraj.
Yes. Nice to see you, sir. There was a paper by Dr. Deepak Agarwal that same question, same way why Dr. Shantanu Pal has answered, 12 to 16 gray versus 30 gray, multiple fraction. SBRT versus the multifraction RT. What do you feel? Ki single fraction SBRT is as good as multiple fraction?
So, as concerned with the pain, as concerned regarding to the pain and dependence on the opiates, definitely single fraction is equivalent to multifraction. Next, it depends upon the site and volume of disease. What dose we have to deliver. Definitely in our scenario, it is going to help with single fraction versus multifraction. Even at All India Institute, we used to give a single fraction on every Saturdays, and that as decreases the load as well as optimum use of machines. Out of 6 machines, we used to use 2 machines for palliation on Saturdays.
I think are the experts believe in the single fraction because it decreases the financial toxicity, it decreases the patient coming again and again, and good response without any significant side effects.
Definitely.
Sir, can I comment on this?
Yes, sir. Yes, sir. Welcome.
Sir, I'm Dr. Anil Thakwani. I'm from Delhi NCR. So
Yes.
basically, I'd like to add to it, like if the bony lesion is associated with some soft tissue lesion also along with that, then it's better to give, it has been seen, it's better to give multiple fractions. But if it is purely a bony lesion, and as Dr. Manjeet said, it is of a limited volume, then we can go ahead with a single fraction because of looking at the easiness of the patient, or like this, if it is only bony lesion, then we would like to give it in a single fraction so as to prevent the further trauma to the spinal cord. So this is what I want to add. Thank you.
Thank you, Dr. Anil. Now, regarding the abstract number 6. What is the quality of life in the stereotactic ablative radiosurgery versus the standard of care? I can ask this question to Dr. Suman Das again. Is Dr. Suman Das is there? I think if he is not there, Dr. Manjeet, you can answer this question. Quality of life.
As in this study, they have shown not a significant detriment for quality of life, but they have used a general tool basically.
Yes, FACT-G they have used.
FACT-G.
Yes.
So by using more specific and more sensitive tool, may have more results. But definitely in clinical setting, definitely single fraction improves other domains of life, domains like social and family worries. They have not to wait, and traveling, emotional as well as social factors.
Thank you. Now for the abstract number 7. That is the pre and post treatment SUV value of the actually PET metabolic matrix, which is the SUV value of that. So for that, we can ask Dr. Madhu. Dr. Madhu, having PETs in their hospital as well as good linear accelerators, many linear accelerators for this therapy. Now, Dr. Madhu, please.
Sir, as far as the study is concerned, it seems to be good where we can have a prediction by just doing PET scan, and we have to see the decline of SUV pre-treatment 3 months and 6 months, and basically what I could understand that we can predict the local relapse of by decline. If that decline is less, we can plan more actions, because we anticipate that patient might be relapsing, and we can plan more action, more supportive treatment, so that that relapse can be delayed. But as a practical purposes, I do have PET scan, but utilizing PET scan for an Indian scenario, especially in government situation where dates are very, waiting list is huge. It will be difficult for us. So as far as in studies and clinical trial, it is good. But using it in practical purposes for all patients, I think it will be difficult.
I think repeatedly PET cost a lot, because you are doing the pre-treatment and post-treatment again 3 months. It costs a lot, so it may not be feasible in most of the Indian setting.
But in future, I think it might help. Yeah.
Yes, that's.
Can I chip in?
Yes.
Can I chip in?
Yeah.
Yes. Welcome, sir.
First of all, we logistically we don't have everything under one roof. In fact, all our cancer centers do not have this PET scan within our premises. So we have to send the patient out. Logistically, this is very tough. But if we can overcome that, and if we do have it in the Apex Center, suppose, then we can build a nomogram from which we can later on use this as a method of clinical decision making, if we can build up a nomogram with these PET scores.
Yes, because they have in this paper, they have very well shown that if more than 75% decrease in the SUV value, definitely they are the better responders, better survival in these patients. Now for the abstract number 8 to Dr. Suman Malik, please. That is vertebral compression fracture, in which they have given the volumetric dosimetric analysis for the vertebral and correlated with the vertebral compression fractures, and they have found the dose more than 20 gray that was associated with increased risk of the volumetric vertebral compression fracture. Yes, Dr. Suman Malik is there. Dr. Suman Malik is there.
Unmute. He needs to unmute.
Okay.
Am I audible now, sir?
Yes, yes. Dr. Suman Malik.
Yes.
So regarding the abstract number 8, this vertebral compression fracture, in which they have found the more than 20 gray dose in the single fraction. So it increases the risk of volumetric, this is vertebral compression fracture, because you have worked in Tata as well. Because you have given so much high dose in the vertebra with the stereotactic body radiotherapy.
Yes. Actually, what we are moving now, we are moving towards a single fraction stereotactic radiotherapy from a multi-fraction radiotherapy. So at this juncture, so previously we used to give 24 gray in 3 fractions. Then we moved to 24 gray in 2 fractions. Now actually people are moving towards 16 to 18 gray in single fraction.
Yes, 16.
So at this juncture, this data is important because how much dose we should restrict our vertebral body to receive, because they have clearly shown if it is more than 20 gray in a single fraction, there is higher chance of vertebral fracture. So this is an useful information for our next step actually. If we are moving towards a single fraction SRS for vertebral body metastasis.
So we used to give not more than 16 gray in 1 fraction for vertebral metastasis.
Yeah.
We never gone beyond that. Thank you for all the experts for their very useful views.
Just wind up because
and we have to just call Dr.
We are behind the schedule.
Yes, we have stopped now. Dr. Pradhan is to you. Dr. Pradhan.
So thank you all.
Final comments and
especially thank Dr. Neeraj. So I especially thank Dr. Neeraj Rastogi for being the session coordinator, and the experts we have Dr. Shantanu Paul, Dr. Madhu Rastogi, Dr. Suman Das, Suman Malik, and Dr. Manjit Singh. So and all the presenters like Dr. Ayush Garg and Dr. Maninder Singh, Dr. Deepak Agarwal, and Dr. Nilesh Mani. I thank you all for this session. Interactive and quite nice, well presented, the presenters, and very good interaction from the experts, and for Dr. Neeraj Rastogi for nicely conducting the session. And in the end, I thank Dr. Neeraj Jain and his teammates for making this a very good program. Thank you all.
I also want to thank Dr. Neeraj Jain and their team.
Very well done. Me too, Doctor.
Yeah, Dr. Neeraj, I just want to add.
Thank you all.
Dr. Neeraj, I just want to add that we do have so many webinars from other specialty, but they are mostly fractionated. You have done a regular course in that to be 48 hours duration, means 2 days, and bringing 1,200 people in one monitor rather than one roof. It's really hats off to you and entire executive body who has participated, and really great. That is our unity. That's our unity.
The joint effort of all the members. All participated. I thank you all from my heart.
It is Dr. Neeraj Jain personal relation to all.
Definitely, it's really you have done great. Congratulations.
Thank you very much.
Thanks.
So with this, we wind up this session and we move on to the next session, which is on the patient safety. And to chair this session, I invite Dr. Vivek Kaushal. who is head of radiation oncology at Pandit B.D. Sharma, PGI Rohtak. And the coordinator for this session is Dr. Senapati, who is from Cuttack. So quickly to Dr. Vivek Kaushal.
Good afternoon. I welcome you all to the next session, which is regarding the patient safety. We know that the main aim in medicine is, while we treat the patient, there should not be done any harm to the patient. So, in radiation oncology, not doing the harm to the patient can be achieved by one of the two means, either by human checking or by computer checking. So, in this session, we have got 5 papers which are covering both the aspects. So, for the first paper, I invite Dr. Sarthak Tandon from Delhi, and he would be speaking on optimizing efficiency and safety in external beam radiotherapy using automatic gland check tool and Six Sigma methodology. Dr. Sarthak Tandon, please.
Thank you, sir. Am I audible?
Yeah, yes.
Yes. So I'll be sharing my screen right now. Just give me a moment for it.
Please stick to the time. It's 7 minutes per speech.
So is the presentation on screen? Am I audible?
Yes.
Hello?
Sir, you are audible.
Is the presentation, can I request the secretary to please put the presentation on, because I think there is some problem with my sharing screen.
Yes, yes.
Please, thank you. Yeah. So, afternoon everyone, all the faculties and the delegates, chairperson sir, and at the outset I would like to thank the organizing committee for giving me this opportunity of presenting these 2 abstracts. So for my first abstract, I would be focusing on a research article by the Stanford University, which is on optimizing efficiency and safety in EBRT using automated plan check, APC tool, and Six Sigma. Next slide, please. So what can all be automated in radiation oncology? So automation is a big new game in the field of radiation oncology. This is what we all know. The major share of international resources are now being diverted to studying and analyzing the effectiveness of automizing various fields and aspects of radiation oncology. So, but for this research, the authors have focused on automation for QA, that is quality assurance and quality check. They have used an APC software, which is the automated plan check software, and Six Sigma workflow. Next, please. This is how the automated plan checker software developed in-house from Stanford University looks like. This is their interface. Next, please. So next, please. So this is the Six Sigma DMAIC. So DMAIC is an acronym which stands for Define, Measure, Analyze, Improve, and Control. It's an old strategy that has always been used to effectively increase the efficiency of a quality improvement project. So by define, they wanted to, it was aimed to describe the scope and goals of QI project and to lay out project timeline and identify involved staff. The measure stage was aimed to investigate the defects arising in treatment plans, learning system, the incident system, whereas the analyze stage was aimed to quantitatively investigate and establish highest risk check item using FMEA. Now, so FMEA stands for the default and analyzing the effect of those faults. The improved stage was aimed to develop and deploy an APC tool based on Pareto sorted text items. And the final control stage was... Sorry? Yeah, so the control stage was aimed to create a continuous feedback loop to provide a sustained optimizing and performance monitoring design and implementation of each stage, as in the description. Next, please. And next slide, please. So can I have the entire slide first, please? Next, please. Yeah. So the goal of this stage, as I said earlier, was to define certain parameters. It needed to define goals and challenges that will encounter during this research. They also identified challenges and defined that successful development and the implementation of automated plan checking software they rely on a collective repository of knowledge and comprehensive efforts from the multidisciplinary team. So these multidisciplinary teams, they often have challenges and complexities within different radiotherapy treatment techniques, modalities, and specific protocols. Next, please. So they also wanted to define a specific timeline. So this timeline was started from January 2018 and is still ongoing. Next, please. So this is the multidisciplinary team which was used in this research project, which included physicists, dosimetrists, physicians, and RTPs as per our daily clinical scenarios. Next, please. So for the measure stage, they had as identified the ILS, which is the incident learning system, are used for both reporting and learning by collecting patient safety related events, analyzing related clinical impacts, and extracting common errors from these ILS. So for this research, they used primarily two ILS reporting systems, the STAR and the Good Catch. Now, I just wanted to say something that this STAR and Good Catch is their in-house ILS, which is not something which has been standardized internationally. So STAR is a non-anonymous 22-item web form which is open to all the radiation oncology department there and is specifically for higher severity incidents. Whereas Good Catch is relatively is an anonymous 4-item web where you can report errors but anonymously. Next, please. So for the analyze stage, they use the FMEA, which is the effect monitoring system, where you analyze the failure modes and the effect analysis accordingly. In this stage, the check items eligible for automations were identified, and then they were prioritized using the FMEA protocol. An itemized list of the individual physics plan check steps were compiled using the AAPM TG275 draft checklist. This is something we all know. Team ranks following the severity of the impact, the detectability dominancy as the probability of error going undetected, or the occurrence, which was determined based on the records from the departmental ILS. So this is how they analyzed the data, and this data was then Pareto sorted. So what is Pareto sorted? The plan checking steps were sorted in the order of decreasing RPN. RPN stands for the risk priority number, so to determine the highest priority item to be addressed with this proposed analysis. Next, please. Next, please. Yeah. So now comes the improve stage. So they were planning to use all the data that they had and come to an improve stage. So what was this improve stage? Can I have the entire slide, please? Yeah, thank you. The APC is specifically tailored to the departmental policy, their departmental policy and clinical workflow. So they had used this Sharp software and then collaborated with Eclipse API to form this Eclipse scripting API. So basically what they're trying to say is this scripting data, the software had used a lot of the data and then incorporated in the in-house running variant system, so that the dosimetrist and as well as the physicist can use those data in individual clinical assessments. Next, please.
Thank you.
So the control stage was aimed to provide a sustained optimization to the APC tool by creating a feedback loop. So what they now aimed was that whatever they have achieved, it should be in a feedback loop so that they could monitor and improve the robustness of the software. So the QI team conducted reviews and reported errors on a bi-monthly basis and then reported this control stage. Next, please. So this is the checklist, this exhaustive checklist. In fact, it consisted of about 101 check items in total, and it was Pareto sorted by RPN, and they wanted to identify the automation priority, and they had so far they had automated about 60% of these 101 check items. Next, please. Next, please. Yeah. So this was their result now. So what they wanted to say from this result was that the RPN ranking reevaluation 9 months post APC demonstrated a statistically significant average decrease in the RPN values. Now it was quite a sharp drop from 129.2 to 83.7%, which is statistically significant. So what they said was that the effectiveness of the APC tool is most evident in decreasing the high severity errors of prescription and plan mismatches and incorrect anti-center shift instructions to the therapist. So these three parameters came out to be the most effective ones which could be checked with using these APC. Next, please. So, as various quality improvement measures were implemented in the clinic to prevent errors in treatment planning, corrective actions taken to alert staff, they resulted in certain corrections. And what they found out was that the before plan approval, the first run versus final run, there was a sharp drop of 13.3 to 4.4%. So what does it mean? It means that they were preventing error propagation, which is, and this was statistically significant. Next, please. So what is efficiency study? So they used 20 clinical treatment plans. This is something which is not mentioned in the slide, but in their paper, they had 8 SBRTs and 6 BMS and 6 3D-CRT plans, which were prospectively selected to participate in the efficiency study. So what they used was, these plans were divided into 2 equal groups. One was for manual physics plan check, and the other was for APC-assisted plan check. What they picked up was 5 errors were found in 10 manually checked plans, including high severity errors of the prescription versus plan discrepancy and missing shift notes. In contrast, only 1 error propagated to physics plan check out of the 10 APC checked plans, showing an 80% decrease in error. So the average time gained with the APC assistance was about 10 plus minus 7 minutes, which is statistically significant. Next, please. So this was the plan documentation interface, which they subsequently uploaded to AryaTalk and automatically generated shift notes to the RT. So basically what they're trying to say is that whatever their work that they had done, it was computerized and was automated. Next, please. So what have we learned till now? The ILS-driven data is a must. We need to quantify errors and prevent them from happening upstream. So basically they had departmental ILS, but you can also use what is called as radiation oncology ILS, which is their nationalized, standardized system of incident learning system. Next, please. So in regards to quality control and quality management, the robustness, what they found is the demise feedback loop was instrumental in getting their dosimetry support. So because of that exhaustive DMAIC feedback loop, their entire result propagated into an effective output. Next, please. So, and then they actually said one of the most important things is that standardization. Their entire result is based on the fact that their software, their protocol, and their DMAIC feedback loop was standardized. So by standardization, they could have a consistent procedure and policy, which could be consistently had a consistent nomenclature and definition as per the ASTRO white paper. Next, please. Yeah, this is the paper that they had used. So what else could you do with this scripting software? ESAPEX is an open source extension library for Variant Eclipse. So they had used Variant Eclipse scripting API. People who have different software can use different APIs. And so they were trying to use this software for easy data mining for different clinical trials as well. Something which was not a part of this study, but this is what they wanted to do in future. Next, please. So as per their conclusion, the authors concluded that Six Sigma DMAIC methodology is useful and effective for clinical QI projects. Automation using SRP, so which is the Eclipse software, improves quality and efficiency of treatment planning procedure, plan checking procedure, especially for high severity errors. Direct impact on patient safety is challenging to quantify. Reduced error frequency reported is in good catch, and reduced error propagation to treatment reported in STAR. For next, please. For the future work, they wanted to use these softwares and their protocol for highly error-prone PDI checks, including plan quality dosimetry constraint checks, creating a separate module for therapy plan checks, as well as brachytherapy plans, and APC to identify outliers based on population statistics for previously treated plans. So this is their integration of plan quality with the APC and their current clinical form. Thank you. Can I have my, can I move on to the next abstract, please?
Okay, thank you, Dr. Sarthak. Go for the next paper.
Thank you, sir. Right. So for my next abstract, this abstract is again based on, sorry, yeah. So my next abstract is also based on quality assurance, but this quality assurance is primarily related with contouring for a clinical trial setting. So quality assurance of contouring for an NRG oncology protocol, RCOG 1308, which was based on author segmentation with deep active learning. Next, please. These were the disclosures of the authors. Next, please. So for precise radiotherapy for optimal treatment requires organs at risk to be accurately delineated. This is no news for us. The better the accurate the delineation, better is the plan and better is the output. However, considerable inter and intra-observer variations in the delineation of OARs have been reported. This has been studied and found. It may result in inconsistent evaluation of doses to the OARs, therefore hampering our efficacy of radiotherapy and analysis of its toxicity. Next, please. So, Low et al., this is one of the studies back in 2014 and it was published in JPO. They reported that 23% of the contours submitted to a multi-center peer-reviewed lung stereotactic radiation therapy study needed major revision. Now, this is a huge number. It is therefore essential to undertake quality assurance of OARs contouring for multi-center clinical trials because the cases come from different medical centers and so are susceptible to inconsistent contouring. Please. This QA procedure is usually performed manually by physician investigators, which is both time consuming and subjective. Again, because there will be multiple physicians involved, there will be subjective error that is instilled in this checking. There is therefore a need for an automated and objective QA method. The authors of this abstract have developed a fully automated method for the QA of OAR contour based on deep active learning. Next, please. So what they've done is that they've taken patient data set from the study, which was a gold standard atlas from the lung CT segmentation challenge back in 2017. So this had about 36 cases. Then they took 110 cases from the NRG Oncology RTOG 1308 trial. How they divide these 110 patients is going probably what we'll see in the next slide. The OARs that they studied were heart, esophagus, spinal cord, and lung left and right. The manual contours of the gold standard atlas were drawn according to the RTOG 1106 contouring atlas guidelines. Next, please. So what were the various auto-segmentation methods that they had used? One of the most important and well-recognized methods is the convolutional neural networks, which is the CNN method. It's a deep learning method which has proved effective for semantic segmentations and is becoming a state-of-the-art method for this. But one of the biggest drawbacks for CNN is that it requires a sufficiently large set of manually annotated instances to achieve a good performance. And these manual annotations must be accurate enough to avoid misleading of the model training. So small gold standard atlas with few annotated cases is insufficient for optimally tuning these fine parameters. So we have the clinical trial data, but the data is large enough and there's a lot of variation in accuracy. So it cannot be relied upon completely. Next, please. So this is the flowchart for their QA procedure. As you can see, the authors prepared a gold standard atlas for disease type and divided the cases from the clinical trial into three major chunks. First, into the candidate set, second, into the validation set, and third, into test set. So now we have four sets with us: the gold atlas, candidate, validation, and test. They fed the gold atlas into the CNN model. So this majorly trained the CNN model with the gold atlas training set. However, this was not sufficient enough for making a fine-tuned CNN model. So what they did was they used the candidate set. Now, how they took the candidate set is something that we'll see in a subsequent slide. But these candidate sets, about 70 in number, they were fed into the CNN model again to fine-tune it. So they evaluated the accuracy of this then attained fine-tuned model by applying it to the validation set. Now, what is a validation set? So validation set is the one which had included contours with verified accuracy. So the physicians had verified its accuracy, and then this was fed into the CNN model. The evaluation metrics included dye similarity coefficient DSC and the Hausdorff distance HD. Finally, they applied the fine-tuned CNN model and the decision criteria to the test set, which was to be tested. Next, please. And sorry, I think, can we move back to the slide? Yeah. So, yeah, let me come up to the slide. So the CNN model had demonstrated to have a state-of-the-art performance. They inputted CNN was the original 2D CT images, and its output was the corresponding segmentation probability map for the OARs. Next, please.
Dr. Sarthak, you have exceeded your time limit.
Okay, sir.
Please summarize in 1 minute.
Yes, sir. Okay, sir. Thank you. So this is, I'll be skipping these 3 slides. These are just formulas that they had used to classify their material methods. So we'll jump to the results section. Can you move to the first? Yeah, thank you. So if you can see the OARs, they had taken out the OARs and presented the result in 2 forms, the BIS and the Hotstop distance. And if you can see that all the OARs passed the passing criteria for both parameters, BIS and Hotstop distance. Next, please. So this is the error detection results table. This table lists the results of contour error detection using test set. The balance accuracy for all the OARs were greater than 0.95, which indicates that 95% of the contours were recognized correctly and no future manual rechecking was required. Next, please. So this is the image set that they had given us, and these figures represent examples of inappropriate contours detected by the QA system. The manual contours are in red and the automatically generated contours are in other colors. From the first column to the 5th column, if you can see that they are heart, esophagus, spinal cord, left lung and right lung respectively. And the system was able to identify slices with missing contours, contours drawn in red, drawn in error and inappropriate contours. Next, please. And now to summarize what the authors wanted to say was that the quality assurance of the delineation of organs at risk is essential for clinical trials in radiotherapy. They proposed an automated method for QA of organs at risk, delineation based on the active learning. The evaluation using multi-center clinical trials demonstrated that the method can detect contour errors accurately and can thus serve an effective QA tool.
Thank you, Dr. Sarthak. And now I invite the next speaker, Dr. Stamsi Arora. Your time is over, Sarthak. Excellent presentation. Thank you.
Good afternoon, everyone. Am I audible?
Yes, you are.
Thank you. The presentation given to me today is reducing treatment delays with a modified no-fly policy. Long wait times and or delay in the start of radiotherapy potentially compromise the timeliness for treatment of cancer patients. If we rush high-risk tasks to compensate for planning delays to start on time, that potentially compromises the patient safety. The purpose of this work was to design changes in planning processes and scheduling to reduce the delays and risk in the start and delivery of treatment. Now we have a quality checklist process map. We analyze the failure modes and effects. We identify the high-risk steps forward and we reverse if we identify any failure modes. Certain high-risk tasks are treatment prescription, treatment consent. We review the path before simulation, contouring, plan completion, second plan check, IMRT quality assurance, laterality, and the first day physics check. Now the risk mitigation strategies. As per Institute for Safe Medication Practices, the most effective to least effective strategies are forcing functions and constraints, automation and computerization, simplification and standardization, reminders, double checks, checklist, policies and procedures, training and education. As per the Northwell Safety Program, the most effective to least effective strategies are no-fly treatment policy with specific stopping rules, paperless operations, process mapping, Six Sigma, Z-score statistical process control, failure mode and effect analysis based quality checklist, custom policy and procedure database reviewed monthly, and transitional phase training. Now this is a standard process where the CT simulation is done, then the contouring is done, plan is made, which is reviewed, which is exported, quality assurance is done, the second check is done, and the treatment is started. This is a standard process. Whereas in delay rush process, what happens? The contouring is delayed and the further steps, they are rushed to start on-time treatment. Now no-fly process, it forces the activity into timed intervals and it penalizes for any failure to complete. Now no-fly policy, we have 7 steps for initiation of radiation therapy, consultation and the treatment, CT simulation and the contouring, chart rounds, treatment planning, plan approval, second physics check, then plan is uploaded, the treatment is initiated. In no-fly, one patients are scheduled to start 9 days from simulation. No process is rushed or skipped, everything moves ahead in a sequence. No-fly patient start delays, treatment starts after all components are complete as per defined timeline. No last minute starts are allowed, patients are rescheduled to start on another day. A no-fly event rules have been established for cancelling appointments. There is a cultural shift from just in time to cancel if not ready. Now the 2010 to 14 results are 15 to 18% of patients were rescheduled monthly proactively and up to 8% of new starts were not delayed. Now no-fly 2 modified the no-fly rules to schedule the start of treatment only after plan approval instead of CT simulation. The corresponding impact of no-fly 2 on delays and safety was assessed using data extracted from our databases. Now what is new in no-fly 2? There are no fixed timelines, interlocks are retained, everything must be completed before a VSIM appointment is made and performed. No-fly is still in effect following plan approval. Now there are 7 steps for initiation of radiation therapy which we have already discussed. In no-fly 1, patients are scheduled to start 9 days from simulation. In no-fly 2, the treatment is started 72 hours after the approval of the plan. No process is rushed, no process is skipped, everything moves ahead in a sequence. Now the results are no-fly 2 resulted in a drop of delays in scheduled treatment start appointments from 10.1% to 1.3% with a p-value of 0.004. There is increase in the time for completion of contours and pre-planning peer review extended the turnaround from CT simulation to treatment start from 10.6 to 11.1 days. There is a delay rush process, however, the delay rush process, however, continued to be mitigated. Conclusion is, changing the scheduling time point for starts from the CT simulation to the date of plan approval has led to a significant reduction in treatment delays. The no-fly 2 policy supports a safety culture that prevents rushed work. Future work will focus on improving the efficiency for treatment starts. Thank you.
Thank you, Dr. Samsi. Excellent presentation. Now I invite the next speaker, Dr. Mathangi from Bangalore. Dr. Mathangi, please.
Good afternoon, everybody. Thank you for giving me a wonderful opportunity to present here. I thank Dr. for conducting this and, of course, all the chairpersons and the panelists here. It's one of the wonderful topic that has been given to us about the patient safety issues. Can you all hear me? Am I audible?
Yes.
Yeah. Thank you, sir.
You are audible. Yes.
Thank you, sir. So I just need to select. Is my PowerPoint also seen?
Yes.
Thank you for the response. So we have been, for the past 1.5 days, we have been loaded with how to treat the patients. That was nice to hear that different guidelines, how to update ourselves and everything. But all the treatment guidelines that has been presently given has to be put into practice. That is, from sick patient to well patient, when all the processes are happening, then obviously we have a chance of getting into a error of treating these patients, how to detect these errors. This is what is the most important thing that comes into the mind, whether if there is an error, it usually we have different steps. Like previously, Dr. Samsi Arora has clearly explained how it goes around the simulation, then the second physics check, chart check, and so many things are happening. And we always in radiation oncology give more priority to think about machine quality assurance rather than giving it to the patient. How do we really get into the quality assurance of our treatment plan check? Most of the errors happen in the treatment planning setup, whether it is from the treatment planning, right from simulation to contouring to planning, and for execution, there are different steps where it is error prone. So Yale School of Medicine, Dr. Calcote has decided to do a blinded prospective study of a problematic plan detection during physician chart rounds. So how common is the errors? In radiation oncology, it is reported, academically it is reported 1 in 200 patients that there is the common error which is happening in radiation oncology alone. So is it really 1 in 200%? Probably it is underreported because of a general culture of not reporting or underreporting most of the errors happening in different fields. So most significant errors happen in radiation therapy planning steps. So what happens? Radiation, as we all know, radiotherapy has its own catastrophic consequences. It may result in huge side effects, or it may result in an undertreatment and a chance of denying a cure to the patients getting treated. So physician peer review, they have found different steps. There is a physics chart checking, and then pre-radiation treatment review, pre-radiation treatment chart round checkings, and there are different steps. In this, they have found out whether chart rounds is really creating an important role in doing a quality assurance check in the treatment planning setup. How can we improve the peer review is the further things. So studies of peer review there is a doubt whether this chart rounds is really demonstrating an efficient way of doing the QA. The doubt comes from the background of peer review in other departments have been 30 to 8, at most 40 to 70% has been reviewed. This can be because of the other department reviews can always be done. We have seen that other department experiences like radiology reports can be reread by the peers, and the pathology reports and the submitted academic journals, and the radiation pre-treatment plan reviews by the physicist. So for example, Gopan et al., there's an article which has been published which checks about the second physicist review. Always a physicist auditing happens. Second physicist auditing happens after the plan presentation. So this, you can see in this example, the patient's isocenter shift has been entered in the system as no right and left or no adjustment needed, whereas actually if you see the error in this treatment planning system, there was a millimeter of differences which has occurred. So Gopan et al. Has found out 67% of the errors can still be checked by second physicist error. But what is the percentage that happens with quality of chart checking round quality assurance is only 40%. So the challenge is why it happens, because in the charted round performance, it happens around, even if it happens for 1 hour, for a busy scheduled department, there will be n number of cases. So there is a time constraint, competing priorities, which is the priority. So many cases like, and the interruptions that happens for a clinician when they are attending this, cognitive bias, because our attention goes down when as the time goes down, a number of cases increases. The treatment complexity, for example, to just guess around a rapid arc or IMRT, a complex treatment field, just sitting in the chart rounds may not be easy for identifying a problematic plan or an error has happened. or there may be a non-standard formatting. For example, not all clinical details are entered properly before simulation is taken for simulation. And then there may be a culture that, see, we have a culture like everybody is posted in different department. A person is posted in simulation, the other person contours, other person looks into the plan, and finally everything should be formatted. The person into the simulation may not even have the clinical details of this patient. For example, if I'm doing a cervical spine, we may not know which vertebra and how much is the epidural extent or soft tissue extent to really do the extent of the CT imaging. From there, the error starts. So as a result, chart rounds likely also can have error detection rates. And most of the time when we are doing, it depends on sometimes the clinical presentation details are not available and we rely on our memory when the chart rounds are happening. Of course, the last and most important thing, when we have too much of workload, we should always remember it is also the fatigue that causes the chart round performance to be little lesser. So as a result, chart rounds likely also has only 40 to 70% error detection rate, and it is not a foolproof technique. So the objective here is to find out if we intentionally put some problematic plan, how much does the chart round really detects these things. So what were the actual factors that were affecting the PP detection methods? So the methods of doing this study was including a physician, physicist, and a dosimetrist, and 20 problematic plans were created and inserted into the chart rounds. And believe me, these all had a potential to cause a harm when it is going to be neglected, ignored, and going to be treated with the patients. So inserted PPs were inserted randomly into and the chart rounds were extended for 1 hour, and the study extended for 9 weeks. And the problematic plans were not is done in such a way that it had a 95% detection rate. So the methods, and also what are the different varieties that we can put this problematic plans as? Either it can start from imaging, as I've already mentioned it, or it can be because of the contouring or planning quality. That can be only of 2 systems, either from the planning or from the imaging system. So further, if it can be classified, then it comes from different sets. Other than imaging, next step will be obviously target contouring. So it can be a wrong contour, or it can be a wrong side, laterality can be, or the normal structures have not been identified and not been spared, inadequate target coverage, dose and fractionation pattern can be incorrect, and the previous treatment may not be considered. So in this, the plans were reviewed from the Eclipse and Mosaic systems, and the plan and images, obviously, after the study has been reverted to the original state because the problems were created. And see, for example, in this patient, we can again discuss this imaging set was not sufficient. Probably during the simulation, the details were not sufficient enough available for the person doing it, that the cervical spine data was not sufficient enough to cover the target volume. In this case, the patient's prescription of palliative RT was 30 gray in 10 fraction, but when it was entered into the system, it was entered as 20 gray 10 fraction. So these are the methods. So recorded PP detection, role, and location of individual identifying, and the type of problematic plan presentation after the charted round was started was all recorded. And it also recorded the detectability and severity. Detectability, can you see this chart? You can see that in the right fag end of the corner, the wrong dose, very wrong dose and dose distribution, location and volume, according to severity, was very high. And these were the estimated probability of failure, which was going undetected, was more than 20%, which is all catastrophic failures, inevitable. And this failure rate, which was going undetected, was more than 20%, which is very, very significant. So if you see, these are the results. This results obviously says, pointing out there are a lot of errors that was not detected. It may be related to the chart rounds, may be related to the fatigability or the number of cases as we have already identified. But we can see that inadequate target coverage and certain things like dose and fractionation pattern, like for example 30 gray 10 fraction or 20 gray 5 fraction, the incorrect pattern was still presented at 8th minute. It was not at the fag end, it was very, very early in a chart round, but still it went undetected, which is going to be a grossly catastrophic.
Dr. Machangi, sorry for interruption. We are already behind schedule, and your allotted time for the first paper is over. Please conclude and move to the second paper. 7 minutes for one.
I will just do the conclusion, sir. So the detection rate was only 50%, and it was more related to the earlier timing. And as the number of weeks people became more aware that these things can happen. So it was only 55%. So we should always remember that chart rounds is not a foolproof technique, and we should have more techniques to detect the error detection. So future rounds can be shorter disease sites. We can have disease site specific rounds, and written patient summaries has to be clearly defined there, and standardized case presentation. Thank you. So I'll go to the next presentation. Is my screen visible?
No, not yet.
Okay, 2 minutes. Sir.
Can the organizers please share the screen for?
Sure, sir.
Yeah, I'm sharing it now. I got it. I hope you can see my screen.
Okay, now it's visible.
Yes, sir. Thank you. This was a poster presentation which was done in Best of ASTRO, and it is again in the section of patient safety. And patient safety was detected as global awareness. By September 17, ASTRO declared World Patient Safety Day. Patient safety is becoming a priority, and safety is no accident is the motto of ASTRO 2019, which was endorsed and developed by, radiation oncology specific program was created. Quality assurance program was, surveillance program was created by ASTRO with the help of Veteran Health Administration System. They together created this radiation oncology surveillance system, the quality process, because they know from a sick patient to a well patient, we need to go through all these things, not only a safe equipment and the safe treatment staff, safe environment, safe procedures, and safe material to a well patient. How do we really quantify these things? For example, to quantify every department, whether this department is performing well. This was mainly created in US to allot to the main of the insurance systems to quantify and qualitatively estimate the quality of particular departments in various sectors. Now this has also been introduced into the radiation oncology department. So the program was called VHA NROP and created the radiation oncology quality surveillance program. And this study was try to check whether such quality measures can be really brought into site specific tumors, and also in different in our department specifically, other than the treatment planning errors detections. So to evaluate the feasibility of defining, can we really define it and score it a detailed set of quality metrics for common tumors, and to provide a comprehensive assessment through continuous passive electronic scoring of patient treatments. So defining quality metrics, what is quality metrics? It is just a tool to measure the quality and quantity of all the healthcare process and outcomes and patient perceptions. So the material and methods, a good number of patients were selected, 1,500 patients, but the two commonest cancer which was selected in ASTRO was IR and HR, high-risk prostate cancer, and the lung cancer, whether it is small cell or non-small cell. The data was collected from EMR and TPS system, and the nationally recognized expert panel defined the quality metrics. And the quality metrics can be further defined as whether it is currently expected, or it can be an aspirational, or can be done for further surveillance. The panel still continued. They identified 34 additional measures also on case scores, aggregate scoring, and the scores related to the other centers. You can compare with other centers depending upon what is your quality and where is your levels. Data was delivered to VHA, and a score of 19 quality metrics for lung tumors and 26 quality metrics. Overall pass rate was determined as 82.4%, but if you watch this, the pass rates for lung cancer overall was only 78%, whereas prostate cancer was 87%. The aspirational QM prostate cancer for quality of life was very low, whether it is only 50%, less than 50%, even at the time of consultation or at a follow-up in more than 17 centers. Survivorship and bone health assessment even were still low, and the treatment options that were discussed with the patients and the frequency of follow-up evaluations were varying widely between the different centers. When the results continued, quality measures, passing scores for lung cancer assessments were very similar across different centers, but they all were less than 60% when smoking cessation, cardiac devices evaluation, motion management, prophylactic cranial RT, and follow frequencies were considered. Of course, the collection of molecular markers and clinical trial participation were also equally low among different centers. Not only about the clinical things, it was also defining the dose volume histogram. Quality metrics were also defined. If you can see in GU, especially the prostate cancer, the mean pass rates were more than 90%, very good. But in lung cancer, if you see, only 3 out of 18 centers were above 90%, and others were only just more than 80%, whereas when the quality of dose volume was less, only 50% for brachial plexus and ipsilateral lung was less than 30% was achieved. So in order to conclude, this may be a very, very small topic, but it is evolving slowly, and it is very, very important to have quality metrics in radiation oncology for a pathway of personal pathway. Every department, when they follow, they will know that percentages, they will know from the peer reviews to know that where they stand, how much they can improve, how the performance can be improved. Thank you, sir. Thanks for giving me the opportunity.
Okay. Thank you very much, Dr. Mathangi.
Yes, sir.
Now it's over to Dr. Senapati for the discussion and for the introduction of the experts. Dr. Senapati, please.
Thank you, Dr. Vivek. Really, it's my pleasure that I also thanks Dr. Neeraj to invite me as one of the coordinator. I understand this is a difficult subject. However, we'll try to make the topic very simple. Because as we know that radiation is a multi-step process. So it is very common that in rad-onc workflow, we are also more prone to commit a lot of mistakes. So I am happy that with me, my panelists are Dr. Madhu Sairam from Coimbatore, Dr. Suresh Kumar from Kottayam, Dr. Anil Kumar Dhul from Rohtak. Besides, I also asked the presenter to stay and also for discussion. So we know that the radiation is a multi-step process. So there is more chance that yes, we can also commit the mistake. The errors are more prone in the field of radiation oncology. So if we'll see here that if we are going to treat the patient and we commit the mistake, definitely we'll commit more mistake, and also there is more chance of the failure. There is more chance of the side effects. But really, how far we are conscious about it? So with this background, let me ask Dr. Madhu Sairam. Dr. Madhu is here?
Yes, sir. I'm there, sir. Yeah. Do you hear me?
Okay. Yeah. Dr. Madhu, so
yes,
what is your comment that in radiotherapy, do we commit any mistake during our treatment with radiation? If so, what is the incidence of reporting?
Yes, sir. I think we definitely do commit several mistakes during radiation. Some of them are very minor errors that can be neglected and does not result in a patient outcome change. Whereas there are certain grievous mistakes also made from both the physician and physicist end and implementing end. If I should give you an example of about 4 grave errors that happened in our department in the last 8 years, I should share. In a patient with esophagus, we started off treating with 180 centigrade into 25 fractions. Instead, patient was started on 0.25 gray into 180 fractions. So after 15 days, one of the chart rounds, we found that this was the error and we changed it. By then, patient had developed a lot of symptoms. Another grievous error was change in laterality. Patient with the right-sided parotid tumor was treated on the left side instead, and was found only on the 22nd treatment of this patient. So it had this patient had to go through the treatment altogether, and there was a great error on the laterality. So
okay, Dr. Madhu, so how far you report this? Do you agree that we are truly reflecting the situations or it is underreporting?
This is for the sake of the forum. This has been reported, sir. I think this was a learning point for the department. So we made our checkpoints. More
Yeah, it is not. It is not with you. It is also with so many departments.
So many departments. Yes,
you see that a lot of centers that are come out with the linear accelerator nowadays.
Correct,
okay.
Sir.
So correct. Definitely this is a learning curve, and also we are gradually learning in these situations.
Yes, sir.
But what actually Dr. Mathai also highlighted that why there is underreporting. Because definitely it is a situation, the unaware of the fact, or there is more workload, there is inadequate documentation. There are a lot of factors that comes for which there is also less or the underreporting of the error that we commit, but we should be very careful.
Can I comment, Dr. Senapati?
Yeah, boss.
Yeah. So actually, you know, it was underreported, and there is less reporting is being done on a within the institution. We are just discussing that is what mostly done. Exactly when we are looking back to the cobalt era, we are making a lot of mistakes in making the tumor off spine at spinal cord tolerance. That is being, that mistake is being. I think that has happened many times. So from that era, you know, we have in a regional cancer center when I was a postgraduate. We have done is that there is a double check. Actually, a second team is checking whether it has been done on the chart rounds. That era we have come up a long way now, and we have the system right now. Yeah.
So definitely this is a learning curve, and also we have to develop ourselves.
Even I want to add something, if you allow.
Yeah, boss.
Okay. One thing that one of my fellow colleagues he just told that this is a good learning, particularly if there is a sort of error happened in their setup. But I don't think that this is a learning thing. I think this is a matter of administrative action, or may even some other complications may go to litigations also. So
fine. Yeah. Dr. Anil, I also agree with you. But see that gradually we are learning, and also we have to be very cautious. And it is for the betterment of us as well as for the betterment of the patient. It's not the scenario here. This is also in developed countries the same scenario, but they have a good audits pattern. Okay, now can you highlight at that we commit the error?
Yeah, basically, as you mentioned that it can be on two levels, that at the level of planning and at the level of execution. At the level of planning, the CT data, suppose we are acquiring, there can be some incorrect acquiring of the data, or the localization of ISO center that is not correct, or we have the target delineation that is not we have not done in a proper way, and the sparing of normal structure is not done in a proper way. There is a previous history of treatment which is not documented, like my fellow colleague just told, that there is some previous history of treatment, and like in head and neck cancer, it's already there, the patient was treated, and during the further radiation they have missed the spinal cord sparing, so that may lead to some severe
Okay. Besides that, also we come across with some machine factors and also the motion managements. So a lot of issue also comes to the picture. So with the background, let us go to our first topic, that is the first presentation. The question: do you feel that APC with 6 sigma is beneficial in reducing the error during external beam radiotherapy? Dr. Madhu?
Well, this looks like, you know, in a few days, automated plan check and this 6 sigma concept may become a business model actually. So if we have this as a checklist, I think there will still be scope for manual errors. I think a machine generated a checklist could be a good way. That is what this paper actually mentions, sir. But I'm not sure if all departments can procure this and go ahead based on this particular software, sir.
Okay. So now let us go to the second paper. This second paper, because what is the aim of this study? Why this study has been presented, and it has been highlighted that this is on the OAR. And particularly, you will see that the 23% of controls submitted to a multi-center peer-reviewed long-steroid radiation therapy study needed major revision. That's the Western paper.
Yes, sir. I think considering that SBRT, where the slices are very thin slices generally, and there are too many structures to be contoured in each this thing, the scope of errors is quite high. So I think
in this they have used the technique auto segmentation, and particularly for the auto segmentation they have used the convolutional neural network. I understand this is a topic because most of our radiation oncologists are not well versed what the term convolutional neural network means. So it is just a simple thing I can show here. It is a type of artificial neural network, and it is used for processing of images and understanding the images. Because you can see here, this is a MRI image, and also it is the input of the MRI image, and that go for convolutional neural network, and the output, whatever we get, it is the output. It predicts whether it is a normal or it is a disease process, or if it is a disease malignancy, what stage of the disease, and exactly what is the site of the localization. So this is a computer model and very ideal model, and it takes an image as input and gives us the content of an image and characteristic of the image, which the clinician can highlight or understand that what this image is. So based on this, the quality assurance of continuing in this topic, what is the outcome? What Dr. Anil, can you highlight on this for the paper 2?
Yeah, in this, as we can see that the balance accuracy for all the OARs was greater than 0.95, and it's indicating that more than 95% of the contours were recognized correctly, and no future manual rechecking was required. So that is the main thing, is just to highlight this particular fact by this particular study, and because the rest of the things we are not using in our department, so I think I will not be the right person to answer this.
Okay, and Dr. Mathangi, can you comment on this? Because we are using this for the OAR, particularly segmentation OAR.
Especially when SBRT is considered, the uniformity is very, very important, and the contouring, because when we prescribe in CCs and percentage, it becomes very, very important, because our dose specifications has to be very accurate, not just for comparisons with other department, it is for our own, because once the guidelines are set for specific volume. It is not like, because I have seen in many centers that they just randomly draw the entire abdominal bowel lobe. It is not that way. And when prostate is being contoured, you have to exactly contour only 2 centimeter above and 2 centimeter below. But most of the site, if they are not clear about their normal contouring structures, they would contour the entire rectum. Then the specifications or the constraints will not suit you. So I really appreciate if such contouring systems are for normal tissues also are equally required. Probably we may adjust for the expansions and filling.
Fine. So can we apply this for this also abdominal organ, particularly bowel bag and bowel lobes?
That is a little difficult question, sir. It may not suit every patient. That may need corrections, but at least you will know that this is the way, this is the levels you have to stop. You cannot just keep contouring more and more. That may little guide the institutes, and it may become uniform across different departments.
Yeah, Dr. Suresh, this is for the abstract number 3. It is the start of radiation after simulation. When to start the radiotherapy. So what is your practice in your institution? On average, after how many days of CT simulation you start the treatment?
So basically, when we are looking at busy centers like a community hospital like ours, it's a medical college hospital. So it's a very difficult question to answer. It will take 2 weeks, sometimes for some patients 2 to 3 weeks to up to 6 weeks. So that's a very tough time for some of those patients. So it's always to have an off-high policy. It's better.
Okay, Dr. Mathangi, how many days that you take in your institution approximately?
Sir, usually when I was studying and it was in a government, Madras Medical College, it definitely took a little longer time because the number and workload is very high. But in private hospitals, I don't think we have the liberty of even extending for more than 1 or 2 days. So I think this may not suit the private hospitals. Even a bit
So what's your comment on the going for the second physics audit? I think all of you agree it's not a big issue.
We do
and
it
also,
as a pattern, sir. We do it as a pattern in our hospital. If there is no second physicist audit, we don't take the patient for treatment. This has helped, in fact, in a patient, sir. In fact, what happened is we had planned a patient with breast conservation surgery with MTLT and supraclavicular field, but unfortunately, the physicist has not scheduled or approved the supraclavicular plan alone. That really helped in the second physicist audit, because this would have been a catastrophic, and the patient would have not received the treatment. This really helped us.
Okay, this is about the fourth one.
It should be incorporated, sir. It should be there.
Yes, good. So this is about the fourth paper, and already Dr. Mathang has also highlighted how frequently you go for internal audit in your department. All of you, any one of you can also comment. How frequently we can go for the internal audit in our department?
Sir, we usually do once a month only, and I think with the COVID scenario that has also stopped in the last few.
Yeah, let us forget COVID period.
Few months.
Let us think.
Yes, sir.
Okay.
The technologists have an internal chart rounds among themselves, and the technologist rounds happens every week. So we felt that the technologists are able to pick up many small errors made, and all the combined department rounds actually goes on once a month in our department, sir.
Okay, okay. Dr. Suresh, do you like to comment?
Sir. For us, we are doing it on a weekly schedule, and for selected care, it is not for all patients to be exactly, because for those patients on IMRT, we are doing it on weekly schedule with the physicist and the RTT.
Yeah. So with this, I think we can come to one consensus that how can I detect and avoid these errors? So we know that as usual, the conventional procedure, traditional methods, a pre-treatment review by physicians, manual verification, and also chart round. Chart round is a Western concept. But in Indian scenario, we can also say that, yes, it is also a departmental audit. Taking one of the radiation oncologist, one of the physicists, and also one of the dosimetrician, and also we can go for review. And there are some computer models that have been also come out, like the ROILS, particularly this Western, the ASTRO has already devised this, automated plan check and Sigma 6, and also convolutional neuronal network. Besides that, any of our panelists can add anything to this?
Basically, what I am thinking about is that, can we have a quality assurance from between centers, basically collaborating centers, so that can improve upon the other centers, because in our country, which is very vast, because all centers do not have all facilities. So the upcoming centers needs support. So is it possible to have
Yes. Dr. Vivek, I am going to end this session. So particularly, I understand that if we will be careful for the errors or the mistakes that we commit day by day, so that we can also cure the disease, and also we can also decrease the toxicity, so that we can have a better therapeutic ratio. Thank you, Dr. Vivek. Yes, Dr. Matayan, do you like to comment?
Sorry to end. I just have one thing. We have always been saying that error reporting has to happen. But I'm really not sure, is there a system of error reporting? Because we know that physicist and quality errors, all those things are happening via the ARB things. But for physicians, is there really error reporting system? We really do not know.
Yes, madam, we have a reporting system, but it's a penalizing system, where if we report an error, there could be a penalization for the department.
Yeah, so let us do one thing. Let us come with a consensus, and also can put it in our association that
I think ICRA can take up that, sir. ICRA can.
Yeah, Dr. Suresh is there. Suresh will take the lead. Thank you.
And thank you, Dr. Neeraj Jain, for excellently coordinating this session.
Thank you, Dr. Vivek, and also Dr. Niraj.
We have received a message from the organizers to end the session. So I thank Dr. Senapati for the excellent slides and discussion, all the experts and all the speakers and all the original researchers who presented these papers. And we end this session. Thank you very much. Over to the organizers.
Thanks, sir.
Thank you, Dr. Kaushal, Dr. Senapati, and all other panelists. We move on to next session, which is a sponsored session by EE-ON. And to chair this session, I invite Dr. Meena Sudan, Professor and Head Radiotherapy at Shri Guru Ram Das University of Health Sciences. Over to Dr. Meena Sudan. Yes.
Good afternoon, everybody. So today I am going to introduce Mr. Anubhav Mukherjee. He is a principal investigator at ION Onconutrition, and he shall be speaking on recent advances of nanomedicine in cancer diagnostics. Dr. Anubhav Mukherjee, please.
Thank you, madam. Yeah, I feel privileged to be here. Am I audible, sir? Madam?
Yeah, you're audible.
Okay. So, a big thank to the organizer team, Dr. Neeraj, Dr. Vivek, Dr. Meena, and a big thank to my company, my CEO, ION SBRT Onconutrition, and for giving me this opportunity to speak here about the recent advancement of the nanomedicine in cancer theranostics. I'm going to share the screen. Is it visible?
No, it's not visible. Just stop the screen sharing and open up with the presentation and start sharing.
Stop share. Shall I do it again?
Yes, start share.
Now?
Now you will, yeah, now your PPT is visible. Just put it on the slide and you can start.
Okay. So, yeah. So I'll take you through some basic researches that has been done in last few years. Some of researches will come from my own research, and some of the other persons that I collaborated with, and I have been to in different companies. So different research things will come up here. Basically, there is no need for this introductory slides that everyone is here clinicians. And so basically, Douglas Hanahan and Bob Weinberg, they put it adequately that the acquired capabilities, the functional capabilities of cancer cells that differentiate them from their normal counterparts are like they are self-sufficient in growth signals, they are insensitive to anti-growth signals, they evade apoptosis, they have acquired limitless replicative potentials, a sustained kind of angiogenesis, sprouting of new blood vessels from the existing ones, and of course, they invade into the tissues and metastasize finally. New emerging hallmarks of the cancers are reprogramming energy metabolism, where our company is taking so much of care from hypercatabolism and hyperanabolism to combat cachexia and to put the nutritional therapy in there. And then, of course, they evade the cancer cells, they evade the immune destruction, the immune cells. The entire cancer immunotherapy will come there. Genetic aspects of cancer, activation of oncogenes and deactivation of the tumor suppressor. Then oncogene silencing, it holds therapeutic promise in cancer therapeutics. The challenge that I took is the RNA interference, deliver double-stranded siRNA, double-stranded RNA or siRNA to the cancer cells. It means killing the messenger. We know the central dogma of cancer biology, our molecular biology is DNA to mRNA to protein. If we can kill the messenger RNA, mRNA, there will be the cancerous protein will not be expressed or manifested. So here we take these few steps for siRNA, is the ATP-dependent processing of the double-stranded RNA to small interfering RNA. Then the rearrangement of the siRNA into the RNA-inducing silencing complexes, and then sequence-specific binding of the siRNA to the target miRNA, causing thereby the breakdown of the mRNA. Disease-causing gene can be silenced or destroyed by RNAi. I have chosen CD20 siRNA here because CD20 is a cell cycle regulator for promotion from metaphase to anaphase and is highly expressed in several carcinomas. What happens in the onset of anaphase is there are some glue proteins through which these sister chromatids are being held together. Separase is a protein that breaks down these glue proteins, and securin is basically this CDC20 is getting attacked, making an adduct to the APC, anaphase promoting complex, and redirects APC to polyubiquitinate securin, the separase inhibitor, to make separase free. Once separase is free, separase will cleave this protein, thereby promoting the anaphase. So we have chosen this CDC20, we have chosen the siRNA, custom synthesized siRNA, to target this CDC20 protein. The challenges we face is the delivery of the siRNA to the cytosol, the site of action. Because it has to cross the negative discharge plasma membrane, they are highly susceptible to damage by systemic RNAs. They are present, rapid excretion through the kidney filtration, and formation of aggregates due to some untoward interaction. Solutions are to choose a suitable delivery system, to encapsulate the siRNA in a suitable delivery system, of course, and the pegylation. Available arsenals as of now, there is the viral vectors, of course, they are present since long, like adenoviral, antiviral vectors are there. What we are looking forward is the non-viral vectors, leading from the front with cationic liposomes, lipidoids are there, cationic cell-penetrating peptides, covalent conjugations, cationic polymers are there. Liposomes, I have done a lot of research on the liposomes, so I will basically focus on the liposomes among all the nanomaterials. Of course, other nanoparticles, other nanomedicine will come into play, but basically we will focus on liposome today. Liposomes are artificial fat bubbles. They are vesicular structures formed when amphiphilic lipids are dispersed into water, and they form a bilayer structure, as is visible from here, and the aqueous interior is cocooned by this bilayer structure. So it's a biphasic structure. In the aqueous interior, hydrophilic materials can be loaded, and in the bilayer, hydrophobic materials can be loaded. On top of that, once we understand the pegylation phenomena, there are a lot of things that can be added on top of the PEG. If the PEG, polyethylene glycol, is grafted on top of this lipid molecule, there will be a lot of other things that can be grafted on top of that PEG, like targeting ligands. That can be a protein, antibody, a peptide, different carbohydrate molecules, small molecules can be. Surface conjugation can be done. And there are a lot of drugs which are presently approved with a liposomal delivery system, already marketed. There are more than 15, and as of now, almost 16 to 17 drugs are available for different therapies. For cancer therapy, of course, there are a lot of things like Doxil, Donabzum, Mipact, Marquibo, Depoxit, Myosate. And for beyond oncology, there are other things are also there. Other disease models, liposomes are approved there also. The clinically used liposome-based product, as of now, there are 15, and recently, Alnylam, they marketed another product, siRNA delivery. Okay. Current clinical status of the liposome. As you can see from this slide, I have just, there are chosen few. In phase 1, there are a lot of things. In phase 2, phase 3, of course, the eroplatin has been withdrawn from the phase 2 for obvious reasons. We have chosen cationic lipids because viral vectors have their own limitations, and cationic liposomes has their own advantage over viral vectors. Because viral vectors are potentially immunogenic, and cationic liposomes are less immunogenic. Viral vectors are unable to deliver large DNA, and for cationic liposomes, they have no insert size limit. Viral vectors can lead to insertional mutagenesis, and they can be targetable. On the contrary, cationic liposomes can be targetable. Viral vectors are difficult to prepare in large scales, and cationic liposomes, or liposomes in general, are easy to prepare and handle. We have chosen guanidine-hydrated cationic lipids because they are potential gene transfer vectors. We already reported this. Because guanidium head group it remained protonated over a wide range of pH for its remarkably high pKa value. Guanidinium head groups, they form parallel deuterionic hydrogen bonding with the phosphate ions of the nucleotides, so DNA or RNAs. They also form hydrogen bond with the nucleic acid bases. With this cationic liposome, with guanidine-related cationic liposome, C18, C16, C14 chain length, and we encapsulated the siRNA or associated the siRNA with this cationic liposome, making a lipoplex, and delivered it into the cells. We can see the cellular uptake study here in different cells, the B16F10 cell line, raw cell line, CHO A5.9 cell line, and then we switch to B16F10 cell lines to see the effect of the CD70 siRNA on the CD70 protein expression. And you see a remarkable downregulation of the protein. In RT-PCR also, we have seen the same thing. With both Western results and RT-PCR results are corroborating here. And of course, we have done it in flow cytometry. The G2M population has been increased after CD70 siRNA treatment via liposome. In the solid tumor growth inhibition studies, we have seen like a remarkable tumor growth inhibition has been depicted by CD70 siRNA encapsulated liposome. This is the untreated, this is scramble siRNA and CD70 siRNA specific to CD70. Now this result has prompted us to take another thing. We took the metastatic model, we injected B16F10 cell into the C57BL/6G mice tail vein so that it will go to the lung and populate populate there. And we see, and then we treated the mice randomly selected in 5 groups, and we see 3 groups n is equal to 5, and we see a remarkable growth inhibition of melanoma on lung. This result was published. The entire study prompted us to take another in-depth structure activity study for cationic liposomes with C14, C16, C18 chain length with monoguanidine, biguanidine, and triguanidine head groups. And there are the synthetic routes have been presented here. How to synthesize the molecules. Amino acid chemistry has been incorporated here. Now, once those liposomes are made, now we have taken paclitaxel as a drug and CD70 siRNA as the siRNA. Paclitaxel, in principle, will go and fit in the bilayer structure of the liposome, and an siRNA, technically, it should be present in the aqueous interior. Because we have added cationic liposome, they are, in principle, will be attached with the positive charges outside the liposome. And we have done the physiochemical characteristics of this liposome, where both paclitaxel and CD70 siRNA co-encapsulated. And we can see the size, the zeta size is mostly around 100 nanometer. Zeta potential, global surface potential are positive, are coming because it is a cationic liposome. PDI is polydispersity index, which shows the multimodality of the nanoparticle prepared. Here we see, because it is less than 0.2, it is unimodal. It is homogeneous solution of the particles. And you can see the encapsulation efficiency here, which is quite high for many things, for many lipids. Like in lipid 7, we see 90%, 94%, 90%, which is pretty high. Similar studies have been done, like cellular uptake studies, toxicity studies of the 9 lipids that have been synthesized, apoptosis study, and similar gene silencing study, and where mostly you can see when CD70 and paclitaxel were treated simultaneously, co-loaded into the liposome, is showing better result compared to their individual counterpart, and of course the untreated lot. Similar results has been replicated in the in vivo study also, where co-encapsulated paclitaxel and CD70 siRNA, the liposome, monoguanidine, biguanidine, and triguanidine lipids, you can see a remarkable tumor growth inhibition here. where both the drugs, paclitaxel and SABR has been co-loaded compared to the individual counterpart. Analysis was the same thing. This we have communicated to Journal of Controlled Release. Now, with my industrial experience, I can tell like the liposomes can be basically, there are multiple methods of preparing liposome. One best method is film hydration method. Or you make a film, we dissolve the drug or the API, active pharmaceutical ingredient, with the co-lipids. Depending upon the solubility of the drug, which is the hydrophilic drug or hydrophobic drug, the drug will be loaded accordingly. But mostly, if it's a hydrophobic drug, it will be dissolved with the co-lipid in the organic solvent, and it will be taken into the RV flask, and then thin film will be prepared by solvent evaporation. Then eventually, we'll choose the buffer, and there is a lot of buffers that we can choose for the hydration of the lipid film, and then we will extrude it sequentially to form a small unilamellar vesicle from multilamellar vesicles. This is the extrusion instrument. In a lab scale, there are bigger extrusion instruments also present that we can use. And for gel filtration, we can exclude the unencapsulated drug. Then we can lyophilize for long-term storage and stability test. This is a lyophilizer. For characterization of the liposomes, we use UV and HPLC estimation for the percentage of encapsulation efficiency or the drug loading. A beta sizer is used for dynamic light scattering. DLS study has been done for average size, surface potential, and for dispersity index. This study is accompanied by the TEM or SEM image analysis to decipher the structure of the liposome. And of course, we have to mimic the in vivo condition where the drug is released from the liposome. The release kinetics, though it doesn't, we cannot mimic the exact in vivo condition, but still it's a simulation. There's a drug discovery. If we can speak about a little like in the liposome, we know the phase transition temperature of the liposome is increased in the liquid crystalline phase by addition of the cholesterol. The cholesterol very nicely fits into the bilayer structure. So taking that finding into account, what we have studied, we have prepared different taxane derivatives or any other new synthesis has been done. Like we know the paclitaxel, docetaxel, lorotaxel, cabazitaxel. So here we have done cabazitaxel. This is the cabazitaxel moiety, which is linked to the cholesterol with a particular linker designed for the feasibility of it to be incorporated into the liposomal bilayer structure. And different linkers has been chosen just to decipher the role of the linker chemistry here. Similarly, GDC 0623 derivatives has been done, BLZ 945 derivatives has been done, bortezomib derivative, lenalidomide derivatives, all these derivatives keeping in mind that the simple phenomena that cholesterol increases the phase transition temperature of the liposome in its liquid crystalline phase. Physicochemical characteristics of different formulations coming from all the previous study. And here we see the DLS structure, DLS histogram. Which is acceptable in most cases. Here actually we have done in the DSP PEG, we gradually increase the amount of DSP PEG in the formulation. Here we see 5% of DSP PEG is present, and in formulation B we have taken 15% DSP PEG, 30% DSP PEG, and 50% DSP PEG. Gradually we increase the DSP PEG amount into the formulation, and we see a drastic change in the image analysis. What actually happened, the entire liposomal structures got dissolved and polymeric micelle structures came up. A new finding, and this study has been done in Harvard and MIT, and we got a patent for this study. These are HRTM images. There is slight difference in principle in cryo-TM and HRTM. Mostly the finding is same. There is a bilayer structure is slowly getting dispersed, slowly getting dissolved and coming forth. The polymeric micellar structure. As we slowly increase the DSP peg amount into the nanoparticle solution. In the self-assembly simulations also, computational study, we found the same thing. The bilayer structure is getting fragmented with the increment of the DSP peg from 5%, 30%. And once we do the 50%, the entire structure collapses, the bilayer structure, and polymeric micellar structures are coming out. We did the in vitro efficacy study with all these formulations, and also in vivo study. We found a 15% decrease in the body weight with the formulation also, and 1 or 2 mortality cases were also reported. For other like GDC molecules, we have done the similar kind of, we developed similar kind of formulations, and we have done the similar kind of cryo-TEM images, and we found the similar study, similar results. Release kinetics from micelles and release kinetics from liposome. Initially, they showed a little difference because there are some kind of burst release we found from the liposome and a little more sustained release we found from the micelle, polymeric micelle. The current plans that we are having to pursue with ION is to make different kind of nanoparticles for cancer therapeutics as well as to deliver the nutrients. Polymeric nanoparticles will be there, lipid polymer hybrids will be there, albumin nanoparticles will be there, and liposome with different pH gradient will be there. And with the targeting, there will be tissue targeting, there will be cellular targeting, there will be molecular targeting. Liposomes has also been used for diagnostic application. Besides demonstrating their ability to carry a plethora of different large molecules like siRNA, DNA, proteins, and a small molecule like different drugs, they are also explored to deliver a myriad of diagnostic agents. This is copper 64, carbon 14 isotopes, quantum dots, gadolinium, spions, and fluorescent probes are all there. So you see, we are also going to do this. A few studies are planned. We'll be pursuing these studies with them for the diagnostic application of the liposome. Theranostics means therapy plus diagnostics together. Diagnostic application of the nanomedicine. I published few recent articles here where I mentioned all these recent developments of the theranostics, like therapeutics and diagnostics. Like here it's in melanoma, in case of melanoma, in case of angiogenesis inhibitor, or lung, and sometimes we go beyond oncology for the neurodegenerative diseases also. These are applicable. Some bioimaging examples are there where we can see like hyaluronic acid nanogel or photochemo theranostic, because there are lots of nanoparticles here. So different nanoparticles, like gold nanoparticles, solid lipid nanoparticles, of course, like micelles, mesoporous nanoparticles, superparamagnetic nanoparticles, quantum dots, nanotube, dendrimers. A lot of nanoparticles are there to participate in the theranostic application of the nanomedicine. We will touch upon a few. This is a PET study again. You can see the formation of the tumor here. I'll just touch base with the few emerging concepts that are pretty much interesting to us. Like lipid polymer hybrid nanoparticles, as we know, it's a hybrid structure. It's a combination. Of course, it takes the best benefit of the two worlds, the liposomes and the polymer. So the polymeric core is surrounded by the lipid monolayer. And this lipid monolayer can again be conjugated with different things. Like it can be the surface decoration. It can be decorated by different targeting agent like RGD for integrin targeting, folate for folic receptor targeting, transferrin receptors, transferrin ligands. Different antibodies can be put here, and also some diagnostic studies has also been done with lipid polymer hybrid. Now these days there is a paradigm shift of lipid polymer hybrids from two-step methods to one-step method. There is a classical two-step method where you can see the thin film is formed and then the polymeric solution is put into their homogenization, ultrasonation, and vortexing. We see the lipid polymer hybrid structures are forming. There is a one-step method where drug and polymer dissolve in water together, water-miscible organic solvent together, and lipid and lipid pair dissolve in water, homogenized together, it forms the lipid polymer hybrid. A lot of studies have been done for oncology also. Antibody-drug conjugate is another emerging concept. 4 antibody-drug conjugates are already approved by different companies. From the name, it is pretty much visible that there is an antibody, and there is a drug molecule, and there is a linker. We published articles on that, and there are 4, like I say, gemtuzumab, ozogamicin, brentuximab, vedotin, trastuzumab, entostine, inotuzumab, ozogamicin. They are all approved by Pfizer, Seattle, Takeda, Genentech, Roche, Pfizer again, and more than 50 antibody drug conjugates are in clinical trial. Different phases of clinical trial works are being done now. Exosome is another emerging concept which we are pretty much intrigued about. Because initially they were thought of as a scale scrapper basically, but as time passed by, they got their attention in the scientific community. Like the early endosome to the internal luminal vesicles, then multivesicular bodies, and finally the exosome is out. They are instrumental in cell-to-cell talking. Once this exosome is out, they will go and enter into the another cell and deliver their message. The codes they are carrying, like the proteins, the RNAs, and the DNA that they are carrying, will be again endocytosed here and released in the cytosolic environment here. They have their application. The tumor-derived exosomes, they have their application, enormous application in cancer biology now, as it is visible here. What we are intrigued about, having said the enormous potential of exosome in therapeutics as well as diagnostics, we are intrigued about making a fusion between liposome and exosome. It's an exosome-liposome hybrid, where liposomes had some limitations in their structure and leaky behavior. Exosome has got tremendous power, and some limitations are there. Once we can fuse these the membranes of the liposomes and the exosome, there will be a complete hybrid structure found. Very few reports are available, but we are intrigued to take it forward as a potential diagnostic and prognostic area. Lots of clinical trials are available for exosome these days, and very soon we will be coming up with a new platform with that. Another new technology, which is very much interesting, is a thermal sensitive liposome. As you can see, the DPPC, 2 palmitoyl link chains are there, MSPC, it's a myristoyl and steroyl, 114, 1 C18 chains are there. They have their phase transition temperature, melting temperature, 40 and 41. So if the liposomes are made with a 3 component, DPPC, MSPC, and DSP PEG. So there we can see a thermal transition and rapid onset of membrane permeability. The moment the temperature goes to 42 by thermal ablation, microwave hypothermia, radiofrequency ablation, there is a targeted release of the drug into the patient body. There is a video on Celsian Corporation. I believe I can open it. Is it visible, sir? So these are my experiences where I have been and few contributions in different institutes in India and US.
With your presentation, I believe.
Yes, I'm done with my presentation. Thank you.
Thank you, Dr. Mukherjee, for speaking on such a novel topic, and it was quite informative and interesting. So I hope everybody must have had some experience with your education. Yeah.
Thank you. Thank you so much.
Now I would like to thank the organizers, and I will hand over the screen to the organizers.
Thank you, Dr. Meena and Dr. Anubhav. So we wind up this session and we move up to the next session, that is on the cancer biology and radiobiology. And the chairpersons for this sessions are Dr. Manoj Gupta and Dr. O.P. Singh from Bhopal. And coordinator for this session is Dr. Vikas Sikta. Over to Dr. O.P. Sharma, as I think Dr. Manoj Gupta is unable to join.
I have already joined Dr. Neeraj, don't worry.
Okay, thanks, sir.
I'm here very much. Dr. O.P., please start. Dr. O.P., unmute, please. Unmute. Dr. O.P., please unmute. Yeah.
Dr. Gupta, you are getting me? Am I? Hello?
Yes,
Hello?
yes, you are audible, sir, please.
Okay. Thank you, Dr. Neeraj, for giving me opportunity to be here, and Dr. Manoj. I think this topic chosen here is radiation in cancer biology, and we have given the opportunity to chair this session. And the session coordinator is Dr. Vikas Jagtap. He's from Guwahati, I think. He's here, Dr. Vikas Jagtap. He's on the screen.
Yes, I am here. I'm from Shillong.
Okay. So first, I want to give say something about the experts. Dr. Asutosh Gupta is from Jammu. Dr. Nalini Rao, she is from Bengaluru. Dr. S.K. Srivastava is from Mumbai. Dr. Pamela, I think, not able to be here from Ludhiana. But then Dr. Anil Takwani from Delhi. And the first topic, I think, the first abstract which I got it here, is the sensitive detection of microsatellite instability in liquid biopsy from early stage colon cancer patient using nuclease-based enrichment and standard marker on NGS-based approaches. So, should I give to Dr. Abhishek Chakrabarti to start it?
Yes, yes, we can invite Dr. Abhishek.
Yeah, so I invite Dr. Chakrabarti to kindly start your topic because the time is short, you know, already the 10 minutes.
Thank you, sir.
Hello, no sound.
Good afternoon. Am I audible, sir?
Yes, you are audible. Please go ahead.
Thank you, sir. Now, today my topic of abstract, first abstract is sensitive detection of the microsatellite instability in a liquid biopsy from early stage colon cancer patient using nuclease-based enrichment and standard marker of NGS. It is by J.K. Magrigoigos and Harvey Mamon, Lionis Ladas. Now, coming directly to the topic, the genetic instability in short nucleotide repeats due to high mutation rate as a result of abnormal DNA mismatch repair. It's prevalent in colorectal carcinoma, endometrial carcinoma, stomach carcinoma. The microsatellite instability, high and stable classification has a prognostic and predictive significance. Now, this microsatellite instability high is a biomarker of positive response to immunotherapy. Recent NGS-based implementations show a continuous phenotype that all tumors have some level of microsatellite instability. Now coming to technical problems in detecting microsatellite instability, the polymerase chain induced indels its insertion and deletion in genome of the organism produces a false positive results and reduces the accuracy for all microsatellite detection methods. Now this is a graph which shows DNA size along with the relative fluorescent unit. And now coming to polymerase chain reaction suppression of the wild type alleles via name probe, which is nothing but a nuclease assisted mutation enrichment using a probe overlap. Now as we know that this duplex specific nuclease, it has a special affinity for double-stranded DNA over single-stranded DNA and mismatched DNA duplexes. So in this figure we can see the red dots which shows wild type of alleles and the blue shows mutant types of alleles. This acting as a sieve to digest the wild type DNA preferentially. And now pre-polymerase chain reaction suppression of the wild type microsatellite via name probe. Now as we see in the slide, the wild type of alleles where the name probe probes are attached and along with duplex specific nuclease. Now the second step we see there is wobbling of this name probe probes. The delocalization of the mismatches along with the homopolymers enables indel enrichment for small and large microsatellites. Example 10 to 40 base pairs. Now the tumor biopsy which is circulating DNA, 10 to 30 nanogram DNA followed by multiple plex name probe, example NR21, NR24, NR27, BAT24, 5 and 26, these are all nucleotides, followed by multiple polymerase chain reaction, followed by optional multiplex high resolution melting, followed by capillary electrophoresis or next generation sequencing. Now this is a detection of microsatellite instability in a plasma of a patient of colorectal carcinoma. The two graphs given free circulating DNA, one taken from colorectal carcinoma patient and another from normal volunteers. So we see in a patient of the free circulating DNA taken from patients of colorectal carcinoma, where the NAM Pro is used, this MSI is detected, which is shown by spike at 105. The clinical study, 66 early cases colon carcinoma patients, out of which 33 is MSI high risk, along with 33 patient MSI stable in a primary tumor. The plasma circulating DNA is extracted and screened for MSI using a name probe plus capillary electrophoresis. The threshold set to favor sensitivity rather than specificity. It is already assumed that MSI low sample to be positive. Result 97% sensitivity and 76% specificity for concordance of plasma with primary tumor MSI status. Now 22 patient having stage 1 disease, 37 patient having stage 2 disease. Now this slide shows to how to enhance the sensitivity and specificity and to include other cancer. The work is in progress of genome-wide enhancement of MSI detection sensitivity, which is shown by sense and non-sense. Now conclusion. Envisioned application using sensitive MSI detection, the early detection of microsatellite instability in a polyp, screening during colonoscopy, screening of MSI in plasma, liquid biopsy for monitoring early detection of high risk groups, like Lynch patients, CA colon patient having endometrial carcinoma 2, plasma-based prediction of the response to immunotherapy, plasma-based assessment of the minimal residual disease. Thank you. Excuse me.
Okay, thank you, Dr. for nice presentation. And now I think the discussion will be done later on. Hello, Dr. Neeraj. Yeah.
Yes,
Dr. Manoj, I think
yes,
discussion will be done later on.
Yes, so he can go ahead. He can continue with second presentation. Yes, please.
Achha, again he's going for second. Okay. So Dr. Abhishek, you can continue with the second one also.
Thank you, sir. Thank you, sir. Now my second abstract, it goes like this. Detectable human papillomavirus circulating tumor DNA in post-op oropharyngeal squamous cell carcinoma associated with progression. Now, the incidence of human papillomavirus associated with oropharyngeal carcinoma is rising. The post-op risk categorization in HPV error remains a matter of debate. The multiple de-intensification paradigms are emerging, including transoral robotic surgery followed by de-accelerated radiotherapy. Now, recent studies have shown the potentiality use of detection of circulating tumor DNA, diagnosis, prognosis, treatment response, surveillance. Circulating tumor DNA in HPV associated with malignancy have been investigated mainly for the patient receiving definitive RT, but the post-op data are very limited available. Now, the aims of the study is to validate an HPV multiplex circulating tumor DNA assay with the serum samples, determine the rates of detectability of human papillomavirus circulating DNA post-op, to investigate the association of the detectable HPV circulating tumor DNA with risk of recurrence. Now, coming to material and methods, prospectively collected serum sample of 1 ml per patient was analyzed using previously characterized ddPCR multiplex assay. A four stain HPV 16, 18, 31, 33, association of the patient and the tumor characteristic with recurrence were assessed using univariate Cox proportional hazard regression model. The estimate of the disease-free progression and the overall survival were made using Kaplan-Meier method. Now, coming to again the continuation of material and methods. A definitive chemo-RT pre-treatment, 18 patients are taken. Surgery pre-op, 11 patients are taken. 29 of these patient samples are given prior to the treatment. Now, post-op cases is considered to be 25 days post-surgery. Pre-adjuvant radiotherapy, 46 cases. HPV negative, 7 cases. Total number of samples taken is 82. Now, coming to the results of the study. But pre-treatment cohort, the definitive chemo-RT pre-treatment is 89%. 16 of the 18 patients have detectable DNA, circulating tumor DNA. In pre-op cases is 100%. 11 out of 11 patients have detectable circulating tumor DNA. Overall pre-treatment sensitivity is 93%. 27 of the 29 have detectable circulating tumor DNA. Now, coming to this graph, this is nothing but the quantitative study of both of Mayo cohort as compared to UNC cohort, which shows the number of cases in Mayo definitive cohort is less, and the more clustering of red dots in UNC cohort, the number of cases is more. Now, coming to results of post-op cohort, for intermediate risk, number of patients taken is 8, for high risk it's 38. Now, 2 out of 8 patients, 25% of the immediate risk patients have detectable circulating tumor DNA post-op, none recurred. In high risk patient, 47%, 18 of 38 high risk patients have detectable post-op. 11 patients have recurred. The 6 underwent distal mets, 5 local regional mets. Now, coming to post-op cohort historical comparison, immediate risk cohort 25% is detectable. Similar population with adjuvant therapy 3 hours recurrence is 11.8. For high risk cohort, 47% is detected. Similar population with adjuvant therapy is 3 hours recurrence of 52.4%. This curve is the y-axis is as percentage and the x is taken as years. The dotted line we see the high risk cohort which is approximately 52.4%, and the bold line is intermediate cohort, which is in 3 years duration, it is almost 11.8%. A post-op study with recurrent versus non-recurrent cohort, total number of patients is taken 37. 26 high-risk patients did not recur. 12 of the 26 patients, 46% were circulating tumor DNA positive post-op pre-radiation. 11 high-risk patients recurred. 7 out of 11, 64% were circulating tumor DNA post-op. Now, post-op cohort results, the variable associated with the high risk is T4 disease. The high risk 14.3%, but the confidence interval is 95% confidence interval is 3.4 to 559.9, where p-value is less than 0.01, more than 4 lymph nodes. High risk 5.4, confidence interval is 1.7 to 8.6, p-value is 0.01, and circulating tumor DNA or HR is 3.31, confidence interval is 1 to 11, and p-value is 0.05. Now coming to this, again this graph, which shows, which is plotted against progression disease-free survival with duration months, where the blue line, which is bold, is undetectable cases, and this dotted line below it is detectable cases. Here it is seen that the progressive free survival, it goes on decreasing as, and then gradually becomes a constant as the time duration of months increases. Is same with undetectable cases, detectable cases, but the p-value is 0.038. This is the same graph which is plotted against overall survival with time to events, where undetectable and detectable cases are plotted, which is a p-value of 0.02. Now conclusion, 93% of the patients of P16 strain of oropharyngeal carcinoma have detected HPV DNA prior to treatment, validating that HPV DNA multiplex assay in serum samples. The circulating tumor DNA is confirmed to be detectable post-op prior to adjuvant RT. The detectable circulating DNA post-op is significantly associated with overall survival and disease-free survival. Now, future direction, validation with a large sample cohort, kinetics and quantity of the circulating DNA over multiple time points, particularly in post-RT, future aims. Thank you.
Okay, thank you, Dr. Abhishek.
Thank you, sir.
Presentation. Yeah, because of short of time, I think now we should shift for the third abstract, which is presented by Shivani Mehra. So, Dr. Shivani is here. Hello, the third presenter is here.
Hello.
Yeah, Dr. Shivani. Yeah.
Am I audible?
Yeah, audible. Just you start because we are already in 25 minutes late. You start your presentation.
So, very warm greetings to all. I shall be commencing my abstract.
Shivani, share your screen first. We are not able to see your slides. So first share your screen and then speak.
Sir, I have already shared this.
Yeah, now we can see your screen. You can go ahead, please.
So we shall be discussing upon the FOXO1 inhibition as a therapeutic strategy for radiation fibrosis. So here in this slide, we can appreciate that here it is an experiment conducted which had mice which had a radiation of 20 gray provided from both the fields, and one of the limb had an injection of this adipose derived stem cells and the other was devoid of it. So we can appreciate that the one which had the injection of this adipose derived stem cell had a lesser of hind limb stiffness or contracture in contrast to the one which did not receive so. So this is a transcriptome DNA RNA sequence. Here we can appreciate that adipogenesis and its metabolism, that is the metabolism of lipids and lipoproteins, it is playing an important role for radiation fibrosis. And so is the PPAR signaling pathway. So here we can understand by this diagram that the normal cells, when they receive radiation, they encounter radiation fibrosis, which is due to reduction in fatty acid oxidation pathway and enhancement of glycolysis. So if this could be reversed, we can obtain or we can reverse this process of radiation fibrosis. So here we would be talking about the agents which could inhibit or which could reverse this radiation fibrosis by enhancing fatty acid oxidation pathway or by these adipocyte derived stem cells transplantation. So here, as we have discussed, that these are genome-wide methylation profiling of the two separate group, in which the one only received the radiation and the other one which received radiation along with this adipocytes derived stem cells transplantation. So HOMER, that is hypergeometric optimization of motif enrichment, it had an algorithm which identified the promoter genes or the promoter region of the genes that are differentially methylated in adipocytes derived stem cells treated samples in comparison to those who only received radiation. So here we know that these FOXO1 fatty acid oxidation receptor binding sites, if they are hypermethylated or silenced and there is reduction in the expression of this FOXO1, then we get we can reduce this radiation fibrosis. So FOXO1, it is a potential driver of the fibrosis. It is a fork-head box protein and a transcription factor involved in metabolic regulation. This suppresses the PPAR fatty oxidation and thus leads to fibrosis. This is a diagram which shows the normal skin, and this is the one which has received radiation representing hyperkeratotic area or the fibrotic area. So once this FOXO1 is inhibited, then we wouldn't be getting fibrosis, or we would be able to reverse this process of fibrosis. So to develop this, we have the reversal of the fatty acid oxidation if it is promoted, or we could lead to this radiation fibrosis reversal. For this, pharmacological inhibitors for FOXO1 to decrease the expression of fibrotic markers, we have extracellular as well as intracellular markers. The extracellular are the ones which are collagen, PAI1 collagen, and extracellular are the ones which have FOXO1, which we are discussing currently. So now we talk about how prostaglandins, they play an important role in radiation fibrosis. Prostaglandin E2, these are the prostaglandin E2, these inhibit the process of fibrosis. Though this is not confirmed, or we do not have any definite proven evidence that these lead to reduction in radiation fibrosis, but we are in the experimental phase of proving so. So transforming growth factor beta 1 suppresses the component of the prostaglandin E2 pathway. Thus, the reduction in prostaglandin E2 pathway leads to increase in collagen and hence the more production of fibrosis or more fibrogenesis. Inversely, when FOXO1 inhibition promotes the recovery of prostaglandin E2 pathway, it leads to increase in prostaglandin E2, which directly leads to decrease in collagen and hence reduction in fibrosis. So FOXO1 may interact with the prostaglandin E2 pathway to regulate the collagen expression as reduction in the extracellular collagen 1, PA1 and fibronectin. So this was the experiment which we had seen in the first slide, in which its hind limb were irradiated and one of the limb was injected with the adipocyte derived stem cells, and the another one was devoid of it. So here, this is the same graph which we had seen before. This one was the one with more contracture, which was devoid of the transplantation, and this was the one which had the injection. So to summarize the same, The normal cells, which when they undergo radiation, they encounter reduction in fatty acid oxidation and increase or enhancement of glycolysis. So if we are able to reverse this process by FOXO1 inhibition via prostaglandin E2 pathway, then we would be able to reverse or lessen the process of fibrosis. So to conclude, the development of radiation fibrosis associated with metabolic dysregulation, wherein there is reduction in fatty acid oxidation. So FOXO1 could be an important mediator for radiation fibrosis, and the drugs that inhibit metabolic dysregulation for the same can be potentially repurposed to mitigate radiation fibrosis. Thank you.
Shivani, continue with your second presentation.
So is it visible?
Yeah. Can you yeah, it's okay, fine.
It's visible.
Now we would be talking about the second abstract, which is on de novo purine synthesis, which is a targetable vulnerability that confers radiation resistance and inferior survival in IDH wild type diffuse glioma. So as we all know that glioblastoma holds its treatment arms, and radiation holds at one of the important treatment that provides survival benefit in GBM. But 80% of the patients with glioblastoma multiforme have tumor which recur within the high dose radiation field. And so there have been efforts to reduce this recurrence, but these haven't been successful till date. So as we know that GBM, glioblastoma multiforme, it is a heterogeneous disease in itself. So there are heterogeneous genotypes or heterogeneous pathways which lead to this radiation resistance. So we need to devise a common phenotype which would have been led by these different genotypes that could confer less of radiation resistance in these GBM patients. So we have multiple distinct cell lines, almost 23 distinct cell lines. If we are able to identify the common ones or the ones who are contributing the most to these, we would be able to reduce these chances of radiation resistance in these wild type IDH wild type GBM patients. So here we can appreciate that the red zone, which is by the purines and the pyrimidines, these are conferring more of radiation resistance, whereas the others like tryptophan, glycolysis, phospholipids, and bile acids, these are conferring radiation sensitivity. So these purines and pyrimidines, these are responsible for radiation resistance in the patients with IDH wild type GBM. So here the solid line is representing the ones which are without the purine synthesis or pyrimidine synthesis, and the dotted ones are representing these with it. So these are having more survival fractions which were with purines and pyrimidines. So this pathway is representing the de novo synthesis of purine. This IMP, it either gets converted into GTP or ATP. So if we have excess of this IMP, this leads to decrease in the radiation sensitivity, whereas if we have abundance of it, it leads to more of radiation resistance. And this is inhibited, the GTP production by IMP is inhibited by mycophenolic acid or mycophenolate. This is similar, if we have more of GTP and less of this mycophenolic acid, we have more of radiation sensitization. This diagram is representing that after encountering 4 gray of radiation, the cells which were induced with mycophenolic acid had more of radiation sensitivity than radiation resistance. And then there was another study which was conducted if this similar phenomena, that is, as we saw with purines, is it similar to that of pyrimidine as well? So this was similar to the ones which we did for purines, but there wasn't much of success achieved in it. Therefore, we concluded that the pyrimidines, these are not that linked to radiation resistance as we saw in that for purines. The depletion of pyrimidine does not sensitize radiation-resistant genotypes or the cells. Then another study was also conducted, which could hypothesize if GTP synthesis was directly related to it, but this was also of, this does not relate much as that of purines. This was the experiment that was conducted to see if there was any biological efficacy, or if the injection with mycophenolic acid could provide the mice or this variant with that of radiation sensitization. The blue arm represents the sole radiation arm. Then the green arm, the red arm represents the radiation arm solely. The green arm, the light green one, represents the arm which received only mycophenolic acid, and the blue the dark green represent the combination of both. So the combination of both confers more radiation sensitivity as compared to the others. So this IMPDH pathway also did not introduce much of radiation resistance or radiation sensitization, as we saw with pyrimidines. So to summarize, the purine metabolites protect GBM cells from radiation by facilitating DNA repair. So if we are able to inhibit this de novo purine synthesis, this could sensitize the GBM cells to radiation by impairing DNA repair. So increased expression of the rate-limiting enzyme in de novo GTP synthesis associated with inferior overall survival in IDH wild-type genotype, and mycophenolic mofetil, an FDA-approved inhibitor of de novo GTP synthesis, has promising activity when combined with radiation in preclinical GBM models. Thank you.
Thank you, Dr. Shalini. Now the next presenter is Dr. Amit Badola. He is from, yes, he is also from Dehradun. Dr. Amit, you are here?
Yes, sir. Yes, sir.
Okay.
My slides are visible?
Yes, please go ahead.
Yeah.
A very good afternoon to everyone.
Put on power slide. Yeah, now it's better.
Yeah, very good afternoon to everyone. My first abstract is the VISTA blockade immunotherapy in a multimodal approach to a triple negative breast cancer in a mice and an impact on a microbiome. As we know that we are lacking in terms of overall survival in triple negative breast cancer. So this is a new approach. VISTA is a negative checkpoint regulator, just like a PD-1 and PD-L1. It stands for V-domain immunoglobulin containing suppression of the T-cell activation. And it regulates the T-cell activation distinct from the PD-1 and PD-L1. So hypothesis was that the focal radiotherapy can sensitize the poorly immunogenic tumor to VISTA immunotherapy. So So the protocol was that on day 0, they the inclusion of tumor cell was done in a mice, and in day 13 and 14, the radiation was given in 2 fractions. A total 12 gray was given, and on day 17, the anti-PD-1 was given, and on day 20, anti-VISTA was given. And the primary endpoint was tumor growth and the lung metastasis. So what they show is the tumor growth with radiation plus VISTA and anti-PD-1, there was a minimal tumor volume and there's a minimal lung metastasis after the injection of immunotherapy plus radiation. And if you give just immunotherapy, the tumor volumes was higher and the chances of lung metastasis at day 33 was also higher. So the further question they try to answer is, can we the low dose cyclophosphamide prior to radiation can further increase the benefit of anti-tumor response? So for this, on day 9, they introduced cyclophosphamide. The rest protocol was remaining same. So what they found is, when they added cyclophosphamide, the tumor volume and the survival was improved compared to immunotherapy alone or immunotherapy with radiation. Cyclophosphamide along with radiation with both double blockade increased the tumor survival, and there was very less tumor volume. And if you see the lung metastasis and the survival, it was very better in a patient who received combined arm, T plus PD-L1, anti-VISTA and cyclophosphamide. The survival and lung metastasis both were very good with this combined treatment arm. So what they analyze is that the cyclophosphamide also modulate the microbiome of alpha diversity and in beta diversity. So basically cyclophosphamide modulate microbiome, and the results show that with adding the cyclophosphamide, the effect of radiation and immunotherapy was better. So the key point was, the key point was of this study was that VISTA is a recently described negative regulator of a T cell activation, which express exclusively in the hematopoietic compartment. And when we inoculate with 41 tumor cells targeting VISTA or PD-1 alone, or the combination, that failed to initiate anti-tumor response. But when we add radiation plus chemotherapy, it increased the local tumor control as well as the systemic and distant metastasis control. The single low-dose cyclophosphamide prior to radiation further improves this response. And the survival benefit is highest when this the quadruple therapy is used. So addition of the cyclophosphamide significantly impacts on alpha as well as on beta diversity of the microbiome. And additional studies are underway to confirm this study results. Take-home message for this study was the unique and non-reductant features of a VISTA as a negative checkpoint regulator unravel the new opportunity for the this target in the triple negative breast cancer. My second presentation on abstract is on the presence of a giant circulating cancer-associated macrophages like cells after a definitive chemoradiation predict for the progression in a locally advanced non-small cell carcinoma lung. This is the instrument which is used for detection and as well as the quantification of the circulating macrophages, cancer-related macrophages. This cancer-associated macrophages like cells, they are actually the giant myeloid lineage cell which is positive for CD14 and CD11. They are a multinucleated cell which is involved in phagocytosis and it is related with the cancer. If we see in a normal healthy individual, their percentage is 0, but as the stage of non-small cell carcinoma lung increases, the percentage of this CAM cell is increased. As we say for the stage 4 lung cancer, the percentage is highest. So in this abstract, they basically want to correlate this CAM cell percentage and their size with the prognostication of the non-small cell lung cancer. So actually, what is the giant CAM cell and why we are choosing this size of 50 micron? Because this, if you see if we differentiate these macrophages on the basis of size, if the size is more than 50 micron, the progression, the red is showing the progression is less compared to if the size is less. Same, the rightmost, the diagram is showing as the stage the lung cancer increases, the percentage of giant CAM cells is also increases. As we are showing for the stage 3 and stage 4, we are seeing the cell which is more than 100 micron. So if the size is more than 50, it predicts the poor outcome in breast, lung cancer, prostate, pancreatic, renal cell carcinoma, and as well as esophageal cancer. So for this study, they choose these cells, the CAM cell, which is CD45 positive in the circulating of a patient with all stage of cancer, and they take the marker of this 50 micron more than above as a predictor of a poor outcome. For this, it took the serial blood samples from locally advanced non-small cell carcinoma before, during, and at the end of the definitive treatment, and throughout the follow-up, as if the patient is on consolidative therapy as well. So this, the first figure which I show is this technology is used for this detection of this CAM cells. Now there's two type of patient cohort chosen for this study. The one cohort was actually underwent the definitive chemoradiotherapy, and there was 44 patients which were included in that cohort. The 3-year prospective single-blinded study, and the median follow-up of the study was 17 months, and total 72 samples was obtained. And the 78% samples we are able to identify this cell, The second cohort was the patient who underwent CTRT followed by the immunotherapy, and total 67 patients were there. 29 patients was from the single blinded prospective trial, and 38 patients from the two trial evaluating the concurrent chemo-immunoradiation followed by a consolidative chemo and immunotherapy. And the median follow-up was 14 months. Total 830 samples was obtained, and 75% sample we are able to find this count cells. So if we see the results of definitive chemoradiotherapy alone, the patient who's, if we see, in terms of progression-free survival, overall survival, and relapse-free survival, if there is a size of this cancer-associated macrophages is less than 50, they did better in the patient compared to where the size of these cells is more than 50. In all terms, in overall survival, progression-free survival, as well as in relapse-free survival. And we see the changes of this size during the radiation in the calm cells. It was seen in if the end of the RT, the size of cell is less than 50, the one of the 7 patients was progressed. And in at the end of the RT, the size is more than 50 micron. There was total 13 patients, and out of which 10 patients were progressed. And if we see the results for the same definitive chemoradiotherapy and immunotherapy, pre-treatment, during radiation, at the end of radiation, and during follow-up, in all these during a period, the patient who is having the size of calm cell less than 50, they did better in all progression-free survival, in terms of overall survival or distant-free failure-free survival. And the same when the size of at the end of radiation, if the less than 50 micron, 5 of 18 patients was progressed, and at the end of the radiation, if the size is more than 50, 20 out of 29 patients was progressed. So in conclusion, the calm cells are the unique cell type found in a peripheral blood of a cancer patient. If the size of these cells is more than 50 micron, is a predict of a disease recurrence in both the patient who was treated with chemoradiation or chemoradiation plus immunotherapy. The monitoring of these cells during radiation and follow-up could be built in as a predictive biomarker on a trial, augment the treatment strategy in these patients. So this continued prospective validation is ongoing of this study. Thank you.
So thank you, Amit. Thank you. So we had all the 6 abstracts presented by 3 presenters. Now for discussion, I invite coordinator of Dr. Vikas Jagtar and experts. So over to Dr. Vikas for further discussion on all these 6 abstracts. Dr. Vikas, please.
Thank you, sir. Good afternoon to everyone. So this topic was actually radiation and cancer biology. I am audible to everyone, I think so.
Yes, Vikas.
Yes. Okay. So regarding the first abstract, that was sensitive detection of MSI or MMR in liquid biopsies. So I will ask Dr. Ashutosh Gupta sir from Jammu. Okay, sir, what do you think that there will be a difference between the liquid biopsy and the actual biopsy specimen with respect to this MSI instability or MMR detection? You are there, sir? Yes, sir. Sir, you are...
Dr. Ashutosh?
I'm here. Audible now? Yes.
Yes, Dr.
Good afternoon. Actually, so nice meeting all of you. Dr. Manoj, not a long time. All my other friends also. So as far as my knowledge about liquid biopsy is concerned, as a clinician, when we discuss with our colleagues and especially from the lab side, sensitivity and specificity is that we ask for. And my take is that if you do liquid biopsy, the specificity, sensitivity, they are putting something about 70%. Vis-a-vis, having a tissue. So it's not bad actually. So if tissue is not available, I'll put liquid biopsy sensitivity something around 70%. Is that what you wanted to ask me?
Yes, sir. Yes, sir. And that has been done in like most of the lung cancer patients nowadays do get a liquid biopsy when the samples are inadequate. That has been done. And regarding the MSI, so most of this cancer, it is done in early stage colon cancer. So if the MSI is high, then probably they can go away without chemotherapy.
It's a favorable prognosis, yes.
Yeah. So do you routinely do MSI testing for all this colon cancer, because it is not so easily available in each and every part of country?
Yeah, so, availability is there. You have now labs. All the labs are there. We have opened up their outlets at most of the cities, so that's not a problem. But problem is that see again, one thing is affordability. Second is your tuning for that. Actually, are you really tuned for that? So I don't think economics should be a problem, but I think we are not at the moment. Most of us are sensitized about it. So I think in future practice, I think these are becoming more and more common now. So at the moment, as the patients coming are now, so I will insist them to have MSI done. And if you convince them, most of the patients are getting it done. So my new patients, actually, I'm advising them and they are getting it done.
Sir, you are doing it into the screenings also? Like if you have a polyp detected and
not at all.
for detection of Lynch syndrome?
So recently, I had a patient who had multiple polyps in the large intestine. He was a 17-year-old boy, and he was one polyp appearing after another after polypectomies. So basically, then I sent him to surgeon who advised total colectomy and total prophylactic. But as far as this is not our field to fact. You have to send to a genetic expert actually. So this is not my field. We treat only. We only advise those patients who have established disease. And if the tissue is available, we do advise. I do advise MSI testing now.
So mostly these MSI testings are done to advise the chemotherapy in stage 2 cancers, and then mostly to for the patients who can receive immunotherapy or not, like pembrolizumab or nivolumab.
So if you have the testing done only, then you can advise all these things actually.
Definitely, sir.
Already also we are getting it done now with PD-1 testing actually.
Thank you, sir. Regarding our second abstract, that was the detectable HPV ctDNA circulating DNA in the post-operative.
Okay.
Hello.
Now we are getting.
Yeah. Yes, sir. So second abstract was circulating DNA in the head and neck cancer, oropharyngeal cancer patients. So obviously, oropharyngeal cancer with HPV DNA is a good prognostic factor. But are we really going to change the practice depending on the circulating DNA methods at present? My question will be to Dr. Nalini Rao. Madam, can you please elaborate?
Hello. Yeah, I found this paper sort of average. ctDNA, HPV is not the biggest cause in India. First thing, it's more tobacco related. In our hospital, we do it. We do a lot of genomics. I must admit right in the beginning. But it is good to think of doing it in the post-op setting, but I don't think they've clarified as to when we should do it, how often we should do it. What is the timing? Do you do it? And most of these patients anyway go for adjuvant treatment. So they are trying to see whether they do need, if you can find a subset which doesn't need adjuvant treatment. I'm finding that difficult to conceive of. I know, and it's very early tumors which undergo curative surgery and no planned adjuvant treatment. In that small subset, maybe it will help.
So do you think those patients who had done a curative surgery and after that there are still a circulating DNA, HPV DNA detectable, so do you think that there could be a small micro circulating cells, tumor cells are present, and maybe you subject those patients to a higher modality like PET-CT or maybe other imaging to detect if there are any mets? So do you think that do that?
I come from a center and we run a clinic for difficult cases. So we sort of routinely do it this way. And the surprising thing is probably because surgeons are more aggressive these days, we're seeing a lot of the recurrences happen very early, immediately almost after surgery. So maybe there is a role for this because the biology is changing. Somehow, all the tumors are changing in their biology. So I'm sure there will be an evolving role. All the works have come from very good centers, and I'm sure there is a very sound basis for it. So I think, yes, there is a role, but in India, presently, in our setting, among the papers that came in, this wasn't my favorite.
Okay. Anyway,
Dr. Jagtap, may I one thing? I want to know one thing.
Yes, sir.
See, my question is that it is mentioned that they did it pre-RT, pre-chemo and pre-surgery and pre-RT. If it is positive, if the ctDNA is there in pre-operative setting, so then it will be treated like metastatic disease or it will be early stage disease, if it is positive before surgery.
The staging is
will
done.
you change the treatment?
I don't think staging will change by detection of ctDNA.
Staging was done as per the HSCC staging.
What is the practical approach? And what is the practical approach?
It will not.
What will be the practical approach? If it is positive.
So basically what Dr. Nalini just said, that there may be a small group of patients, very early, stage patient where curative surgery was done and there was no indication of post-operative RT. But if you find after surgery there is circulating tumor DNA, probably that may, if we get more strong evidence, may be one of the indication for post-operative RT to reduce the local recurrences. Because in this study, they have seen that not only distant metastasis, but local recurrences also increased if there is a circulating DNA. So that may be the small group of patients.
Yeah.
Am I right, Dr. Nalini?
Hello.
Yeah, Dr. Nalini, please.
Yes. Lovely to see you all. Dr. Manoj, congratulations on your new machine, and I'm happy to see all of you in the times of COVID. It's so lovely. Yeah. Dr. Singh, you are asking me something?
Yeah, just I wanted to know about, even pre-operative setting, when it is positive, ctDNA is positive. So do you think to change your way of treatment? Or the
most of the cases, you need to have the mutation up front. So you do have to do a baseline thing, and only if that mutation is available in the baseline, then it makes sense to follow up these patients. At least that is my current understanding so far.
So it is going to change, I think.
No, I don't think it will change. It becomes a tumor marker kind of a thing, an expensive tumor marker. But if you don't have any other tissue for diagnosis, you can follow up. There's a very expensive way to follow them up, but we can follow up them with liquid biopsies instead of looking for it. And in case you need to, we are de-escalating in HPV, so I don't see the need for escalation of radiation dose. But if you have left disease immediately after surgery, or if you find anything else, maybe there is a reason, but I don't see anything except that small group which I alluded to.
See, if you find circulating DNA in a tumor stage, it will not change the staging at all.
No, it doesn't change.
Absolutely, because it doesn't mean the tumor is spreading out. It is throwing metastasis, isn't it?
Yeah.
So you should be very, very careful in, when you analyze the results in clinical setting. Will you change your treatment? See, your treatment will be guided more by other factors, post-operative, where nodes are positive, PNI, LVI, other things, rather than if surgical margins were clear or not, rather than going by circulating DNA.
TNAN, basically TNAN.
So we'll move out to our next abstract, sir. So our next abstract was the FOXO1 inhibition as a therapeutic strategy for radiation fibrosis. I would like to ask Srivastava sir. Now he has been gone through Cobalt era, then again 3D CRT, IMRT, and now to the advanced technology. Sir, what do you think is the most important factors where we can actually prevent the fibrosis in these patients, and how much the benefit really these inhibitors will have in future? Srivastava sir. Yes. Sir, can you hear us, sir? Srivastava sir.
Is he there?
Yes, sir, he is there, but I think.
Can you hear me?
He's there, but I think he's not. What do you do?
Dr. Shyam, I think you are muted. Can you unmute?
No, he's not muted.
He's roaming around probably.
Anyway, so maybe Dr. Akwani sir can take it again, sir.
Can you please repeat what you were asking?
I was asking.
Very good afternoon to everybody.
Yeah, so we had you gone from the Cobalt era to the new machines with the IMRT, VMAT, everything.
Yeah.
So what is the most important factor that will affect the fibrosis? Is it the technology, or is it the inhibitors are going to have a lot of changes in the fibrosis that we have at presently in our patients?
Yes, basically what I think is that both the things are very important. If we see the technology, we have progressed from the Cobalt era, where most of the tumor and around the structures which are nearby, they got radiation, and which results unnecessary radiation fibrosis. But as we progress from IMRT to IGRT, then we were able to localize the treatment to the tumor only. So it has reduced, of course, reduced the radiation fibrosis. But if we see all these like the inhibition of FOXO1 like thing, then definitely in the coming future, these type of the therapies definitely will help us in reducing further the radiation fibrosis.
Sir, any other products in the market where you think that the fibrosis is less? There are some products which are available in the market. So are there any experience from your side that they are really helpful that we had given to some patient and they had less fibrosis? Because obviously the patient wise, there is a lot of variation in the fibrosis even with the same dose, same plannings.
See, basically, there are a lot of products which are in the market which says themselves to be that they are effective. But in my practical experience, I don't think so there's any effect on the radiation fibrosis. But definitely, our technology, definitely, when we have come from cobalt to IGRT and IMRT, definitely it has proved good in reducing the radiation fibrosis.
So as of today, I think rather than the drugs available, the technology has more benefit in reducing the fibrosis rather than the drug. So we'll wait for the result of FOX1 in the clinical trials where it will see whether we are still good.
We'll wait for that.
Yes, ma'am. Yes, ma'am. Please.
I tend to use a lot of drugs for, at least I use pentoxifillin, which is Trental, 400 milligram twice a day with vitamin E, and I find it very useful. The issue has been tolerance, GI tolerance, particularly diarrhea with some patients. They go off and they come back, but I find it's very useful.
Okay. So,
and we tend to think of all our machines have helped radiation fibrosis as subcutaneous fibrosis, but there's still a lot of tissue damage happening inside organs, which is going to be more and more with hypofractionation. So I think we have to look at radiation fibrosis drugs for it. It's my personal opinion.
Yeah, that's what I tell you. It will take some time for us to observe these things, because till today I don't think so there's any significant role of these medicines.
Can I just add upon that? Actually, when we were young, there was a drug called amifostine. We were all familiar with it. It had a lot of promise. We attended so many conferences. It didn't work at all. You know, so what I mean to say is that additives with radiation, there's no substitute for a good technique. There's no substitute for a good technique. And you can use your own drugs and you can have a better experience, but they are not reproducible, ma'am. If you use a set of drugs and you try to reproduce most of them, you are unable to do that. So at the further time being, I think there are no additives which are radioprotective in some way or the other at the moment, maybe in future.
I think with Dr. Gupta here, I have to make a comment that all these days we taught the 4 R's and refer to the 5th R, intrinsic radiosensitivity. And now all this molecular biology, genomics is opening up that, and we're going to individualize and find out in a particular patient, what is it that causes a fibrosis? We may have universally come to a certain level, but I think we need to move further on this. My personal opinion, I would go further.
I'm not saying we should not move further, but I think at the moment, I think it is an infancy. Whatever the drugs
it is. I agree with that.
That's what I said.
Dr. Gupta, I fully agree with Dr. Jagtap. I fully agree with Dr. Gupta, because sometimes this fibrosis needs some advantage. Say, it is said when we go for 4R or 5R or now 6R.
You are not audible, Dr. Opi. You are not audible.
Sir, your voice.
Sir, Dr. Opi, you are not audible.
I think
he lost his signal.
It's connected. Okay.
You can go ahead, Dr. Vikas.
So our next abstract was, our next de novo purine synthesis in the IDH wild type glioma. Yes, sir. We can see you again. So, any of the expert panel can take it. How much difference do we observe between the IDH wild and IDH mutant type of GBMs? At present, we are treating them in the same way. So, obviously, temozolomide is still the standard of care for so many years. So, do you think that this novel strategy will really change the survival aspect of GBM in the coming years?
Yeah, I would like to comment on this. Basically, IDH mutant. Basically, nowadays we are confused when we come up with a patient with a low-grade gliomas. So low-grade gliomas like grade 2, So one or two. So when to give adjuvant therapies post-operatively. So sometimes it becomes very difficult for us. So then we come up to this IDH. If it is an IDH mutant, then I don't think so. There's any need for any adjuvant therapy. But again, if there's no residual disease, of course. But if it is IDH wild type, then definitely we should go ahead with the adjuvant therapy like radiation and temozolomide, even if it is of grade 1 or grade 2. So most of the time, what happens, like if it is an IDH mutant in grade 4, also in GBM, then it is said that it is a secondary glioblastoma multiform, which has come up from the lower grade gliomas. But if it is most of the time it is an IDH wild type only in a GBM. So this was the next point.
Okay. So what is your take on this new molecule MMF? MMF.
I couldn't get you.
So what is the take on this new molecule which has been done for the purine synthesis downregulation?
You're talking about this IDH, huh?
Yeah, IDH only.
Basically, my takeoff is like if it is a mutant and the tumor like this is the low grade glioma, like grade 2, then we can skip our adjuvant treatments. Okay, but if it is a wild type, then definitely, even if there's no residual disease and grade 2 gliomas also, so we should go ahead with the treatment, further adjuvant treatment like temozolomide and radiotherapy post-operatively.
Any other take on this?
Yeah, what I saw was this mycophenolate mofetil is a immunosuppressant which is already being used for transplant, renal transplant immunosuppression. And if you look at the class of antimetabolites, they were already addressing the purine and pyrimidine metabolism. So I don't know whether they're just revisiting or finding a subgroup of IDH wild type who might benefit by this. But again, it's a bad disease. Every step forward is a step forward. Significant step forward is my take.
Yeah. So coming to the same, which like these drugs which are used in a transplant patient. So our next abstract was depending on that, the VISTA blockade immunotherapy with multi-modal approach. So where they had given cyclophosphamide along with radiation. So cyclophosphamide is also immunomodulator. And definitely that would have been some effect in these settings where the immunotherapy is used and they are probably immunomodulating these effects. That's why you see better tumor response and better patient outcomes in these patients. How the radiation is going to affect the immunotherapy? So any take on that? Maybe you or even Manoj Gupta sir can also take this question.
So basically, now there are a lot of experiments which are being conducted on immunotherapy along with radiation, especially in metastatic setting. So they just want to invoke immune response, with radiation, so that these immunotherapy will not only work locally but also at distant sites. And it has been seen in many cohort of patients that when you give especially the moderate dose of radiation along with immunotherapy, they are not only able to reduce the disease at local site but also at distant sites. So again, this is present abstract is another step in this direction.
Yeah, so along with radiation, they had added an immunomodulator that was cyclophosphamide.
Yes.
Modulate the effects of immunotherapy and the results will be. The last abstract was presence of giant circulating cancer.
Add here, you have to be concerned with the dose of radiation. It has to be high dose per patient. You are talking about.
They had given 12 grade 2 divided doses. That was
two times. Yeah.
Good study to take, isn't it? Immunotherapy versus cyclophosphamide. See the price difference.
So that was Dr. Manoj sir was also saying high dose radiotherapy for the metastatic diseases, along with immunotherapy.
It brings in the abscopal effect which we are talking about with hypofractionation.
Yes, ma'am.
So much difference between immunotherapy versus cyclophosphamide. So it's
but Ashutosh, they have not used the cohort where they are just using cyclophosphamide plus high dose of radiation. They have used the cyclophosphamide along with 2 immunotherapy.
Along with VISTA and other.
We do not know what will be the effect if you give
single
along with radiation, right? So we do not know that.
And it will be more cheaper option if at all it helps.
Yeah, it helps.
The PD1 and the CTLA4 got a Nobel Prize, so VISTA might be in line for a Nobel Prize.
So regarding the last aspect, so circulating cancer-associated macrophage has been studied in other cancers also, like breast cancer. There are many published studies, and they had been already think as a progression or the predictive biomarkers for most of these patients. But are we going to change our modality for adjuvant treatment if suppose that for a lung cancer patient they had given a ctRT, squamous cell cancer, and the patient has residual disease with a more than 50 micron of macrophages still present? So are we going to consider adjuvant therapy straight away, or we are going to still assess them for a period of time and then consider treatment? Anyone can do this. Taklani sir, Chakwani sir, can you please take this? Am I audible? Hello?
Yes, you are.
Yeah. Am I audible now?
Yes, you are.
Yes. So, see, basically, practically, if we see this size of the macrophage, so we don't take it into the account. But if we don't have any other clue, like any other like margins, if we see the margins or there's any radiologically reappearance of the disease, then definitely it can help us. If the patient general condition is good, and if we see the this giant macrophages more than 50 micrometers, then definitely we should add some adjuvant treatment to it in a form of chemotherapy or this immunotherapy or radiation, whatever.
Yeah, because in the study they are also seen that those who had good responder, the macrophages below 50, more than 50 decrease slowly over a period of time. So they had less macrophages.
So that is why if the more macrophages are being seen in the blood, then definitely we should go ahead with the treatment, because we already know that the prognosis is not that good in that case, and more chances of the progression of disease can be there.
It will be an easy method to do because it could be done in most of the laboratories without much issues.
Yes.
Other than going for some advanced technique. That is what
yes.
But again, only I will say that this study only shows the prognostic effect of these macrophages, right?
Yes,
so,
sir.
Unless we have evidence that when we treat these patients with adjuvant treatment, they have better outcome or not. So we need to do this trial first, and only then I think we can.
Or sir, one more thing. What we can do is that we can keep these type of patients on a maintenance therapy or metronomic chemotherapy, what we call it. So it can help in the patient for the disease to come again. So this can be a solution to that.
It could be a new.
Yeah, what I'm trying to tell that before we bring this thing into practice, we should generate some data whether the if we give metronomic or maintenance chemotherapy in these patients, whether it's really going to help or not. So
yes, that's true, sir.
Data before we put into practice.
Yeah, it's true, sir.
Hello, Dr. Jagtap. My question is, does local therapy affect this size of giant cells? Local therapy, dose and surgical intervention and something. Affect the macrophages size? Local therapy, so say it is in breast, suppose in breast, we are giving good radiotherapy. In that case, it is going to affect this.
Macrophages were associated with the tumor.
Giant macrophages?
Yes, sir. So these macrophages were associated with the tumor. So as the tumor size decreased, the size which were more than 50 also decreased slowly over a period of time. So those patients who had a very good response, their more than 50 micron cells also disappeared from there. Yeah, it will be less. But that will be affected.
That study should, that type of study should also be required, I think. Local therapy versus say post-operative RT versus no RT. In that case, we can see later on.
In breast cancer, it has been done.
Yeah.
So maybe the results will be
more effect. It is not published yet. No?
Any other questions? I think we are already over the time.
Yeah. Thank you, everyone.
Thank you, Dr. Neeraj, and thank you, Dr. Manoj, sir.
Thank you, sir.
Thank you, Dr. Vikas Jagtap, for this interaction, and thanks, I think, Neeraj, for giving us this opportunity to interact with our friends in COVID time. Thank you, Neeraj. Over to Neeraj. Neeraj, I think we.
Thank you, Neeraj.
Thank you, Dr. Manoj, and thank you, Dr. Opi. And now quickly move on to the next session, that is on medical physics. And I invite Dr. Kamlesh Pasi to chair this session, and Dr. Lalit Mohan is the coordinator for this session. So over to the chairperson.
Thank you, Dr. Neeraj.
Yes, sir, Dr. Lalit, you can start.
Yeah, madam is joining or not?
Madam has joined, but she is muted.
Okay. So we are at the fang end of the best of ASTRO, and this is the session 12 on radiation and cancer physics. So in this session we have 5 presentations, and they are on various subjects. So we are running short of time, so straightway I request Dr. Amandeep Kaur to start with the first presentation, that is abstract work, the low dose bath paradox. And in the meantime, Madam Basi will take over whenever she joins. So Dr. Amandeep Kaur, please.
Join and ask her to, Madam, please unmute and. Yeah. Yes, Madam. Now.
Is it okay?
Yeah.
Thank you, Dr. Neeraj.
Thank you. Most welcome for thanks for coming and joining. So starts the proceedings, please.
Yeah. Okay. Dr. Lalit has already invited Dr. Amandeep Kaur.
Yes, ma'am.
Yeah.
I'll just
start
with
your
the screen
presentation.
sharing. Okay.
Yeah.
Greetings to the audience and thanks to the organizer for giving me the today I am presenting the topic, the low dose bath paradox, whether the spatial irradiation patterns play a role in the radiation pneumonitis incidence following proton therapy.
Dr. Amandeep, please put on the slideshow.
Little loud.
Yes, sir.
Yeah.
Yeah, you just enable editing. You just press this enable editing button. Yeah, and put it on the slideshow.
Now it's clear, sir?
The slideshow,
Yes.
You make it slideshow. Yeah, fine. Please go ahead.
Yeah.
Yeah. So this lists the outline of the topic is the radiation pneumonitis was studied for patients treated with IMRT, normal X-ray therapy, and proton radiotherapy, and the DVH was compared for patients proton therapy. So voxel-based dose analysis was also done in this study. In this, we all know that radiation pneumonitis is a common side effect of the thoracic irradiation. So the goal of this trial was to learn if the two techniques that are compared, whether proton therapy reduces the risk of developing this side effect in lung cancer patients. So among the 178 patients with locally advanced non-small cell lung cancer enrolled at the MD Anderson Cancer Center, 114 of the patients were treated with image-guided IMRT and 64 of them were treated with proton therapy. A total dose of 66 to 74 gray was given in 33 or 37 conventional daily fractions with concurrent chemotherapy. But no significant differences in the distribution of clinical factors between IMRT and proton therapy patients was observed. Radiation pneumonitis was graded according to CTCAE of external clinicians. This shows that the normal lung volume receiving 5 gray of dose was significantly lower in proton therapy, passively scattered proton therapy, than in IMRT. And no different incidence grade or symptomatic radiation pneumonitis was observed. Voxel-based approach was also followed to study whether there is any dependence of the spatial location of dose delivery in proton therapy and IMRT. And this was the basic approach that was to be studied in this trial. The voxel-wise average of planning CTs is much sharper after spatial normalization of the plans. The voxel-wise frequency of the GTV as well as the local variance of the dose distributions are uniformly distributed throughout the craniocaudal axis. This slide shows the spatial dose patterns of radiation pneumonitis. And this is the voxel-based comparison of the RT modalities. The anatomical regions significantly spared by passively scattered proton therapy, and the radiosensitive regions are basically complementary, as we can see. So to conclude, the different and photons provide a unique chance to exploit the power of the voxel-based analysis of dose distributions. The lower lungs and the heart are confirmed to be strongly correlated with radiation pneumonitis development as compared to the upper part of the lungs. Sparing normal tissues could not be enough. We need to spare the right regions. Means we need to see the spatial location of the dose delivery. Voxel-based analysis seems to be a promising tool to probe organ radiosensitivity in a clinical context. To better exploit advantages from new treatment modalities like proton therapy, more sophisticated radiobiological models are required to overcome the limits of a dose volume-based approach. Thank you.
Thank you, Dr. Amandeep. Madam Basi is there.
Presenter, Ms. Kanchan Sachdeva. She'll be speaking on habitat evolution imaging features to assess early response and predict prognosis in oropharyngeal cancers. Yes, Ms. Kanchan.
Hello, good afternoon, ma'am. My presentation topic is other one. It's not that.
Which one?
Ma'am, my topic is regarding that imaging-driven biophysical model for the differentiation.
Okay, it's the fourth abstract.
Madam, I think second is Mr. Balbir.
Yeah.
Okay,
yes,
okay. There must be some change then. I don't know.
Second.
Yes.
Excuse me,
must be some change.
Sir, Dr. Balbir is rejoining. So can we start with Dr. Kanchan, please?
Okay.
Thank you so much.
Okay, thank you. Just a minute, ma'am. I'm just sharing my slide. So it will take a minute. My slide is visible now?
No, it's not visible.
No,
if you want, we can share it from our end.
Yeah.
Okay. Yeah. We are sharing.
The slide. Okay.
Dr. Kanchan, you can start now.
Okay, thank you so much. Firstly, good afternoon to all, and I really want to thank Dr. Neeraj Jain and the organizing committee that they gave me opportunity to present this abstract. And this was conducted at the Wake Forest and titled Imaging-Driven Biophysical Model for the Differentiation of Tumor Progression from Radiation Necrosis. Next slide, please. Yeah. So as we know that patients with brain mets treated with SRS often develop the areas of contrast enhancement on the follow-up imaging, and we can see there are the two set of images. One is for the radiation necrosis and the other one is for the tumor progression, and it is very much clear that the both are very much similar to each other. So this inability to distinguish between the two often results in miss or delayed diagnosis, which in turn can lead to the disease progression, improper discontinuation of systemic therapy, unnecessary steroid use, unnecessary surgical intervention, or inaccurate prognosis. So till that any accurate non-invasive tool based on the radiographic findings to differentiate these two are lacking. Next slide. Yeah. So since the underlying physiology of the tumor progression is different from the radiation necrosis, and this difference would be manifest in the biophysical behavior of these lesions, and the behavior could be mathematically modeled. So this current work is based on this concept, and they introduces a novel framework that utilizes the medical imaging with in combination with the biophysical model of tumor growth progression to distinguish between the tumor recurrence and the radiation-induced necrosis non-invasively. So they use the follow-up images to derive best fit key model parameters, and these optimized parameters allow to predict about the lesion etiology to enable clinical decision making and therapeutic interventions. Next slide. Yeah. So here they are sharing the three equations. Can you just run those equations on the screen? So this work was mechanically coupled tumor growth model. They just share the three equations for that. So equation 1 describes the rate of tumor cell number change, that is N, at a given time and location as the sum of random cell diffusion, which is the term on the left side, and the logistic growth, which is the term on the right side, where D is the apparent cell diffusion coefficient and K is the spatially dependent growth rate, and theta is the tumor cell carrying capacity, where the equation 2 describes the tumor cell diffusion coefficient as a local modification of the global tumor cell diffusion coefficient by von Mises distress and an empirically derived coupling constant, and whereas the D naught is the local cellular diffusion coefficient of tumor cell in the presence of the mechanical stress. And the third equation represents the mechanical equilibrium with an expansive force due to tumor cell growth. Since the brain isn't in motion, so the sum of the forces have to be equal, where N is the spatiotemporal varying cell member and lambda is the cell growth force coupling coefficient empirically derived. Can you just share next slide? Okay. So this is the model overview. So this model was applied on the 73 patients with the pathologically confirmed radiation necrosis or the tumor progression. Follow-up images from the 2 time points they were taken, that is post SRS immediately prior to diagnosis. So lesions were manually segmented in the both of T1 weighted images. The tumor cell number in both the segmentations were estimated using the Gaussian description. So the first segmentation shape was used as a starting point and the final shape distribution as the desired outcome to derive the model parameters. The tumor cell diffusion coefficient, that is D naught, and K, that is the tumor cell proliferation rate of for each of the patients were estimated using a custom Levenberg-Marquardt parameter optimization algorithm. They used in the MATLAB and subsequently solved these 3 equations. Following model to data fitting of parameters, can you just click enter so that the slide will be shown fully? Yeah, okay. Following model to data fitting of parameters, they were then able to forward model the mechanical solid stress field imparted by expanding lesions. Next slide. Okay. So tumor progression would induce direct mechanical stress, generating edema, and thus more edema would be present in the regions of high mechanical stress. This is in contrast to the radiation necrosis, where edema was caused by the vascular permeability, and thus the location of edema would be more independent of mechanical stress. Therefore, they quantified the overlap of model estimated stressed field with edema segmented from FLAIR imaging at the final time point using the Dye's similarity coefficient, the Dye's index of the segmented edema region, and each mechanical stress was calculated from low stress to high stress, that is from 100 to 500 pascals. So next slide, please. So here we are with the results. So in this model, base parameters were compared to the standard radiographic morphometric analysis parameter using a receiver operating characteristic curve, which is shown on the screen. The model demonstrated excellent accuracy for differentiating and enhancing lesions and significantly outperformed standard radiographic assessment. Other measures were not that significant. Next slide, please. So the future directions. Then they began to develop the multivariate logistic regression model combining individual parameters. For comparison purpose, they extracted advanced radiomorphic feature data from each patient using the common toolkits. We can see that the multivariate regression model combining parameters outperforms advanced radiometric features. Next slide. Yeah, in conclusions, in the nutshell, successful non-invasive diagnostic techniques to distinguish radiation necrosis from tumor progressions are lacking. The biophysics of a lesion can be parameterized using the standard care of imaging. The novel non-invasive imaging-driven biophysical model can accurately differentiate radiation necrosis from the tumor progression, and the model hold potential to be powerful tool for interpreting follow-up images in this significant patient population. Next slide, please. So here is the references. For the further study, you can just have a look to these references. It's a very good paper, and thank you so much.
Thank you, Ms. Kanchan, for conforming to the time. Thank you very much. I call upon the next presenter. I think it's Dr. Balbir Singh. He'll be presenting two abstracts. First one is the habitat evolution imaging biomarkers to assess early response and predict treatment outcomes in oropharyngeal cancer. And the next abstract, that is the acute toxicity patterns in adaptive high precision radiotherapy for head and neck cancer, a randomized control trial, will also be presented by Dr. Balbir only. Dr. Balbir, please.
Good evening to everyone. Am I audible?
Yeah.
So the topic
Be a
for
bit loud.
Yes, the topic for the presentation is habitat evolution imaging features to assess
Can't hear you.
The topic for the presentation is habitat evolution imaging features to assess early response and predict the prognosis in oropharyngeal cancer. As we know that there is a rapid increase in the prevalence of oropharyngeal cancer due to the human papillomavirus infection, and the current standard for the treatment for this oropharyngeal cancer locally is the concurrent chemoradiation, which results in morbidity and poor quality of life of the patients. The HPV related tumors respond well to the chemoradiation therapy and these patients have a better prognosis. For the de-intensification trials for HPV having a oropharyngeal cancer, RTOZ 1016 trial was there. It did not meet its primary endpoints given by the Gleason scores. And the patients who having the high risk of relapse should not be enrolled in this study. The TNM staging and the smoking history are imperfect for the de-intensification trials. Along with the additional prognostic markers are needed. The purpose of this study is to develop image-based signatures to predict the prognosis of oropharyngeal cancer. This is a totally radiomics-based study. So for this, we need baseline and mid-treatment FDG and PET-CT scan to assess the early responses. A novel spatiotemporal imaging features was used to characterize the evolution of intratumoral subregions, that is our habitats. Along with this, we need primary tumors and involve lymph node with the help of novel spatiotemporal imaging techniques. This is a table here. In this table, patient characteristics are there, and there are two types. In this study, oropharyngeal patient consecutively treated with RT 2009 to 2017, and we have taken pre and mid patient PET-CT along PET-CT scans. So 174 patient was there. We have excluded the patient who have gone through the previous surgery, having the low PET-CT imaging quality and the pathological features T0, and no concurrent chemo was given. So in this study, only 162 patient was remaining for the radiomix. So how this is the overview in this slide, starting from the pre-treatment and finding the imaging signature. So in this study, two cohorts was used. One is for training cohort, one is for validation cohort. 162 patients was there. Out of them, 81 patients, we have finding the training values, and we have reproduced the same values. Here in this figure, we finding the same value of habitats, and between the training and validation, those intensity maps are using further for finding the contouring and the registration variable. We'll discuss it later. In this figure, this is a schematic illustration of proposed habitat discovery framework. This method consists of two-stage clustering process. So first is individual level clustering based on city number at SUVs plus their local entropy maps, and followed by the population level clustering. So in this population level clustering, distributed stochastic neighboring and embedded analysis was used to find out the tumor superpixels populations along with the nodal superpixel population. Corresponding to this TSNE analysis, we have finding out the three different density. Means we have extracted the different features from the pre-RT and the mid-RT treatment CT scans and PET scans. From that, we have finding our habitat map. So this is a consensus matrix. Here you can see this is a consensus matrix from the different entropy and the intensity map, which is represented as a heat map for the patient. The patients are both in these figures are represented as rows as well as the columns, and the consensus values in this map, this is a very huge topic actually, ranging from 0 to 1. 0 means the patients which are never grouped together, and intensities means, and the 1 means always grouped together. And here, this is a box and whisker plots here. This one is a box and whisker plots which shows the distribution of 4 PET-CT, PET-SUV, CT number and entropy maps. It means the stars. The star which is showing here, it means these are the significant values, and here the p-values for the training and the validation purpose, both the p-value found to be less than 0.0001. 0.0001. In this figure, which is showing the implementation of multi-regional spatial interaction matrix. Here, this one, in this which summarizes the co-occurrence statistics among different habitat regions. One is pre-habitat, in between separating habitat regions for pre-RT techniques and for the mid-RT, and finding the quality. It means this statistics is using the different habitat regions, and it is computed separately for pre-RT and the mid-RT treatment. And finally, this delta multi-regional spatial interaction matrix will give us the change of spatial habitat interactions. Here, this one. And the figure B, which shows the implementation of spatio-temporal habitat evaluation matrix, which summarizes the temporal co-occurrence statistics among spatially co-registered habitat maps, where the voxel level evaluation of habitats from baseline to mid-treatment is characterized. In both cases, we have included the surrounding tissue as a distinct habitat region to account for its relation with the tumor. So this is a model, as already told. I have taken in this study, 81 patients was taken for training, and out of 162 and 81 for validation purposes. So as I had discussed, two different algorithms, MSI and SHE. Based on that, they have made models to finding the progression-free survivals, and in this they can find out the they can extract the different radiomics features for the clinico-pathological factors also involved to find the multivariable analysis. So in this figure, this is a detailed of 4 habitat-related features in the trained and the validation purposes. So the p-values for different are found to be significant here for both the features, for both the MSI and the spatio-temporal habitat evaluation techniques. This is a waterfall of the predicted risk with this one is a predicted risk for the training cohort waterfall graph, and the second one is for the habitat evaluation based imaging signature for the training as well as for the cohort. And the graph showing right hand side, which is this is the area under the curve representing predicting the 2-year progression free survival, where the patients are stratified here for the training base. Patients are stratified according to the risk score of the proposed habitat evaluation based imaging model for both as well as for the training as well as for the validation purposes. And this graph is a Kaplan-Meier curve for the progression-free survival, where patients are stratified by the median risk score according to the proposed habitat evaluation-based imaging signature, which we have extracted earlier in the earlier slides for the training cohort as well as for the validation cohort. And the second one, this Kaplan-Meier graphs including the HPVs of the patient for the training cohort along with the validation. Patient is population is more in this case. And to compare
Yeah, Dr. Balbir, please try to conclude because you have to present the next abstract also.
This is the accuracy of predicting the progression-free survival by the conformity index for habitat-based imaging signature compared here with the top-ranked conventional imaging features from the PET along with the CT images, which are extracted respectively at the pre-treatment and the mid-treatment where there is a change. The comparison was carried out separately in the training along with the validation cohorts, and it was ranked with the conformity index. So the last slide. Here, As already I have told, we have finding the imaging features, means I have finding the radiomics features for the clinical histopathological feature also included, and for that we have also finding the habitat imaging signature. Here univariate we have did earlier, and multivariate features like TNM staging along with the human papilloma virus. So for that the p values of the training cohort and validation cohort are significant here. And to summarize, this developed novel habitat image-based signature which predicted the disease progression and prognosis in the oropharyngeal cancer. And this method are broadly applicable to the other cancers also. The limitation of this study was it is a relatively small study and using the single center patients. The future work should focus on the prospective validation and testing its utility to stratify the human papilloma virus for the de-intensification therapy of the patients. Thank you. The second presentation is
Yes, please. The next one.
Excuse me, please. The next presentation is on the acute toxicity patterns in the adaptive high precision radiotherapy for head and neck cancer, which is a prospective.
But you are still with the old slides. Balbir, you are still with the old slides.
Excuse me, ma'am.
If there is any problem, organizers can share the slides.
Yeah, you can see here.
Yes, sir. Sir, please go ahead.
Yeah, start.
So the second presentation is on acute toxicity patterns in adaptive high precision radiotherapy for head and neck cancer, which is a prospective randomized controlled trial. Next. So the background, as we know, adaptive radiation therapy takes into account the changes in the target volume and organs at risk during the course of vaccinated radiation therapy. This adaptive radiation therapy has a potential to provide improved loco-regional control and reduce the quality of reduce the toxicity and improve the quality of life. Unfortunately, there is no randomized data which is published on till date on the acute adaptive radiation therapy. The objective of this study to study the clinical impact of the adaptive and the non-adaptive plan on the acute toxicity quality of the patterns, to identify the clinical and dosimetrical triggers for adaptive replanning for head and neck cancer patients undergoing precision radiotherapy using the volumetric arc therapy, and the imaging guidance using the cumulative dose which is delivered to the tumor and the OR for the adaptive along with the non-adaptive treatment plans. Next. So in this study, this is a single institute prospective study of phase 2 randomized control trial. In this, certain assumptions was there to calculate the sample size in which alpha error which is to be taken 5% and beta error for sample size is around 20%. For randomization, sample size of 100% was taken with 50% in each group for adaptive and non-adaptive patient treatment. This is a trial how head and neck cancer patient requiring radiotherapy for adaptive, and the flow charts give us the non-adaptive treatment. For the adaptive treatment, for every 2 weeks, they did the plan adaptations, and in the non-adaptive radiotherapy, no new treatment plan was given to the patient for the whole course of radiotherapy. In this, the different variables which were analyzed was gross tumor volume and the OAR, along with the OAR and the volume changes of the parotids, acute toxicity pattern as per the radiation therapy oncology group criteria. So in this arm, adaptive arm, So every in the third week, fifth week, seventh week, patient were assessed, and according to the changes, variation in the volume, they have contoured with the help of MIM ASTRO 6.5 version software and replanning of Monaco version 5 and execution of the adaptive plan. But in case of non-adaptive plan, the patient was continue still treatment on the original plans. So the variable which were analyzed here, we have seen the bilateral parotid of volume change in the third week, fifth and seventh week, and assess the toxicity criteria as per the R2SU group. And the quality of life is to be determined based on the European Organization for Research and Treatment for Cancer, and the quality of life questionnaire was given to assess the patients. Next. Eligibility criteria. All the patients which were planned to undergo curative intent radiotherapy with and without chemotherapy for treatment of primary squamous cell carcinoma, head and neck cancer, the patients were grouped between 25 to 85 years, and the Eastern Cooperative Oncology group commonly used in prognostic tools. It means it helps to determine the treatment of the patients. All the cases were histopathologically proven head and neck carcinoma, and the patients staged as per the American Joint Committee on Cancer Edition 7 from stage 1 to stage 4. Patients who had the daily calorie intake of at least 1500 kilocalorie who were able to provide informed consent were recruited in this study. The patients which were rejected from this study having the history of previous head and neck lesions and having the uncontrolled comorbidity histories of prior invasive malignancy. Next. Next slide, please. Next. Okay. So the pre-treatment planning. So for this medical fitness of the patient was taken for this CBC, LFT, RFT, echocardiography are performed to assess the medical fitness for the patient, and imaging in both the arms underwent pre-treatment imaging in form of CT and MRI, and in mid-treatment also taken. For delineation, planning, delivery, next slide, ICR 83 recommendation was used for target delineation, and Monte Carlo based algorithm was used for planning. Image accelerator was used to give the both types of arm treatment, adaptive along with the non-adaptive. VMAT was used with the image guidance for treatment of patient, and adaptive replanning software which have having the intensity based deformable registration algorithm was used. Next, the results means the demography of the patient. We can see here the different variables like the patients having the male, female, radical treatment adjuvant along with the chemo. In both the arms in this study, the patient which were having the most type in the higher cancer rate was larynx, and in both the studies, larynx was the highest cancer, and having the 4A stage was 46%. So coming to the result, next slide, coming to the result, the first result having the endpoint according to the RTOZ criteria, that is mucositis. Here we can see in the graph, the most significant advantage of adaptive replanning was seen in terms of reduced mucositis reaction in adaptive arm. None of the patient in adaptive arm having the more than grade 3 mucositis, where 26% of the patient developed it and on the 7th week of the treatment. You can see the P values here. Adaptive replanning at the 5th week of treatment provides the optimum reduction in high risk treatment volume. This will reflect in form of improved toxicity. So next, for the second result, which is a dysphagia, difficulty in swallowing, in this we can see, we can compare with the help of adaptive, non-adaptive based on the grade 0, grade 1, grade 2 and grade 3 techniques. In this technique, we have found that in the week 5 and week 7, the adaptive treatment plans, the dysphagia toxicity is reduced in adaptive cases if we compare it with the help of non-adaptive. Occurrence of grade 0, grade 1, grade 2 in case of non-adaptive. It means in non-adaptive cases, higher the toxicity. Next. Based on the imaging, the results here we can see the volumetric changes in the parotid since starting of the treatment to the last day of the treatment. We can see here that there is a slightly variation in the volumetric changes of the parotid. It means if we give to the adaptive radiotherapy, we can reduce the dose to the parotids. Along with there is chances of less occurrence of the toxicity like xerostomia. Same, we can see the GTB regression starting from the simulation to the 6th week. So we can see here there is also variation in the tumors also. So parotid, as already discussed, there is a reduction in size. Next slide, please. Reduction in the size of parotid starts as early as 3rd week and continues throughout the course of treatment. It means adaptive treatment planning provides better sparing of parotid glands. The difference is significant in the 3rd and the 5th week of the treatment. Now, xerostomia, already I have discussed. Number of patients which having grade 2 xerostomia was less in adaptive arms and at the time of time points in our study, and the difference was significant with a p-value which is a 0.006 at the 7th week. Next, the last slide. Based on the quality of life, as we have discussed earlier, quality of life was based on two features. One is for EORTC and second one is for quality of life questionnaire. In these results for the adaptive and non-adaptive for the EORTC quality of life and the quality of life questionnaire, it means the quality of life questionnaire head and neck 35 in the 7th week, which gives the significant results for the adaptive treatment planning in compare with the EORTC trial. To conclude this presentation, adaptive radiotherapy helps us to monitor the volume changes in the GTV as well as the bilateral parotids. It also facilitates change in the tumor OR location in a high risk and low dose regions over the course of radiation treatment. The radiotherapy adaptive technique seems to be more advantageous when it is used for the patients which are undergoing radical radiotherapy, as the prescription dose is more in these patients. Maximum benefit of the adaptive radiotherapy is obtained when replanning is done at 5th week of treatment. This is the first randomized control trial which is reported in the literature comparing the two arms in terms of dosimetric as well as the acute clinical toxicity patterns. Thank you.
Thank you, Dr. Balbir, for a very nice presentation. I call upon the last speaker of this session, effective volume of parotid glands for assessing radiation injury during radiation therapy for head and neck cancers. Hello. Is the last speaker present?
Hello.
Hello.
Am I audible?
Yes, please. Start.
I request Pankti to start the backup presentation.
Yes, ma'am. Ma'am, please go ahead.
So, good afternoon, ma'am. I thank Dr. Neeraj Jain for inviting me to present on this topic, effective volume of parotid glands for assessing radiation injury during the radiation therapy for the head and neck cancer patients. So, next slide. As we all know that xerostomia, or what we can say dry mouth, is one of the most common problem in the falling RT in head and neck cancer patients. It not only impairs the quality of life of the patients but also lead to some long-term oral disorders. So the next slide. The purpose of this study is to propose an effective volume by excluding the fat from the physical volume of the parotid glands and to conclude on the what will be the prediction for the radiation injury of the parotid glands in the head and neck cancers. For that, the study has taken the data, city-based data for the patients, for 21 number of patients, which will be discussed later on.
in this study, not only the volume is an essential factor they have taken city number change factors of the parotid glands after the fractions, after the radiotherapy. During the radiotherapy fractions, they have taken the combination of these two changes, like change of volume in the parotids and what will be the changes in the city number. These two factors are used to predict the rate of xerostomia. Next slide. Enter. So parotid glands are made up of basically two cells, acinar cells and the adipose cells. What they have taken the hypothesis, if the fat is excluded from the physical volume of the parotid glands, the remaining volume, that is effective volume, would be more efficient to predict the mouth dryness. Next slide. This is a city number method. Like, as we know, whenever radiation passing through a material, it will get some absorbed and some part of it will get transferred. So mu is the linear attenuation coefficient and HU is the Hounsfield unit. By this formula, mu minus mu water by mu water into 1000. So they have taken this model to calculate the change in the city number of the acinar cells as well as the adipose cells. Next slide. So when the radiation will pass through acinar cells as well as adipose cells, the two different attenuations will be mu1 and mu2. Next slide. The combination of these two materials will give this formula. Next slide. So the HU and the volume of these contours, what they have taken the diagnostic city quality data daily during city guided RT, and daily they have drawn the contour of the parotid glands, submandibular glands, and the subcutaneous fat. Okay, the Hounsfield units and the volume of these contours were used to calculate the effective volume of the parotid glands with the two assumptions. First one was, next slide please. First one was the HUs and the volume of the HU of the acinar cell. Next slide. Enter. Previous one. The HUs of the acinar cells in the parotid glands can be substituted with that of the submandibular glands, which is less fatty, and the HUs of the adipose cells can be substituted with the fat. Okay, then the correlation, next slide, previous slide, previous one. Then a correlation between the effective volume with the xerostomia were analyzed using the Pearson correlation test, and the significances were inspected using the t-test. Okay, next one. Next. So this is just a summary what they have taken. I have just told you. The same method was also used for another patient cohort in China, 18 patients with nanophages. Here comes the results. So what they have found in the change in the volume of the parotids. On an average, the fat initially accounted for 25.9% with some deviation of the peak of the physical volume of parotid glands, and it has raised to 30.2% after the RT. The change of effective volume was significantly smaller than the physical volume. Next slide. Yes, enter. So you can see here, this is the data which is comparing the absolute volume reduction with the relative volume reduction of the physical volume of the parotid glands, and it is showing some xerostomia stages with grade 0, 1, 2 and 3. 0 and 1 is under mild, and 2 and 3 is under the severe. So the change of effective volume, next slide please. Next slide. So this is the same data, but this is for the effective volume. The change of effective volume was significantly smaller than the physical volume and is more correlated with the xerostomia grade than the change of the PV. So by replacing the physical volume with the effective volume, the correlation coefficient has been increased from 0.56 to 0.72. And next slide, please. Yes, this is the effective volume model. The correlation between the absolute volume, as you have seen in the previous slide, the correlation between the absolute volume change and the relative volume change becomes more linear with the linear correlation coefficient that is from, I think, 0.56 to 0.72. In this graph, here we can see the effective volume lead to clear clustering of the moderate xerostomia cases in a spread region along the linear fit of these cases from 0 to around 70% in the figure, where the relative volume reduction was plotted with respect to the absolute volume reduction. And here the sensitivity came out to be 88% with the specificity of the 100%. Next, please. And these are the same graphs, but this is for the second data for the China patients, but they have taken 18 number of the patients. Next slide, please. Next slide. Next. So what is the possible adjustment? Like, what can we do for to find out the effective volume? Here they have just predicted this method. Next slide, please. So in conclusion, what they have done by excluding the fat, they have given the method to find out the effective volume of the parotid glands, which will improve the correlation between the parotid gland volume reduction with xerostomia grade. This facilitates the predicting the severity of the radiation-induced injury to the parotid glands. Limitations like small group of patients were taken, no ideal substitute was there. So future work can be, this explanatory study shows the possibility of using the quantitative analysis of the CT-based data. The methodology could be improved with a multimodality image technique and serve as a quick and convenient tool for the clinical purpose. Thank you so much.
Thank you very much. I thank all the 5 presenters in the session, and I call upon Professor Lalit Agarwal to take over the charge of the stage and carry out the discussion part. Professor Lalit Agarwal, please.
Thank you, Madam Basi. We have a very nice session and nicely presented all the abstracts. So without wasting time, I would like to discuss the first abstract. It was a good study. The only concern is that they have shown that the sensitivity of the lower lobe of the lung is more. So if Amandeep could answer this, so what is the reason that why this lower lobe is more sensitive in the lung?
So it might be dependent upon the response of the DNA to the damage caused by the radiation, and also on the repair capacity of the genes.
Okay, so it means like, because they have shown that in proton therapy the result was better, not because of the spatial distribution of the dose, but because of the radiosensitivity, and the area treated by the proton was other than the radiosensitive area, whereas in the IMRT the dose was more in the radiosensitive area. So I was just wondering, if we contour this lower lobe in the IMRT, so and give the dose constraint, so we will be able to save that area. So this could be.
Yes, sir. Adding that additional constraint to lower the dose to the lower lobe of the lung will be a good alternative. But I'm not clear about the thing that do we have a tolerance limit additionally for the lower lobe of the lung or not?
Yeah,
Because
exactly.
in total we will be seeing the tolerance limit for the lung in total.
Yeah.
But yeah, to reduce the dose, we can additionally add that constraint.
Okay. Anybody would like to add? And just I want to say that because in this panel discussion, we don't have Dr. Divya and Dr. Shabab. So Dr. Sunil from Varanasi is joining. So welcome, Dr. Sunil Chaudhary. So anybody would like to comment on that from the panel?
Actually, yeah, what I feel in this, like she has discussed about passive scattering proton therapy and IMRT. Do we really reduce the radiation exposure or the incidence of radiation pneumonitis with this? Or do we have a better control on the local failure with this passive scattering proton therapy? I think it's a bit too early to like know about these things. What do you say?
Okay. Any comment on that?
Yes, so we can study further on this part. Yeah, it might be some early to say about this thing.
Yeah, that's right. But only thing which I see, because they have shown that that there is a sensitive portion, because generally we take mean dose or the V20. So here I think if we give the separate constraint in the sensitive area, I think that is the take-home message. So let us go to the next abstract. It was a good study where they have divided the say CT images and PET images into 3 habitats, and they have studied and they could tell the outcome of the prognosis. They can predict the prognosis. So this study basically, to do that study or to practice this thing, we need a PET scan, and more data is required because the number of patients were less. So, and I was wondering because SUV value, they depend upon body mass index also. So anybody would like to comment on that? Yeah, Dr. Sunil, please. Yeah.
See, as a general rule, any suspicious lesion which is there on MRI and which shows increased FDG uptake is usually represents tumor recurrence.
Right.
Right. So, and maybe that 18 FDG is not useful for brain to detect brain mets or recurrence or necrosis, but it can be replaced with 11-carbon-methionine.
But Dr. Sunil, this is regarding oropharyngeal cancer. So in this, they have studied this in oropharyngeal cancer.
Okay, sorry. I was thinking.
Yeah. So let us go to the next abstract. Yeah, this is an interesting one, acute toxicity pattern in ART for head and neck cancer. In this, basically, just I want to know that they have taken, they have done resimulation in 3rd, 5th, and 7th week. So, what are the bases basically? What are the bases of this timeline to do the replanning in 3rd, 5th, and 7th week? Anybody would like to comment on that?
It's very debatable actually. The timing is a controversial issues. Like different that as per the literature, there is no fixed timeline when ART should be done. Some suggest 2 weeks, after 2 weeks, or after 3 weeks. Usually, the tumor shrinkage is after 3 to 5 weeks of radiotherapy. So probably after 3 to 5 weeks, it should be done. But patients who have gross shrinkage of the disease, or there's severe weight loss, or patients with advanced T stage. So these are the patients where ART may be done should be individualized. The timing should be individualized in this
Right.
patient.
I think you're right. And what about the
Actually, special, Dr. Lalit, 1 minute.
yeah,
When
ma'am.
there is a very large node or something like that, the lesion is very bulging out. So that regresses sometimes very fast. So in that case, adoptive radiotherapy will help if we replan it and we retake the CT for that.
Right.
Because even the cast get loose with that.
Yeah, very right. And should we shrink initial PT? There's a big question mark on that, because in this study, this study is silent on that. They talk of the parotid gland. They don't talk of the PTV. However, they have told in the conclusion that it could be effective in tumor also. But just I want to know, should we shrink the PTV or not?
There is no question of shrinking the PTV at all.
Right, exactly.
The initial PTV, the initial pre-treatment volume should receive the complete dose.
Yeah.
Exactly. Yes, yes, very true, very true. So, what are the pros and cons of adaptive radiotherapy?
It's very labor intensive and requires lots of resource. And even like we need to have deformable image registrations and automatic segmentation to have ART in place.
Right, right. Yeah, seems to be promising, but it is a labor intensive and lot of time is required. And then, especially in our country,
Technically very challenging.
Very challenging. Yeah, yeah. Thank you, thank you. So we quickly move on to the abstract number 4. So this is a imaging-driven biophysical model for the differentiation of tumor progression from radiation necrosis. So it's a good study. Actually, now a lot of image feature you are extracting and you are able to predict. But I was just wondering that can we get the same result with the PET scan?
Good afternoon, sir. So PET is the functional imaging. So I thought that with the PET scan, we have to include different parameters. Like in this study, which is basically based on the MRI. So they have just used the stress factors and the specificity and the sensitivity, and they plotted with the ROC characteristic curves.
Exactly.
So with the sir, with the PET scan, we can also do the same, but the parameters may vary.
That's right, because parameters will definitely vary, because once you are doing on the MR imaging, and only thing is that you can't do it with the FDG. You have to have a carbon 11 for this.
Yeah, yes, sir. Yes.
Okay. Any comment on that? Anybody from the panel?
See, occasionally, like most of the time, MRI is difficult. On MRI, it's difficult to really differentiate between a necrosis and a recurrence.
Yes, sir.
So ultimately, you need to do a biopsy, if you can avoid biopsy, so a PET is a good modality using 11 carbon methionine. Right. So if you can fuse MRI and PET together, the probability of finding out differentiating between necrosis and the recurrence would be higher.
Yes.
Right. So I think if this type of study, whatever feature they have extracted, and they compare their result with the PET imaging, I think that will be more fruitful, and then they can have a more robust data.
Yeah, so there is one more study on that PET scan also, that is combined with the MRI, what the Dr. Sunil has suggested.
Okay.
So it is also very good.
Okay, thank you.
Thank you.
So coming to the last abstract, effective volume parotid gland for assessing radiation injury during radiation therapy for head and neck cancer. So I think this is a very interesting thing, because generally we think that if the size of the parotid is shrinking, it is directly proportional to the xerostomia. But here they have shown that if you remove the fat component and then you take the effective volume, that is more correlating with the xerostomia. So what is the opinion of the panelists? Anybody would like to comment on that? Ramita Sharma, I think you have presented this paper. Would you like to comment on that?
I think so. Hello.
Hello. Yes, Zubinda.
So the xerostomia, I think that we can, in the study, like they have taken the daily CT data before just the RT,
Right.
but this method is not so much easy for the every patient, or for the in the centers where they have more lot of workload. So we can't take the daily CT based data, and it will increase the workload for the doctors also for contouring daily the parotid glands and other fat tissues. And yes, this method is if we can we can reduce the dose, like mean dose less than 26 gray, that will be the best way if we can reduce the dose to the parotids. But if there is no option, then there are chances that we know the xerostomia will occur with some grades. As the dose will increase, the rate of xerostomia also will increase. So,
yeah, one thing in this case, like when they draw the PTV, most of the time, a good portion of the PTV goes into the parotid.
Yes.
So if you make a parotid excluding the PTV, that will give you a different dose. But if you take as a whole, the dose will be definitely higher.
Higher. Yes, we are taking the PTV parotid minus PTV for the planning.
That's okay, but the part which is in the PTV, that is getting the higher dose. So xerostomia will be affected by that dose. Though if we exclude it and we see the remaining parotid, then of course the dose will be lesser to that part, but it will not reduce the xerostomia. So it has to be overall dose to the parotid. That should be reduced. Like if we are able to achieve less than 24, that should be good.
Yeah, thank you. Any other comment on this?
Can I add something?
Yeah, Dr. Sunil, please.
I beg to differ to what Dr. Pasi said. Like this study clearly shows that the effective volume is more relevant in terms of the xerostomia than the physical dose.
Right, exactly.
Right. So if
No,
we
that is there, but only if we differentiated the effective volume and the parotid gland volume.
Yeah.
But in our practice, we don't do it.
It's difficult to differentiate on a CT based on the CT. It has to be an algorithm based.
Yeah.
We need to have an auto segmentation or some algorithm where the computer itself will help us in teasing out the effective volume from the glandular volume from the fat.
Yeah, that system has to be there.
Very
software has to be there.
Yeah, because whatever all studies were there where they were extracting the features from the image, and this study where they have calculated the fat effective volume from the CT number. So now in the future TPS, we will have all these parameters, all these feature extraction methods. So now future planning system will be more than the planning system, where we can have these things incorporated in the planning system, where we can calculate the effective volume, because these are the formula based. So these algorithms you can put it into the computer, and so TPS will be able to calculate the effective volume. So I think these are the future of the treatment planning system. So
it's a way forward, actually.
Yeah, way forward, exactly.
Yeah,
exactly. So thank you all the panelists, and I thank Dr. Pasi and panelist, Dr. Amandeep, Dr. Kanchan, Dr. Ramita, Dr. Sunil, and the presenter, Dr. Balbir Singh, and I thank Dr. Neeraj for giving us the opportunity. Thank you very much, and I hand over the mic to the organizer. Thank you very much.
Thank you, sir.
Thank you, Dr. Neeraj, and for giving this nice opportunity to meet everyone and to have a very wonderful discussion with all. And I think this COVID-19 didn't affect your enthusiasm and your dedication toward academics. Thank you, Dr. Neeraj.
Thank you, Dr. Pasi, Dr. Lalit, and all the panelists and presenters. Now I invite Dr. Rajesh Vishesh to give concluding remarks since we are at the end of this conference.
Good evening, everybody. And
Good evening.
First of all, I congratulate to Dr. Neeraj Jain for successfully conducting this webinar on this different occasion. Congratulations, Neeraj Jain, and carry on further also. And now in
Yes, sir. Yes, sir.
graduates, I hope you have gained knowledge and implement your patient and your clinical practice and your improve your knowledge also. Most probably you have gone, because last 2 days I have seen that every topic is covered and discussion and everything was great, good. That is better than the live discussion. If you go in the auditorium, that more better than this time discussion is. Because everyone is limited to their questions and no extra questions. Now, in this country, Faro country members are also participating. I hope they also enjoy learn the more, and hoping all the best. And again, congratulations, Neeraj, and thanks to you to do wonderful job.
No, sir, it was under your guidance only. So,
no, Neeraj, yes. Thank you, all of you.
Thank you, sir.
So I thank you all the participants, the dignitaries who came for the inauguration, Dr. Bashir, Dr. Reddy, Dr. Giri, Dr. Kostav, Dr. Srinivasan, all the chairpersons, all the coordinators, all the experts and all the presenters, and the trade delegates and who supported us, and my idea team, and delegates who participated in a large number. So I thank you all, and this way we conclude this conference. Thank you very much.
Thank you. Okay, meeting again. Nice to see everyone in so many after a long time.
Thank you, sir. Thank you, everybody.